Good morning, everybody. A pleasant Bangalore morning and a warm welcome to all the delegates, faculty, the senior members of Fortis Healthcare and Agilis, IHH group of hospitals. Thank you for your presence. And let's move on to the first lamp lighting ceremony. As the Sanskrit shloka goes, Asatoma Sadgamaya, Tamasoma Jyotirgamaya, Mrityorma Amritangamaya. Let us all lead from darkness to light. And with this Sanskrit shloka, I would like to inaugurate the CME, which is aptly coded as SURGX 2026, 3000 robotic procedures. As we're innovating further in the field of medicine, robotics is the future. AI and innovation have made a mark in every field, and medical sciences is no stranger to it, I would tell. So these 2 days is going to open your mind and reach out to AI robotics in a way which you have not imagined in the past. But maybe the future is in the hands of the skilled surgeons, guiding the robots and also taking the help of the AI and innovation. With these words, let us go into the lighting ceremony with the prayer. Vakratunda Mahakaya, Koti Surya Samaprabha, Nirvignam Kurume Deva, Sarvakareshu Sarvada. May the God of remover of all obstacles make it a successful day and evening for the learning which is going to come in the next 2 days. I would like to call upon the following dignitaries to the stage. Dr. Bishnu Prasad Panigrahi. Please come on stage, sir. He is the Group Head, Medical Strategy and Operations, Fortis Healthcare. Dr. Ritu Garg, ma'am. Welcome, ma'am. She is the Chief Growth and Innovation Officer, Fortis Healthcare. Dr. Anant Rao, VP and Business Head. Okay, sir, thank you. Dr. Murali Chakravarti, Director Anesthesia, BG Fortis. Dr. Priya Sridharan, Director Medical Service, Fortis Bangalore. Welcome, ma'am. And how can we forget Dr. Mohan Keshamurthy? Okay, he'll be present. Okay, sir. Dr. Manjunath Doshetty, he is the Consultant Nephrologist, Chirayu Hospital, Kalburgi. Please welcome, sir, to the stage. Dr. Manjunath, Consultant Nephrologist, BG Hospital. Welcome, sir. Dr. Veerbhadra Gupta, he is the Director Nephrology of Nagarbavi Fortis. Please welcome, sir, to the stage. Mr. Vishwanath, sir. He is the BH South of Agilis Diagnostics. And last but not the least, Dr. Anantrao, sir, and Suneet, ma'am. She is the lead for the Agilis Diagnostics. Can we start the lamp lighting, ma'am? Okay. Shubham Kurutvam Kalyanam Arogyam Dhanasampada Shubham Kurutvam Kalyanam. I'll introduce you. Dr. Anant Rao, he's the VP Business Head of Fortis Healthcare, all Fortis Bangalore. He would like to speak a few words. Welcome, sir. Namaskara. Bani, sir.
Thank you. Welcome to Bengaluru, welcome to India, welcome to Fortis, and welcome to Fortis Bangalore. I know it's an early morning, 8 o'clock in the morning, wonderful Bangalore weather, difficult to wake up and come, but thanks all of you here. Some special guests we have from Malaysia, so we acknowledge your presence. Thank you so much. So these 2 days, like our MC already mentioned, I think is more than just a celebration of 3,000 robotic surgeries. I think what we are celebrating here is being one of the fastest ones to achieve it in the Asian continent. I think that's the bigger part of the celebration. We were the fastest to get to 3,000 robotic surgeries, which is a goal in itself that the steering committee of the robotic program at Fortis Bangalore had. So I think kudos to all the surgeons and all the physicians who contributed to the growth of this. So can we hear it for them, please? Yeah. One of the features of the renal transplant program, because we are talking of a good part of renal transplant here, is what Dr. Mohan would always say: we accept cases that others don't. So we are known for doing high-risk work. We are known for doing complex work, and possibly one of the very few centers in the world who have excellent success with the TREAT protocol, that is robotic assisted both for the donor nephrectomy and the recipient. So we are one of those people who have one of the largest series of the TREAT protocol, well published, very well acknowledged in scientific literature. And the team of Dr. Mohan and team, along with the nephrologists sitting here, Dr. Mallikarjun, Dr. Manjunath, Dr. Sridhar, and all of them who support them, Dr. Ashish Parekh, I can't forget. So I think some of these gentlemen have put together this entire architecture of what we call as the TREAT protocol. And we are we have some of those case reports that possibly will send shivers down the spine. Why would somebody do such kind of work? And we also have pediatric protocols well in place. So Murali sir is here. So sir supports the anesthesia. All of you appreciate that the anesthesia is quite challenging, and sir has been supporting this for for the longest time that I can remember. So I think this confluence of the next 2 days is primarily to reflect what we have gained in our experience over the robotic transplant. And more specifically, the agenda for this hall has been the immunology piece, because we ought to be, with our partners, Agilis, which is also our sister concern, we want to be placing immunology on the top of what we can do in terms of forefronting the science, because immunology otherwise is relegated to very few aspects of medicine. But considering the way we understand immunology and considering the way its role in transplant is emerging, so we want to be at the forefront of what we can do, and that's going to be the deliberations of what Dr. Suneet has put forward to all of you. I think the joy will come when we have the learnings, the documented learnings being shared with all of you, and more importantly, I think the take-home message will be to see if anybody wants to take home protocols, take home experiences, participate in future workshops. So we are the right people to make sure that we have the connect and we have the audience that would be interested, and we have the platform to make sure that the interest is sustained in all of you. So welcome, Mohan sir. So I have taken over the MC, and so I will hand it over back to the MC now for the formal lamp lighting process. So Dr. Mohan heads the the urology and the transplant, and almost I can say from my knowledge the originator of the TREAT protocol for us. So thank you, sir, for being there and spreading this vast knowledge platter out for all of us. And a special welcome to all the international delegates who are here. So I think we should play the player song, please. Yeah.
Sir, good morning. Dr. Mohan Keshavamurthy, the doyen of BG Hospital. He's the chairman urology, chairman robotic, and principal director renal sciences. Welcome, sir. And I would also like to welcome Dr. Manjunath Shetty. He's the HOD nephrology, JSS Medical College. Please come on stage, sir. And Dr. Mallikarjun, he's the consultant nephrology senior person. Please welcome, sir. He's in BG Road, Fortis. Welcome to all the doyens, consultants, and the administrative group of Fortis, Agilis, and IHH group. A warm welcome to all of you. Please, can we start the lighting ceremony?
शुभं कुरु त्वं कल्याणम्
Thank you, everybody. With the lamp lit symbolically, and the knowledge, let it spread like the light and enlighten all of our minds. And let the force be with us. I call upon the first speaker for the day, Dr. Suneet Kaur. She is the Director, Laboratory Services and Technical Head, Agilis Diagnostics. She is going to speak about pre-transplant risk assessment and immunological workup. Ma'am, please. Please give her a round of applause.
Good morning, everyone. It's an honor and a privilege to be a part of such an esteemed gathering of learned minds today in Bangalore. Beautiful weather, as always, and I hope you have a great time staying in Bangalore. So today, the whole idea of the CME on precision immunology in kidney transplantation came from the thought process that, as the medicine is evolving, everybody is talking about, tailor-made approach to everything, whether it is diagnostics, whether it is treatment. So a lot has been discussed about precision oncology. So why not precision in immunology was my thought. And with that came the idea of the CME. Without wasting much time, because I'm myself very eager to listen from the other speakers, I'll just move on to my presentation. It's about the pre-transplant risk assessment and immunological workup. So why renal transplant? We all who are in this field, we know that it's one of the definite treatment for the end-stage renal disease, meaningfully improves the quality of life for many patients. Although it might look expensive in the first look, but again, it's actually a saving if we see in the long run. Patients are saved from the whole gamut of hemodialysis day in and day out. But only thing we have to remember is that our country, especially when we talk about India, we deal with a lot of living-related practices. Most of our donors are live-related. So it's a huge burden on the doctors that we ensure that the transplants go safely. The graft survives for a long time, because the whole idea of transplant is not just to give a temporary relief to any patient. We have to ensure that at least for 8 or 10 years, the graft life should be there. And not only that, the patient should be able to have a good quality of life. They should be able to join back the workforce. And because, especially in developing countries, there's a lot of burden on single individual to make bread for the family. And as a responsible doctors, our approach should be more evidence-based rather than intuition-based. So what is the purpose of this entire gamut of immunological testing? So immunological testing is never to say no to any transplant. It's always to risk stratify and identify if there are any preformed antibodies, give some idea to the nephrologist and the urologist that whether they can go for a paired kidney transplant or they should follow a protocol of desensitization, and flag the unlikely that in case if the doctor feels that there is no possibility of any transplant. So moving on to the core pre-transplant workup. So as per the STAR guidelines, the first thing whenever a patient comes or approaches for a transplant is always to do take a good clinical history of the patient, see whether there is any prior sensitizing history, look for any events like a blood transfusion or pregnancy, or even nowadays a simple viral infection also can become a trigger for immunizing the patient. Second, transplants, definitely. Husband to wife, because again the pregnancy is a sensitizing event, so the lady has been exposed. Child to mother also has to be looked into, and a historical antibody positivity has to be seen. So it says that immune system never forgets an X. Then we move on to next thing which is important is the HLA typing. HLA typing, we can do a low or a intermediate resolution or a high resolution. In India, I think still people prefer to do many a times only an ABDR, but I think we should move on from those old practices, and because it's an extremely tricky area, it's an extremely polymorphic gene. So we should, as a lab, I always recommend that we should go for high resolution typing. We even have started high resolution typing on ONT platform, which is even capable of giving reports on the same day itself. So reducing the waiting time from maybe a week or 10 days to even the same day itself. But if a lab doesn't have the facility, definitely low or intermediate typing at least should be done for all the recipient donor pairs. So this is just to show you that sometimes on low resolution, what looks a 10 by 10 match might turn out to be on a high resolution only a 5 by 10 match. Next thing is to do is always if there is a antibody screening. The screening available nowadays are a mixed antibody screening, which is actually quite an inexpensive test. It does class 1, but it is a qualitative test. So it gives you an idea about whether the patient has class 1, class 2, or a MICI antibody, which is a non-HLA. PRA screening is also available in the form of class 1 and class 2, which can tell how much the donor pool, how much sensitization a patient has against a particular donor pool. Then comes is a cross-match. Cross-match, there was a time when CDC was only considered to be the gold standard, and people thought that only by doing CDC they can just go for a very safe transplant. But now, as we have seen that a lot of limitations of the CDC as well. First of all, it's a little bit of a tedious process, time-consuming, a lot of subjectivity is there. Some may say score 1, some might say a score 2. And also, many papers have been published that it does not catch up the antibodies up to the level of 7,000 MFI. So CDC, although a gold standard till now being followed by many centers as the only test, we need to really think about our protocols and try to move beyond it as well. So if you can see, the CDC came somewhere in the 1969, given by Dr. Paul Terasaki, one of the biggest pioneers in the field of transplant, followed by the flow cross-match, which became popular in the 90s. Again, it's more specific, is more sensitive than a CDC, picks up many more antibodies, more quantifiable. At least we are able to give the patient some cutoff, some ratios, and more objectivity to the test. But again, the limitation comes with the nowadays the rampant use of rituximab. But we always in our lab we use CD19. So and all the times we are using a pronase treatment, which helps to give us remove all those false positivity as well. Then a lysate-based cross-match, which is very popular among the clinicians, although not really recommended by most of the labs, that is the DSA. What is popularly known as the lysate-based cross-match. Again, it's a good method, a bead-based assay, but again, there are a lot of false positives associated with it because of the non-specific binding to the cryptic bead antigens, raising unnecessarily false positivity. Also, it gives a false negativity against HLA-DP and DQ many a times. So this cross-match became popular in the 2000. And now we are in times of virtual cross-match. Virtual cross-match has become almost the go-to for many of the nephrologists we have seen practicing around the world. But only thing is, when we do a virtual cross-match, we need preferably high-resolution HLA typing. And many people, although they might say 6 loci is enough, but actually, if you want to go for a proper virtual cross-match, it's always a good idea to do all the 11 loci and do a recipient antibody titer. So with the help of something which is the most popular star of today's times, which is the single antigen bead. So single antigen bead, class 1 and class 2 in a recipient, along with the high resolution HLA typing, preferably 11 loci, gives you a very good picture of what kind of a specific donor-specific antibody is there in a recipient against a particular donor. And that is what is the virtual cross-match. There is no mixing of cells involved between the recipient and the donor. So you don't actually really depend on the donor lymphocytes as well, which are a big question mark when we are sending samples across distances. We might not be able to get enough lymphocytes as well. So virtual cross-match has removed all the requirements, and many of our machines are standardized even with the buccal swab protocols. So saves a lot of effort of collecting 4,4, 5 vials of blood from the donors, what is happening for flow and CDC. So many donors are not comfortable, so that also need is removed. We can just have a buccal swab. We can do a recipient antibody titer, and on a single antigen bead we can do the assay, and we can tell exactly if there are any donor-specific antibodies present or no. And that can guide a nephrologist a way forward. Many countries actually have started doing a single antigen bead on a 6-monthly basis and keep a data set of all the records. And they do, whenever there is a disease donor available, they do a high resolution typing, and that can itself give the grade on the disease donor list, which patient can be utilized against which donor. So single antigen bead, as I told you, it's the star of the show. Everybody is moving towards it. Many people, they are just asking for single antigen bead, whether it is a cardiac transplants or a renal transplants. And not only for pre-transplant, it's very, very important when we are doing a post-transplant, when we follow up the patients, especially for the sensitized patients, when we do a second or third transplant, it's of great utility. So currently, many of the labs, they use beads which are having for 98. We even have extended panel which covers for 151 antigens in class 1 and 119 in class 2. Nowadays, still some improvements have come for the single antigen bead as well. We can use a C1Q, which can even tell you exactly that whatever antibodies we are labeling on a single antigen bead, are they complement fixing or no? So that itself can be told by a C1Q testing. So that still gives you a more exact idea what are we dealing with actually. Now, many times they say that, patient, everything was negative and still the patient went for a rejection, or he developed some kind of a complication post-transplant. So blame it all on the non-HLA antibodies. So although non-HLA antibodies, not many people are doing the workup. But now, as I was telling you, with the mixed antibody screen, we can actually, it's a very cheap test, and you can immediately qualitatively get an idea whether you have a MICA antibody or no. And if you actually get a MICA antibody, then further you can classify them, whether it is an AECA or a ATIR or a MICA. That can also be done. So definitely non-HLA antibodies still, they can create a lot of issues whenever there is a, if you are getting everything okay, but sometimes flow also picks up positivity, then we really need to go and look up into the non-HLA antibodies. And also HNA3A has been found to be associated with the rejections. So what do we do what is the easy way to classify and do the testing nowadays? So from the history itself, I think most of the nephrologists, they stratify the patients into a low immunological risk and a high immunological risk. So once the patient is classified broadly into a low or a high immunological risk, what can we do? So the best thing is to do is that do a CDC flow and single antigen bead for all the patients. That is what is internationally recommended, that you do for all the cases along with the high resolution HLA typing. And if at all there is any positivity on any of them, then it has to be repeated again after maybe 2 weeks in case of an IgM positivity, or maybe just before the transplant. In case of high immunological risk, if the patient has been given a desensitization protocol already, then again it has to be followed by a repeat CDC and a flow and a SAB for high immunological risk. For low immunological risk, If initially everything is negative, then they just need to do a CDC and flow just the pre-transplant and go ahead with the transplant. But for a high risk, obviously you have to again look into all the CDC, flow and single antigen bead again prior to the transplant. So this is one practical approach I read somewhere to risk stratify the patients. So in case of low risk, if you have a calculated PRA of less than 10%, no DSA on a single antigen bead, CDC and flow are completely negative, there is a minimal sensitization history, you can always put them under a low risk and the standard immunosuppression can be taken care. Moderate risk if the calculated PRA is between 10 and 79%. Low level DSA may be roughly between 300 to 1500 MFI. A flow is a borderline or a CDC negative. Some sensitization like a transfusion or a pregnancy, then I think the nephrologists are the best people to recommend. Enhanced induction plus a closer post-transplant antibody testing timetable has to be established. And high risk if the CPRA is more than maybe 80% and MFI more than 1500 on a single antigen bead, a positive cross-match, strong history, prior transplant, multiple pregnancies. So in those cases, a strong desensitization protocol, consider a paired exchange if that is available, and intense monitoring should be done. Disease donor, again, you can just do an HLA typing. For the recipient, it's a mandate. For the donor, in case the facility is available, it has to be done. Do a patient PRA or at least an antibody screen. And if it is negative, directly do a CDC cross-match, I think, which is followed all over Karnataka. That's the practice. And they can go for a transplant. If at all the antibody screen comes positive in a recipient, then maybe again the gamut of testing has to be done. Sensitize, I will not say in details because Dr. Shruti Tapiawala ma'am is going to cover on that. So global approaches, just a brief on what are the global approaches for risk stratification. So I'll just highlight the BSHI, the UK protocol. That gives a very comprehensive way how we should approach the transplants. As per the BSHI guidelines, it's always a good idea to go for a complete 11 loci, high resolution typing, antibody testing to be done, virtual cross-match on at least 2 samples. And the most recent should be at least 3 months old, not less than that. If a patient did not have a complete typing, means if it is only a 6 loci or a 3 loci, in that case, CDC and flow becomes a mandate. And interim sensitizing event, which can even be a severe viral infection also, needs again a repeat transplant workup. Then just to show you what is the Vienna approach, they do a quarterly SAB testing with the annual CDC. The Sao Paulo approach, one of the largest public sector kidney transplant programs, they actually, only when the MFI is more than 1500, they treat it as clinically relevant, and below that actually is an acceptable reactivity for them. In our center, most of the times we are doing a CDC flow as well as a lysate-based cross-match. If all are negative, we are proceeding for a transplant. It is done twice. We are doing it first and again repeating it prior to the transplant as well. But if at all we find that any of them flags positive, we are doing a single antigen bead class 1 and class 2, depending on which one has flagged positive. And only on the basis of that, a repeat is done again prior to the transplant. And after following the desensitization protocols, we proceed for the transplant. And this is the famous Delhi approach, I think Dr. Anil Handu and the team in Delhi has provided. It's a very friendly approach, what is there. They do a flow cross-match and antibody screening for all the patients who come to them. And if both are negative, they don't do any further testing because of the limitation. You know, we have a lot of poor patients in our country, so they progress to the transplant. If any of them turns out to be positive, they do a single antigen bead, antibody identification. Again, if there is no donor-specific antibody which is targeted against a particular patient, then they again go for transplant. If there is any donor-specific antibody detected, they offer a paired exchange or a disease donor transplant. So what we feel in a country when the resources are less, probably we can do a screening rather than a single antigen bead for everybody. We can opt for a single mixed antibody screening as a protocol along with the CDC and flow for all the patients because of the lack of resources. But if a patient is affordable, the best idea is always to go for a single antigen bead whenever we are planning a transplant. So it's a very tight rope what we are walking. If we lean too cautious, maybe we reject everybody. If we are too bold, maybe we end up with some problems. So the actual answer maybe lies that layer the test one by one and maybe see that whatever is the best approach for the patient, tailor make it for individual cases and move forward. So as I told you, why precision medicine? Because surely one fit is not for everyone. We cannot squeeze everybody into the same hole. We have to see that everything is tailor-made for individual requirements. This is just to show you the cross-match requirements and organ-specific testing, what all should be done for individually. I think liver is an exception, but otherwise all of them virtually have to follow the same protocols. They have found that whenever we talk about donor-specific antibodies, they definitely have an impact on the longevity of the graft and the patient survival. So when they say that if it is a mild, when the DSA is mild, maybe less than 1500, the 8-year survival is 89%. And whenever there is a moderate or a high DSA, that time the survival itself goes down. So DSA, donor-specific antibody, which we are detecting on the single antigen B, definitely has a lot of value. And matching definitely makes a difference. They have found that if we don't properly match our patients, the outcomes will suffer. We will give huge doses of immunosuppression, and that might itself lead to sepsis. So many patients might not die of the graft failure as such. They might die of the infections later on. This is just to give again the same thing, that they say that if the MFI titer beyond 3,000, 5,000, all of them don't actually make much of the difference. So although we believe we are very much worried about the MFI of 3,000, 4,000, 5,000, but overall the impacts they have seen is not really different. And what lies underneath is the greater truth of epitopes, which Dr. Feroz will tell you in great details. So what drives a ABMR-free survival? I think the MFI strength, if it is less than 5,000, less of the DSAs, the flow cross-match status is negative. That really is a guide to have a better outlook for the patient. So there are some takeaways that there is no one size which fits all. Build the workup in tiers. Don't just do everything for everyone. You can, based on the sensitization history, probably you can look into the things. The algorithm differs from patient to patient. Low resolution can be misleading. Please go for a high resolution. DSA strength is prognostic to a certain degree. So we need to always do something to make sure that we know whether we are dealing with a mild, moderate, or a high DSA case. Look past HLA. If a rejection is unexplained, please look into the non-HLA part. And again, even SAB also is subject to some false positivity and false negativity. So that point is relevant for the lab people. So we have to make sure that all our results are correct, our quality controls are correct, we follow the proper protocols, and make sure that every transplant is a safe transplant and gives a good life to the patient. We should focus on longevity of the graft and a good quality of life for the patient. Thank you so much for your time. I think we'll not waste time, and please, if you can call the...
That was a wonderful session, ma'am. Coming from the lab background, I know what it takes to do these tests, the quality controls. These are the preparation before you even touch the patient, because the outcomes are definitely, you can see whatever ma'am has presented in the statistics. Can I please call upon Dr. Ritu Garg and Manjunath Doshetty to give a memento to Dr. Suneet Kaur? Thank you, ma'am. Thank you, sir. Now we move on to the next speaker for the day, Dr. Firoz Aziz. He is a consultant nephrologist, clinical director, transplant immunology services. He is an MD, DM nephrology, Aster MIMS, and ICRA Hospital, Calicut. He will be speaking upon improved transplant outcomes with epitope and eplet-based analysis. Please welcome, sir.
This is a pointer. Slide there. Good morning, respected seniors, friends. I thank the whole Fortis team, especially my sincere gratitude to Dr. Mohan Keshmurthy sir, Sunita ma'am. Madam gave you one of the excellent overviews in transplant immunology. I'll be like deep diving into a focused area which is evolving right now. Basically, fundamentally in transplant immunology, the key concept is that you look to the coming organ, the foreignness, what is not in self. You don't create self anti-HLA antibodies. So this foreignness is basically looking at the difference in the HLA proteins, HLA antigens. So this is the mismatches we look, when I as a recipient looks into the donor, what I try to look is that what is the mismatches I have with this donor. And more mismatches means inferior outcome. I think all who have been into transplant might have seen a graph, this graph or a similar one, okay? I will go back to this graph again. So this is all based on HLA mismatches. The more mismatches means it's inferior. But HLA is not, not that, if you interpret these outcomes from an HLA perspective, it can be a little challenging because the HLAs are increasing day by day, each and every day because of the molecular techniques that we are involved. We are identifying new HLA alleles, and it is like 45,000 counting still. So that is one thing, to get a HLA matched individual can be a difficult one. Second is that I'm going back to the previous graph. So what we see here is that this graph was populated from 200,000 patients. As any of the transplanters sitting here might do a few hundred or 1,000 transplants in his lifetime. Suppose it had been 5,000 transplants, you might see a zero antigen mismatch, the top one doing better, but the rest, 1 antigen to 6 antigen mismatches would be just one line. You will not be able to tease out the differences between these small mismatches between 1 to 5, 1 to 6. So, this is some sort of a, not the real picture that as a clinician is going to see it. So people have started to look into proteins within the HLA or other than HLA to explain, anyway, we know that some kidneys do well. So it was this search that led into what is called as the epitope or eplet, what I use as synonym actually in this presentation. Okay, so this was Professor Dickersnoy from Pittsburgh, who actually, everybody knew that there is something in HLA that triggers the antigenicity and immunogenicity, but it was Professor Dickersnoy who took it to the next orbit and came with, so this is how a HLA this is just HLA-A. If you look at it grossly at it, what you can see is more of these dots and dashes than the alphabets, okay? So pretty much, though there are like 200 people sitting here, we are really polymorphic. To get a HLA identical individual from this group is virtually impossible unless you have come with your HLA identical sibling. So, but among the HLA, there is a lot of homology or similarity between the HLA. So if HLA is a protein, it is like around 250 to 300 amino acids long. Through the HLA, course of HLA molecule, there are like islands or patches or hotspots we call as the eplets or epitopes. That actually gives the immunogenicity to that particular HLA. So a nomenclature came for HLA, and it is just like, so the problem is that the same eplet present in one HLA can be present in other eplets also. This is just as if you have a pattern of certain facial characteristics which group in to form a face, and you can have the same mustache in different type of people. So how the numbers come down to? So you have like, if you look at the first row, HLA, if you look just class 1 HLA, A, B, and C, there are like 27,000 alleles. But it is just mix and match of 250 applets, okay? And if you look at it, if you look at the farther end of the right-hand column, out of these 252 applets, 192 has been seen in multiple HLA antigens. So that's the problem that we have. It is not unique to one particular HLA antigen, okay? So this is actually a plot from the Canadian blood bank data. This is basically what they have done is that they have populated their the population, the multi-ethnic population based on HLA. So what they found is that certain alleles are very common and certain are very, very rare. So to find a HLA matched individual based on HLA can be tricky. But the same population, they again replotted based on their applet pattern. What they found is that a little more even distribution. So this developed a concept that, you might be able to match for a applet rather than match for an HLA. So that was the dream concept, but it has not been like practical yet. So how do you get the applet information? Basically, there are different softwares. The applet registry is that one I usually use. It is free to use. Basically, we feed the softwares with the high resolution HLA type that Sunit Madam told, and what it teases out the applet information for you. So now we have to disconnect. I as an individual I just forget what HLAs I am made up of. I put all my HLA information into this one of these software tools, and it gives you that I as a recipient has so many applets, okay? Now here comes a donor for me. So just like HLA mismatch, you look at which are the applets that you are mismatched to, and you find there are 2 mismatches. And what we tend to believe, at least most of us, is that more applet mismatches is bad, okay? Let us revisit that, okay? So I have tested one particular recipient against multiple donors, donor 1, 2, and 3, and that is red, orange, and green respectively. And what I see is that in the green one, it is just 20 applet mismatches, which is lesser than the 36 and the 44. So I tend to believe that the last one, the third donor, is a better donor. But do we have data to support that, okay? So if you really look into the data, this increased applet mismatch causing inferior outcome has been demonstrated only in class 2, DR and DQ, okay? This is a paper from Canada where they showed that, okay, 0 DR DQ mismatch did fine. Everybody knows that 0 mismatch does fine. But they were not able to tease out the difference from an antigenic perspective. That is the topmost curve in 1 to 4 DR DQ mismatches at the antigen level. But the same graph again repopulated into an applet level. They found that increased applet mismatch, you could see the splaying or the separation of the curves showing that this had increased outcome, increased applet mismatches had inferior outcome. The same thing has been proven by Belgium. Again, 920 patients, 8-year follow-up. Again, they showed that only DQ has got this applet mismatch impact, okay? So we tend to believe. So at this point, we tend to believe, okay, the whole class 1, class 2 doesn't have much of a significance. So we were happy. At least class 2, DR and DQ, we have an information where increased applet mismatches is inferior. But people, again, deep dived into these data. So what they found is that even if you have an increased applet mismatch, they did fine. Only when they become non-adherent, either from a patient perspective or doctors have, play with their immunosuppression or decrease their forced to decrease their immunosuppression for X, Y, or Z reason. So only when they become non-compliant or subadequately immunosuppressed, or curtailment of immunosuppression, then these applet mismatches show their true color. This is the CT09 study, which had to be discontinued. The study was very, very adventurous study. What they did was that if the patient did not have any donor-specific antibody, normal surveillance biopsy, they tried to stop stop tacrolimus. And what they found is that they had very bad rejections and inferior outcome. They had to stop the study. But even when they went into that, looked into that data, the tacrolimus stopping people rejected. In people who had increased class 2 mismatches, they had this bad outcome. So for a prospective kidney transplant, doing applet mismatches as a alternative to HLA mismatch is some sort of a hype, okay? Because the studies are retrospective, evidence is only for class 2, And inferior outcome actually is shown only when you have a curtailment of immunosuppression. But suppose you are a lucky transplanter to have a patient with multiple donors. But it is having more impact now because we are doing increasing disease. Paired kidney programs are coming up in India. So in that case, okay, if you have two same type donors by all other demographics, then you can go, okay, this donor might be better for you because you have, at least you can initiate a discussion with that particular patient in that. No, but I don't want to leave that on a disappointing note. But I think there's another area where applet can be used, okay? So these are at least the 3 clinical contexts which we have found that it can be very useful. So one is that, just like Sunil ma'am told, the single antigen bead profile, it's a very sensitive tool, okay? So many times, just like the sonologist puts a Doppler into the ultrasound, we might have to tease out information from the single antigen bead, and many times analyzing an applet pattern can help. Second is that, again, just like ma'am told, a retransplantation. You know that a husband is the donor, or a child is the donor to the mother, or coming for a retransplant. We know that this particular individual has been subjected to a transplant or an immunological insult. Now, he might have a memory. So how to circumvent this memory applet analysis can help. Third is that to broadly sensitize patients, to expand their transplantability, again, you can have this applet. So these are the 3 important clinical contexts where a clinician can use applet analysis. So first is SAB, to understand the SAB. So these are published data from one of the two topmost HLA labs in the world. One is Professor Tarasaki's lab, and other is from Opel's lab from Germany. So what they have found is that 25 to 60% of non-sensitized male who are never exposed to any immunological insult have anti-HLA antibodies. So it's a very sensitive platform. This is where we have a problem with single antigen bead many times. So when you come to single antigen means you have a problem at the bead level, you have kind of a problem at the serum level, and always there has been an issue with the underrepresentation of the alleles, though the vendors have come with increased spectrum of antigens. So coming to the first one, so the thing is that MFI, just you can have an MFI. So people have been historical, and there have been like 2 eras in histocompatibility. One is the serological era. We just had CDC cross-match and serological typing. Now we are in a molecular era. So in the serological era itself, people used to identify alloreactivity using cross-reactive antigen patterns. It is basically, they know that certain sera reacted to certain group of HLA antigens. So they identified that sera to be belonging to one Craig group. And this is how these Craig groups has been like, So each sera, A1 Craig sera reacts to all these HLA antigens. But now we have a molecular explanation. We have identified a particular applet. So A1 is actually by 163 RG. So now we have an explanation, right? So these applet patterns can come up. So whenever you get a single antigen profile, we have all the crab has been covered, plus we have new applet patterns which we can tease out whether this has got any meaning. For example, I will show you 2 graphs. Both are like around 5,000, 6,000 MFI. Pretty much the curves looks the same. So what does it mean? So when you do an applet analysis, so the what you see in the yellow box, in the blue box is what that particular applet confers to. So it doesn't make any sense, and the flow cross-match was negative. Whereas the other single antigen bead analysis, it can be, the whole pattern can be explained by 2 applets, and the flow cross-match was positive. So this is how you give life to a single antigen bead. So in that particular case, I will be really worried about these HLA antigens, whereas in this particular case, I will not be worried. I will not deny a transplant based on this single antigen bead, whether we call it a DSA or not. Now, this is another case. So this is a young male accelerated graft loss. It happened in Bangalore, to be precise. So he lost his graft, and father was the donor. So we expect that this kid reacted to his father's HLA, okay? So we have the HLA information, and we know the applets which are mismatched by putting it into the computer. So we know these HLA mismatches are there. So one of the applet mismatches are. So one or many of these applet mismatches should account this HLA antibody pattern. But none of the applets that explains this were actually could be associated with this particular applet pattern. So we knew that there was some false reactivity in the bead part. So what we did was we retested it with a different vendor. Now we got a same syrup, okay? Within 24 hours, tested with a different vendor, it gave us a different, we could give a pattern what was explained by one of the mismatched applets. So this is the information that we can tackle it with a applet information. Then again, the question of, though they have come with new beads, but many times we never needed, all these 15, 20 years, we never had this extended beads. But when you get an information, this is like a particular, very commonly seen antibody profile. We know the particular donor is A2 and 11. So we don't have A211 bead, okay? But we know that 201, 202, 203, and 211 all share one particular applet. So we can say that even if there is no 211 bead, this particular antibody reactivity is against that particular antigen 211, which might not be represented in the SAB panel. Now coming to the second important thing, how to circumvent the memory response to avoid the previous memory and to facilitate a transplant. So this is a real case. A young guy, his mother-in-law was the donor, actually had an accelerated graft failure and comes for a second transplant. So we know that this guy has reacted to this mother-in-law. So there we look at the applet mismatches. Okay, these are the applet mismatches. So of these applet mismatches, 1 or 2 should explain this antibody pattern. Very simple. So we go, everything, the computer does it for you, okay? So we know that I got 2 applet patterns which can explain this antibody pattern. So he has lost a graft, okay? So I should be very careful that I should avoid these 2 applets when I plan a second transplant. So we put in a paired kidney transplant. His wife was not matching, sister was not matching. In a paired kidney exchange, we found a donor which avoided all the antigens that had these applets, 55 pp and 66 ER, and we transplanted him, and almost 3 years down the line, he's doing fine. And now the last one, how to facilitate applet analysis to transplant your broadly sensitized patients. This is a challenge. You see patients, like a big antibody wall staring at you. Unless you find some pulse and, to find a way out, you are not going to transplant that individual. So this is one sum. If you look at this graph, this is a real graph of a broadly sensitized patient. So what you are left with is just few antigens that you are safe with, And that is to get just like an antigen, even in any paired kidney transplant would be challenging. So what we did, what does this antibody mean? We did an applet analysis on it. So what we find is that you see many loopholes, Many of these antigens that we see here are not explained by any applets. So they could be like non-significant antibody signals. So that's why we can do some sort of a cross-match. So any decision is finally taken by a flow cross-match. So what we find is that we could see, compared to the previous donor, you have a little more transplant options. And this has been exactly what has been done by the acceptable mismatch program. They used to look at antigens at one time, and now they look at applets at one time. So what they do is that basically, as we go, we try to identify more and more acceptable mismatches, where, it is not a match, it is a mismatch. Here what we try to look is that we actually try to ignore the positive antibodies because it doesn't make any sense with an applet analysis. So we get potentially more donors. We look virtually at them, then we do a physical cross-match, and if we do, we just go ahead. Otherwise, these patients are never ever going to get transplanted. So just to conclude, I think for prospective applet mismatching is some sort of a hype, but the data is retrospective more only in class 2. But in paired kidney exchange programs, I think you can use it. But at least as a practicing clinicians, we should be careful in playing with this immunosuppression if there is a lot of mismatches in class 2 applet level. And in clinical practice, I put that there are, at least in my experience in the world, I've been a student of this thing, and I think this is the 3 core areas where I think we can use applet is that to analyze your single antigen bead pattern is a very sensitive tool. Many of these antibody patterns doesn't make any sense, so always it gives some sort of a validity in your interpretation. And second is that to cross your memory, this is a very powerful tool. And again, to transplant your broadly sensitized patients, I think applet can be handy. I thank my mentors who have taught me everything and my team who has helped me all throughout. They are working there. That's why I'm here. Thank you all.
Thank you for the wonderful session, sir. And also, you mentioned about your mentors and your lab. It was very good. And we came to know about the applet-based analysis, which is very enlightening for us. Can I please call upon Mr. Mohan Keshavamurthy and Dr. Suneet Kaur on stage for the felicitation of Dr. Firoz? Thank you, ma'am. Thank you, sir. Thank you, sir. Okay. We'll move on to the next session. This is by our own Dr. Mohan Keshavamurthy. He's speaking about robotic renal transplantation. Sir is the Principal Director, Renal Sciences, Fortis Hospital, and also Chairman of Robotics. Welcome, sir.
Good morning. Sorry for the delay in starting. I'm possibly the only carpenter in a room full of engineers, the only urologist with a lot of high IQ nephrologists around. Usually the topper in the class went to nephrology because nobody understands much how the kidney works. But it's very easy to shift kidneys from one body to another, and that's the job of a carpenter. We did achieve 3,000, the fastest in our country in terms of robotic surgery, thanks to a pioneering support from the corporate team led by Dr. Bishnu here, of making us the first center with two Da Vinci Xis in side-by-side OTs at Fortis Banagata Road. Also, it's a privilege that I have, that I'm the oldest in a team of 30 urologists. I'm not the best, but I'm the oldest, and hence I get the platform for myself on most of the sunlight. We are the largest corporate sector urology program in India, possibly the second largest in Asia. We do over 12,000 to 13,000 procedures a year, and we do everything in the textbook of Campbell's Urology and a lot more outside of it. We have every piece of technology that Cleveland Clinic has, and in some instances, much more than Cleveland Clinic, considered the mecca of urology on the planet. We have a major training program recognized by the Government of India. We have trained about 25 urologists. We have also hosted urologists from about 18 countries. We have pioneered transplants in East Africa, West Africa. I, in fact, participated in the first 100 transplant of the 200 done in Nigeria, both at Abuja and Lagos. Started the transplant program in Ghana. Also started the robotic transplant program in Philippines. So we have been able to inspire a lot of teams to work alongside us in the evolving field of improved surgical outcomes in kidney transplant. As far as our own journey in robotic surgery, it took us 53 months to do the first 500. Obviously, in between was the COVID epidemic, and then the next 500 took us just 17 months. The next 1,000 took us 15 months. The next 1,000 took us 12 months, and the next 1,500 will take us 10 months. So it's been an exponential growth in robotic surgery. I have Dr. Murli Chakrathi nodding his head, our chairman of anesthesia, who's been a powerful proponent of adopting and adapting to robotic surgery. The ability of the robot is not immunological, but the ability of the robot is to take any patient which the nephrologist provides to us, irrespective of the anatomical problems, whether it be a right-sided donor kidney, whether it be a vascular cripple, whether it be neurogenic bladder. We are able to use the precision and the ergonomic ability of the robot to overcome anatomical challenges once the immunological challenges, which is a part of this, which is a focus of this particular CME, are taken care of by the nephrologist and the immunology lab. So irrespective whether it's an obese donor, a donor who's undergone multiple surgeries in the past, especially a mother to a child, it's a marginal donor like an elderly grandmother to a grandchild with a differential of 70 years in age, or a right donor kidney, which most centers don't do, or multiple arteries. In fact, today I'll show you a video of 3 arteries we did last week, who will be part of the press conference today. The question is, if we can do open transplant well, why do you want to use the robot? The answer is that despite over 7 lakh transplants, we still have 1 in 7 transplants with severe infection and 1 in 7 transplants with a significant hernia happening post-transplant. So we have published this data. We amongst the 10 large single center publications in robotic kidney transplant. This took the first 100 we did. We are now at the 200 mark a year later. And it is similar to most open transplant programs in terms of patient demographics. The surgical technique, robotic kidney transplant, as RAKT as we call it in urology and transplant circle, is basically a Vatikudi Medanta technique. It's an Indian-inspired technique that has gone across the world. And the most important part for even robotic surgeons in the room or for those who are not used to the nuances of robotic surgery, you need specialized equipment besides a Da Vinci Xi or any other high-end robot that you use to perform transplant. So you need a gel port. We drop the donor kidney through a port which can maintain insufflation. We need a very special instrument for the robot called the diamond forceps, which can hold 7080 suture. We need very expensive vascular clamps, bulldog clamps, which the robot recognizes. They're called robotic bulldog clamps. And then a very desi innovation, we call it jugaad in Hindi, which basically means you innovate low cost to make up for that which the high cost system doesn't provide. It's an aortic punch. The Da Vinci platform doesn't have an aortic punch. This is a $100 punch made in Agra in India, and it is used worldwide. It's a reusable stainless steel punch. The only problem with this arterial punch is it is not controlled by the robotic surgeon, but by the gentleman on the laparoscopic port. So you need a very good assistant who is as good as you or better than you to be on the lap port. So when you build teams, you need colleagues who are better than you. This is how the intraoperative setup looks. So it's a classical 4-port approach with a port placement about 3 finger breadths above the umbilicus. The kidney we take it down robotically. We call it treat. I'll explain that later. And we wrap it in gauze. If any back table surgery has to be done, if you have multiple arteries, it's done on the back table. Between retrieving it from the robot A and then putting it through into the recipient in robot B, which are adjacent OTs at Fortis Banagata Road for us. So basically, you prepare the bed on one side, you prepare the donor kidney for retrieval on the other side. These are in 2 side-by-side OTs simultaneously, both on the Da Vinci Xi platform. And then you do back table as required and then drop the kidney through the gel port and take it forward. So in terms of warm ischemia and cold ischemia, the warm ischemia is about 3 minutes longer than the traditional open transplant surgery. But in terms of cold ischemia, in terms of anastomotic time, both for the artery and the vein, and the total ischemia time is approximately the same. So it's just the 2.5 minutes longer warm ischemia. Obviously, in minimal access donor nephrectomy, you will have to retrieve the kidney after you have devascularized the kidney. In terms of graft function, in all studies, including ours, there's no difference between open surgery and robotic surgery, so it's comparable. The advantage, however, would be in the need for transfusion and in the pain relief. We use ICG perfusion as an intraop technique. We have a BK drop-down ultrasound probe that allows us to do intraoperative Doppler through the camera port, and we can use ICG on table to be sure before medical legal purposes require a formal Doppler to be done. But we can assure ourselves our anastomosis, especially if it's multiple vessel, is working on table with ICG. So where has it helped us and allowed us to grow? As I said, we are a center who 1/2 of our transplants are multiple donor arteries. A significant proportion are neurogenic bladder, and this indication is increasing. We create a pre-transplant robotic Mitrofanoff procedure. We are pioneers in robotic Mitrofanoff on the Da Vinci platform in the world. And we also manage other centers' transplant ureteric complications from about 10 countries in the last 10 years, most of them by open technique, but in the last 2 years by robotic technique, especially for commercial transplants coming in from the Middle East, commercial transplant done elsewhere for patients in the Middle East. We've been able to robotically solve their ureteric complications post-transplant. We have done a few deceased donor transplant, one of which is the world's first. We took a 14-month-old's en-bloc kidney and put it into a 29-year-old gentleman. We have published and presented this across the world. Now, this is the transplant I intend to show you. And So this is how we prepare. This is the donor nephrectomy being done. This donor had 3 arteries. This was the only donor available. As Dr. Firoz was saying, this was the only donor available whose cross-match was negative. We had known on the angio that there were 3 arteries on the left, but we also knew on the right there was only a 5 millimeter right renal vein. So we took the lesser challenge of taking on 3 arteries rather than taking on a very short vein. Although the robot solves the short renal vein with a cable cuff, we do take robotic cable cuff down in donors when we take a right donor kidney. But for this particular patient, we decided to go with the triple artery left donor kidney for donation. All the 3 arteries are delineated. Our robotic donor nephrectomies typically last 60 minutes now. Used to take us 2 hours when we started about 2 years ago. We call it the TREAT protocol. We are the only center in India, one of the 3 centers in the world to do total robot-enabled and assisted surgery. What we mean is both the donor and recipient are done on the robotic platform simultaneously. So all the 3 renal arteries were dissected individually and then clipped and taken down. So the smaller arteries, the polar arteries, were about 2 millimeter and 2.2 millimeter. The main renal artery was 5 millimeter with an early branch. When I show you the video of the back table work, you'll realize the complexity of arterial anatomy of this particular donor kidney. So we sequentially clipped the 3 renal arteries, dissected prior and kept ready, and we know the bed, the robotic bed on the recipient side is ready. We have transmission on multiple screens of one OT into the other, so the surgeon knows where exactly is his colleague in the neighboring OT. That's the renal vein being cut. And once the arteries and the renal vein is cut, we retrieve it through a short fan and steel incision. That's the vein being cut. And then on the back table, we reconstruct the vessels. We perfuse the kidney first, reconstruct the vessels, then pack it in a gauze jacket and drop it through the hand port into the recipient abdomen. So those are the 3 arteries and then the vein being taken down. So that's how the bed looks. And going forward, this is so that's the angio of the patient. It shows 3 renal arteries. You can see all 3 there, and this is the back table being done. We did one polar artery into the main artery, and then did a pantaloon for the second artery. So this is the first is the piggyback. So we have punched a hole in the main artery to connect the polar artery on the lower polar side, and on the upper polar side, the upper polar artery was a pantaloon. So as there's a handheld camera that is recording the back table work, we use a cardiac coronary stent. Privilege of having a cardiac anesthetist, like Dr. Murli Chakravarti, being actively involved in helping us, that we have taken 1 millimeter, 2 millimeter stents from cardiac colleagues and started using them in reconstructing back table the kidney transplant vascular architecture. So these are borrowed coronary stents from the cardiac OT. So that's one artery being piggybacked onto the main artery, which has an early branching. And then you can see now one has come through. We have connected it back to the main artery. Then we did a pantaloon of the other polar artery. And you will see the complexity of the reconstruction once the reconstruction is complete. It took us about 22 minutes to reconstruct on the back table. But since we have perfused the kidney, so that's how it looks now. We have reconstructed, and then it goes into a gauze jacket, allowing us to move the kidney around because the Da Vinci doesn't have tactile feel, which has been corrected in the DV5, which is an expensive new toy we all wish to possess, provided Dr. Bishnu sanctions it for us. So this is a gauze jacket, and then it is dropped into the. Now it is dropped into the. This is the bed on the recipient side. We prepare the external iliac artery and the external iliac vein. This has already been done by the time the back table is done. the mannitol on the donor side is given. So the external iliac vein and the artery for a suitable length have been prepared. And we then drop the jacketed kidney, donor kidney, through the hand port into the right iliac fossa. So that's the kidney being dropped, and I'm moving it with a diamond and the bipolar. Then we clamp with the expensive robotic bulldogs. I'm doing a venotomy, and then we use a very special suture. We are perfusing with cold saline. We use a very special suture called gore. Gore is a suture where the needle and the diameter of the suture is the same, so that no bleeding happens from the needle hole. Also, gore doesn't have any memory like proline, which is the more commonly used vascular suture. And with time, our anastomosis time has come down from about 33 minutes when I first started to about 16 minutes now. So and we use a single strand and knot it at either end to complete the anastomosis. Once the anastomosis is done, we then go ahead and put a bulldog on the renal vein and go ahead for anastomosis of the renal artery to the external iliac artery. As I said, we use a local Agra-based arterial punch, which is, to me, even now the most risky part of this anastomosis, because it's not controlled by the surgeon, but it is controlled by the gentleman on the lap port. So that's the vein being done, and we have put a clamp across the renal vein, and that's the renal artery. I've made a hole, and now comes the most scary part of transplant for me, which is the arterial punch. Once it is done, we use a gore suture to suture and we have the ability of the intraoperative Doppler probe using the BK to measure individual arterial velocities in the 3 renal arteries in this instance. When there's more than one artery, we use intraop 2,500 of heparin given at the time we declamp the artery to ensure that primary anastomosis is functional. That is a cardiac stent being put in when we are connecting the polar artery that has been reconstructed, and we pull out the cardiac stent once the anastomosis is half complete. We use Gore 6 for the vein and Gore 7 or Gore 6 for the artery, 6-0. So that's we perfuse it prior to check for any leak, and then we put a clamp on the artery, declamp the vessels, and then proceed to perform ureteric anastomosis. So that's the anastomosis complete, and then I put a clamp across the multiple arteries, pull off the arterial clamps. There are many colleague nephrologists in the room who patiently sit through with me doing these anastomosis with their heart in their mouths of what exactly would happen if it doesn't go well. But after 200 transplants, most of them are convinced that for difficult transplants, robot is the way to go. That's the uretrovesical modified Lisch-Gregoire technique being done. Is generally given to the younger member in the team as a training process to learn the art of anastomosis under pressure in kidney transplant. We do only stented ureteric anastomosis. That's the stent being put. I don't do non-stented anastomosis, and we'll discuss that nuance to anybody interested to know. So that's, I won't show this. So that's the difference between the scar of an open surgery and the scar of a RAKT. It takes about 10 cases to move from open anastomosis to robotic anastomosis. Takes another 20 cases to have your tachycardia down and for you not to pray in the room, and also to think of all good things before you declamp. And another 20 cases to be very comfortable that you can start teaching and training people. We have set up in-house 2 transplants on Monday for a few of you to join us to see nuances of how robotic transplant can be done so that you can start your own programs in the near future, which is a privilege that Fortis Healthcare affords the team urology in Bangalore as mentors for robotic transplant across the world. So if you compare published RAKT data, we are amongst the 3rd largest such purveyors of this technique, and our results are comparable. The cost in this country is extraordinarily cheap, both for open transplant and for robotic transplant. And with 3D augmented reality, AI-driven organ matching, machine perfusion and machine learning, and our own innovations in doing multiple vessel robotic donor nephrectomy with back table reconstruction, I see RAKT being adopted for those who are anatomically not being accepted as donors prior. The limitations of, in our particular program is that a significant portion of our patients come in from international locations and they go back and we don't have much of a follow-up. We don't have a very powerful deceased donor robotic kidney transplant program, which is something we'll correct in the next 24 months. A lot of my colleagues are brilliant robotic surgeons, and hence our results are tainted by the fact that very exceptionally qualified robotic surgeons perform the transplant, which may not be true in a single robotic surgeon or urologist-driven program. And we don't have all the data we are giving are retrospective. We don't have any prospective trial to actually say RAKT is as good or better than open transplant. In conclusion, it's a powerful technique for those donor nephrectomies which we couldn't accept, or for those recipients who are difficult anatomy, but it is still an early kid on the block, has significant learning curve, and needs a team approach to be successful. This is what we call it, total robot-enabled and assisted kidney transplant. I have a large team, as I said at the beginning, and we have been rewarded and awarded both in India and abroad on behalf of the team. Those of you who visit the hospital will have the privilege of meeting much more brilliant women and men in my team. They are all around, and this is a DV5. This is a request to the corporate leadership in the front row. This is the next toy that we would like to own as and when they find the money to bless us. Thank you for your patience and kind consideration.
Thank you, sir. That was an enlightening session, audio as well as visually. Sir told in the starting of the session that he's a carpenter in the house full of engineers. But then this carpenter works when the machine is on. So it's a better skilled work, in my opinion. Can I call upon Dr. Sunit Kaur and Dr. Murali Chakravarti? How can the anesthetist be behind when the surgeon is here? Please welcome, sir. Please welcome, ma'am. Please do the honors. Thank you, sir. Thank you, ma'am. Now we'll move on to the next session. The titans of the nephrology and urology world, as I may call it, because there will be a panel discussion, as in the clash of titans. Can I call upon Dr. Limesh M. He's MD, DM Nephrology, HOD Department of Nephrology, Narayana Health City, Bangalore. Please welcome, sir. Next, can I call upon Dr. Chetan CS? He's the Professor of Nephrology, AIMS Belloor Medical College. Please welcome, sir. Next, I would call upon Dr. Anup Gowda. He's consultant nephrologist and transplant physician, Apollo Hospital, Sheshadripuram, Bangalore. Please welcome, sir, for the discussion. Next is Dr. Kiran KK. He is the Professor, Nephrology, JSS Medical College, Mysuru. Can I please call upon Dr. Vinod Nagesh? He is the Consultant Nephrologist and Transplant Physician, Fortis CG. Welcome, sir. And to moderate the session, Dr. Manjunath S. He is the Additional Director, Nephrology, Fortis BG Road. Please welcome. Can we get more chairs on the dais, please? Moderator gets the biggest chair.
Thank you.
Ah, okay. The topic would be optimal individualized solutions for immunology dilemmas in kidney transplantation.
Good morning, everyone. Warm welcome to today's CME program. The topic for the panel discussion is optimal solutions for the immunological dilemmas in the kidney transplant. As you all know, the CKD prevalence is increasing worldwide. The worldwide data indicates around 850 million people are being affected with chronic kidney disease, and millions are ending with end-stage renal disease. In India, it is estimated at around more than 2 lakh new patients being diagnosed as end-stage renal disease and requiring renal replacement therapy. The renal replacement therapy in the form of either the maintenance dialysis or the kidney transplant are the two ways. And kidney transplant is considered as the best form of renal replacement therapy in view of improved survival and the improved quality of life, as well as more cost effective in the long run. When it comes to the transplant, the outcome is dependent on multiple factors. In that, the pre-transplant workup and the management of the immunization status, immunized status, has becomes important determinant in the outcome. For today's discussion, we'll be having a few case scenarios, and we'll request our experts to give the opinion regarding the scenarios.
Thank you, Manjuna sir. So we have 3 hypothetical cases today. So we will begin with the case number 1. So this is the first case for the panel discussion. Mrs. SK, 38-year-old female, she CKD stage 5, end-stage kidney disease on maintenance hemodialysis. Basic disease is presumed chronic glomerulonephritis. She is on dialysis for past 9 months. She had 2 pregnancies in the past, and last childbirth was 8 years back. She had no blood transfusions in the past. So the donor is her husband with non-consanguineous marriage and is a 44-year-old male. It's an ABO compatible transplant. So prior pre-transplant CDC cross-match and flow cytometric cross-match were negative.
When it comes to the renal transplantation, 3 main important factors from the immunological aspects what we see. One is the HLA match or mismatch, then the blood group compatibility, and as well as the tissue cross-match compatibility. First, I would like to ask Dr. Limesh to enlighten us regarding this case, whether it is an immunologically high risk or low risk, and how to go about it.
At the outset, I'd like to thank the organizers for giving us an opportunity in this SURGX. Thank you, Manjunath sir. So, if you go by this history, she's husband-wife, probably she's HLA mismatch, probably not done the HLA typing here, and she has past history of 2 pregnancies. Probably she has been sensitized in utero when the fetus would have been exposed to the maternal blood. So, I would place her in the high risk category.
And next, if it is a high risk category, what would be the choice of induction agent, and what is the dose recommended for such cases?
Maybe in this case, whether any HLA antibody screening or
HLA antibody screening was not done.
Single antigen bead assay. So that
single antigen bead not done, sir. Only CDC and flow cytometric cross matches done.
Maybe in that case, the risk stratification would have been more precise. So assuming that she is at high risk, I think ATG induction would be better.
The dose, what would you prefer, sir, in this patient?
I think 3 mg per kg, some low dose induction with ATG, standard dose is what is practiced in most.
So just to differ, probably in our center we use 1 mg per kg body weight of ATG. We have seen less complications of invasive fungal, CME infections. We don't have the robust data, but our experience states that a single dose of 1 mg per kg body weight of ATG does wonders. In the long-term outcome of the graft, even in the terms of rejection or in the infection, yes, we probably we may in another 3-4 years we may have some robust data.
the induction protocol differs. Uh, there are many variation regarding the dose of the the use of the basiliximab as well as ATG, and it all depends on the center and their experience regarding the induction. Next, Dr. Kiran, can you tell about whether flow cross-match and DSA is required in this case?
Yeah, I think both are required. Flow would probably give us an idea whether the patient has antibody against the donor cells. And but the only flip side is flow will not tell you whether it is not specific. It does not tell you which antigen it is effective against. So that can be probably confirmed by DSA, which is more specific. So that will give us an idea as to which specific antigen it is the antibodies against. And probably a mix of both would help us easily characterize whether the patient is low risk or high risk. So that can help us in deciding about the induction agent.
Okay. Dr. Anup, is there a need for a single antigen B test in this case?
If flow and DSA is negative, I wouldn't do it. However, if you want to play safe, then SAB in all cases is the way to go about having. She's had 2 kids, so definitely she would be exposed to husband's antigens. So she would have developed some antibodies for sure. So SAB in all cases, if finance is not a problem, and if you want to play safe, definitely.
And as well as even the donor HLA, so that we can have a virtual cross match.
Exactly.
Yeah, right.
And if there is, then we can always plan. Like I would definitely prefer an IL-2 blocker rather than ATG in this case, as Limesh was speaking about.
Okay. Yeah. Thank you. We'll next move to the second case.
So we will move on to the second case. She is Mr. S, 44-year-old male, is a CKD stage 5 or end-stage kidney disease on maintenance hemodialysis. Basic disease was IgA nephropathy. So he underwent first transplant in 2018. A mother as a donor. It was a ABO incompatible transplant, B2O. So over a period of a time, after 2 years, patient had a graft dysfunction. Allograft biopsy was suggestive of chronic ABMR. So eventually, over a period of a time, he lost the graft and is back to dialysis by 2023. And he is on dialysis for 3 years and is registered for cadaver kidney transplantations. So 2 times organ not allocated in view of positive cross-match. So because of this, patient was interested to go ahead with transplant. Single antigen bead was done. This is the profile he had. In that, the highest MFI for class 1 is 3877 and class 2 for DRB 885. So this is the patient profile. If you want to have a look at the DSA profile.
Here, this gentleman is basically IgA nephropathy, underwent a ABO incompatible transplant, then subsequently had a graft loss because of ABMR. And now he is registered for a cadaveric transplant, for the second transplant. And what is the best option for such kind of patients? Whether to continue on dialysis or go for a swab transplant or desensitization and transplant. I would request Dr. Limesh to.
Considering his age is around in 40 years, probably the first option to be for looking for a second transplant itself. It's a very common scenario we see in our daily practice. The patient would have lost his graft for 4 or 5 years, then would have registered for a deceased donor transplant. And historically speaking, he has cross-match positive. So he's, for all the practical purpose, he's highly sensitized this one. Yes, definitely the HLA, I mean, the alleles, the MFI values are all for the multiple antigens is very high. It's a high-risk transplant. Swab for an immunologically compatible donor, probably getting a PRA would have been an answerable question. I would have done a PRA. If the PRA is say probably 100%, the probability of him getting an organ will be very, very less. Yes, I would have, if he gets an, by lucky chance, if he gets a CDC negative, any deceased donor, yes, we will go for an organ allocation and with the desensitization protocol.
Next, what is the approach for desensitization on a patient waiting on the cadaveric list? Whether should we consider rituximab, MMF, plasmapheresis, IVIG, or DSA monitoring and desensitization? Means basically, how to manage this patient and how to prepare him for the next transplant?
This will be the second transplant, and he has multiple anti-HLA antibodies and with cross-match twice positive. I think routine preemptive desensitization while on the waiting list may not serve any purpose. I think we should go for a swab transplant, or if a incompatible donor is there, definitely swab transplant would be the best option in this case.
So majority of the times swab transplant availability is very limited. So in that scenario, if he really...
In that case, I think he should go for a virtual, this thing. When the donor becomes available, do a virtual cross-match, and this thing is negative, then maybe a limited desensitization around the peri-transplant period, desensitization, and then to proceed.
The only problem with cadaver transplant is the timing. Many a times the waiting time is so long that even if you tend to desensitize early, they may develop antibodies they may have a relapse of the antibodies at a later stage. So you need to really keep monitoring the PRA levels, and then...
Can we give rituximab then followed by MMF CNI as a...
Yes, certain centers do follow that protocol.
Monitor the
but then the
PRA.
cost of transplant in Indian scenario, I'm not too sure, considering the cost, the
risk
cost,
of infection.
yeah, the risk of infection. Infection risk goes up.
In fact, in such cases, we ask for, along with the CDC, when the patient go for a cross match, we request for a DSA also. That gives whether that in case if the donor HLA is available, we can do a SAB also and find out by virtual cross match whether that donor is suitable. And at the same time, if the donation happens in-house, when we get a sufficient time, we can give a plasmapheresis session and followed by IVIG, then give the induction immunosuppression. That also can solve when the PRA levels are low. And the next question is the choice of induction agent in such cases and what are the doses?
Again, this is a high-risk candidate, so invariably we go with rabbit ATG. A dose probably you would require around 4 to 6 grams over 3 days. In our centers, we usually don't go beyond 1 milligram per kg, and we've had excellent results. Especially the risk of rejection is less. At the same time, we don't see too many infectious complications also. But him being a very high sensitized patient, probably a total dose of 4.5 to 6 milligram per kg would help him.
The next, the post-transplant immunological monitoring such cases, whether should we do a DSA subsequently, or do we depend on the biopsy, or either a protocol biopsy or indication biopsy, if there is a derange in the graft function, or should we look at DDCF DNA, which is a new the investigation modality available?
So basically, organ allocation in this case is extremely rare. Like we only do CDC in our Karnataka as of now. So the chances of him being positive will be very high. So high PRA for sure. So I would definitely use Ritux in the early stages. And I had few patients who were high PRA. So I had put them on Ritux and MMF protocol, and I also went for an SAB on these patients to look for how many antibodies they have. And basically, if they are dropping their antibodies, then that's the best scenario. If that doesn't happen, then chances of him undergoing transplantation is extremely rare. By luck, if he gets a swab transplant or an compatible transplantation, then definitely DSA at the end of, say, 5 or 6 days, or protocol biopsy is the way to go about. The DNA, those are the antigens which is released because of the new kidney, and measuring those quantities also will be helpful. If there is too much of DNA, then high chances that he develops an immunogenic response. To add up this note, there is a newer drug called as imlifidase. I think in UK, King's, they have done 3 transplants. Yesterday they did one with imlifidase. My very close friend is there, so I was speaking to him. So what it does is it cleaves all the IgG, and IgG disappears over next 6 to 8 hours. So once there is no IgG, then you do the transplant with the classic ATG induction with plasmapheresis, and then offer plasmapheresis if there is any rise in creatinines.
Right. Good.
The only problem with imlifidase is there's the antibody rebound.
Rebound.
So after
is
1 week,
for fun.
the antibody again picks up.
That's where the monitoring of
again,
the DSA comes in.
It costs 1.3 crores there itself.
It's
So
very
not possible as of now.
So let's move on to the third case. Here we have an African American who is a 45-year-old male, international patient, CKD stage 5 ESRD. His blood group is O positive. His basic disease is presumed CGN. He wishes to go ahead with kidney transplant with the donor, his brother, 55-year-old male. Blood group is A positive. It's a ABO incompatible transplant, A2O. And his baseline anti-A titers in the recipient are IgG 1:512 and IgM 1:256. HLA has been done. HLA mismatch 9 out of 10. And the DNA testing, they are brothers.
Yeah,
is this
9/10 mismatch, extremely high sensitized patient, 512 to baseline. So definitely a tricky and very difficult transplant when it comes to ABOI.
What is the acceptable level for the
No, I would definitely, if they have come all the way from Africa to here, we'll have to offer them, do a good round of plasmapheresis, 3 rounds, rituximab about 3 weeks. I normally prefer 3 weeks before ABOI. And then I haven't got the CD19 levels post-Ritux, but few centers does Ritux also, CD19 levels also. And then do plasmapheresis. I prefer our own dialysis machine as a plasmapheresis. And then immunoabsorption at 512 for sure. If immunoabsorption cost isn't constrained, then series, we have done series, I have put 2 filters seriously and pulled out the IgG and then look for IgG. And safe zone would be about 1:8 or 1:16. I would see if there is any rebound. So you prepare this patient, say 5 days prior. If there is a rebound after 48 hours, if it is going to 1:64, I would definitely wait for some more time. If it is stable around 1:8 and 1:16, then that's the window, ATG, to block the T cells, and then methylprednisolone and MMF and TAC.
Next, what baseline titer is immunological safe for ABO transplant, ABO incompatible transplant?
I think most of the centers are more comfortable with a titer of less than 1:8 before they, but so many centers also do when the titers are less than 1:16. But probably in our center, we prefer the titers to be less than 1:8. So we go ahead with transplant when it's less than that.
What should the desensitization should be planned? Does the rituximab for dose of rituximab for desensitization?
Most of the times, I think they go for the fixed low dose rituximab of 200 mg given, I think 2 to 4 weeks prior to transplant. But this, the titers are very high. Whether this requires a little higher dose of rituximab, I think maybe the centers who are doing more of ABO incompatible should.
Just to mention about the titers are very high. Probably the blood banks, they are not using this reagent, what is called as DTT. It's a reagent which removes all the false positive antibodies. And it only specifically targets the anti-A or anti-B titers. Probably that will give more information. That's what was happening in our unit. We didn't know that this one is there. Then when we added DDT, the actual titers of this anti-A anti-titers have come down. So 1:512, probably it will be 1:124, something like that. Probably you need to talk to your hematology. And yes, the dose now we are using in our unit is around 200 mg. That's all. Only one dose.
To add this, any antibody titers, the both IgG, IgM are detected together. And with the DDT, definitely IgM part can be taken out. And in a ABO incompatible transplant, the IgG plays an important role. And in the monitoring of the titer, we look at the IgG part, not the IgM. And at the same time, when it comes to the induction, there are two two schools of thoughts. One is the ATG as an induction. The second one is when already rituximab has been given, the basiliximab carries a better long-term prognosis in terms of infection as well as the prevention of ABMR. Next.
Immunoadsorption or plasmapheresis.
Do you suggest immunoadsorption in such cases or just a plasmapheresis to go ahead?
Actually, the immunoabsorption, there is double filtration plasmapheresis that has really made our life easy because plasmapheresis, we have seen a lot of bleeding complications in the intra-op and the post-op complications. Yes, there will be a cost difference of around 50,000 to 1 lakh with 5 sessions of plasma exchange and this double filtration plasmapheresis. For 1 lakh, probably the immunoabsorption, that is glycosol, will be the ideal choice for us, which we follow in our unit.
Is this patient suitable for
Plasma membrane filtration?
Regarding the plasmapheresis, there are again two ways of doing the plasmapheresis, the centrifugation method and the membrane filtration. Which one do you prefer?
In our unit, we use, because as nephrologist, we use only the membrane because we don't let go our transplant patients to the hematology department. Yes, both are equal, but cost are also comparably equal. We, for all practical purpose and logistic purpose, membrane filtration is the choice for us.
But however, centrifugation does offer the advantage. Bleeding complications are much less, and if you want to do a large volume exchange, then probably centrifugal this thing would be helpful, beneficial.
Albumin loss will be very less.
Then a role of IVIG in desensitization protocol in ABO transplant.
Low dose IVIG, 100 mg per kg or something like 5 grams after each session. I think that should be adequate, I think, while we are doing for preconditioning for a ABO incompatible transplant.
Couple of centers are not using IVIG because it may interfere with the antibody titration and measurements. Few centers use and few centers do not use. POD4 after successful ABO incompatible transplantation, the creatinine increases from 1.2 to 2.5, and anti-A titers also jumped from 1:8 to 1:128. So in this scenario,
biopsy is indicated, or should we?
Yeah. Definitely, he has graft dysfunction, plus he has raising titers. So that probably he might be developing rejection. So definitely biopsy is indicated. We have to rule out because the risk is quite high in the first 1 to 2 weeks post-transplant in an ABO incompatible transplant. So we have to do a biopsy to really know what is happening. Sometimes apart from this also, patient may have associated T-cell rejection, or he may have other problems like ATN, or it may be CNI toxicity. To really rule out which one is a possible cause, we have to do a biopsy.
And post-transplant antibody monitoring, how long should we do and when should be done?
In this scenario, both the entities may be playing it. The ABO rejection can also be there, or the HLA, because there's a 9/10 mismatch when that possibility is high. So DSA straight away. Biopsy would not tell us whether it's an ABOI rejection or whether it's an HLA rejection, but DSA high titers going up definitely would help us there. That's how I would do in my insert.
Titers probably, yeah, we may have to monitor more closely in the first 2 weeks, maybe on an alternative basis in the first week, and then probably twice a week for the next 2 weeks, and then weekly for the next 2-3 weeks, and then probably after that monthly for the next 3 months at least, or as and when required if there is any graft dysfunction.
Anybody want to differ from this?
In our unit, for the first 2 weeks, we monitor them every alternate days. And then if there is normal graft functions, we monitor them once a week for up to next 2 months, then every month for the next 6 months to see any rebound of the titers and with the graft dysfunction.
So thank you, the panel discussion, I guess. Take-home message from this discussion is current international guidelines favors prioritizing compatible transplantation through paired exchange wherever possible, and reserve the desensitization for carefully selected patients due to its higher cost and higher risk of infection and ABMR, and individualizing treatment based on immunological risk and patient's overall clinical profile will definitely help us to achieve good post-transplant outcomes. I thank all our panelists for giving their expert opinion on our individualizing the transplant decisions. Thank you.
Thank you. Thank you, everyone. Now the floor is open for question and answers. If there are any questions, please.
safer side. If there is graft dysfunction,
even that whatever the scenario they tell, no, this is 1 is to 250. I think it's unlikely. Do you want to do plasmapheresis? Because there no
graft dysfunction, yes.
Yes. So we have to search for other causes of the graft dysfunction by doing biopsy.
For the first 2 weeks, probably we need to monitor them closely, sir, because even accommodation will take at least 2-3 weeks. So till such time, probably a close monitoring of the titers would be beneficial.
No, do you advise plasmapheresis that one if the titer is 2.0?
If graft is stable, when there is a graft,
only rising titers is not an indication for plasmapheresis.
Case is no 2.5 creatinine.
Here, the creatinine has increased from 1.2 to 2.5.
Yeah,
we don't know what is the cause for the graft dysfunction. So definitely, I would
pre-transplant
prefer doing a biopsy along with the anti-A titer monitoring.
Yes.
If
So
the
first
graft
biopsy
biopsy suggests, yes.
Or plasmapheresis on biopsy or first biopsy and then?
No, first biopsy. We have to find out
to
what is a lesion inside, and then based on that.
As you told, we have to search for other causes of
Yes.
dysfunction.
Thank you.
No, 1:8 to 1:2, 1. It is 1:128. It's like quadruple. So I think safe subset is we'll have to think it as ABOI rejection.
No, depends on the centers. Those who have experienced avian control, they are doing no titer. They are not at all monitoring. What are they? Even 1:1256 also they are doing. Only thing experience and rituximab regarding the rituximab, Kolkata Racer only is giving only 100 milligram, not more than that. Only 100 milligram, 14 days. Then others will start the tractanosemab minus 14 only. So as we get experience, I think we'll get more confident of doing avian control.
The protocol differs, starting from the dose of rituximab and the dose of basiliximab. Means whether to use a basiliximab or
some centers they use
scenarios.
Because
and also there are wide variation, like in the how they practice, whether to give immunoadsorption or just go with a plasmapheresis. Whatever the standard protocol is, when the titers are more than 1:128, the immunoadsorption is advocated.
No, that is always better option if the cost is not effective.
When the
cost is not a
yes,
concern.
True.
As you told, plasmapheresis will definitely have bleeding complications during this one. Immunoadsorption is always better. I think Deepak is
we have to expert in ABO.
Good morning, I am Dr. Ravindra Madarki from Bijapur. Just I have a question regarding post-transplant monitoring for anti-ABO titers. Is there any guidelines after 2 weeks for monitoring anti-ABO, or is it any clinical worthwhile monitoring up to 4 weeks?
Usually by the end of 2 weeks, the accommodation happens. Unless there is a graft dysfunction, if there is no variation in the creatinine and the patient is doing well with a good urine output, the monitoring would be like only if there is a graft dysfunction. Otherwise, I would not do.
This is what we also do. But any guidelines or recommendation after 2 weeks to monitor anti-ABO titer,
No, sir.
irrespective of the graft function?
Individualized center-wise, sir. The KDIGO, there is no guidelines from KDIGO or any other bodies regarding this.
I also didn't come across anything. Just I was thinking somebody is telling once in a week or somebody is telling like that. But I only monitor for 2 weeks, and if graft function is normal, we are not monitoring. I have very small experience, and I was also going through the literature. I couldn't find. That's if anybody put a light on this.
Anybody has experience of doing ABOI transplantation without giving ATG? Because recent studies have told that giving ATG in ABOI transplantation increases the risk of ABMR.
Yes, there are studies where the combination of the rituximab and ATG, they have compared with rituximab and basiliximab. They have found the results are better with rituximab and basiliximab in terms of ABMR as well as infection and long-term graft survival.
So all the questions on ABO incompatible transplant will be answered in our next session.
Dr.
Deepak sir is taking ahead the course. So we will try to clear all the doubts. Thank you.
Thank you all the panelists, and thank you all for your participation.
Thank you.
Thank you, everybody, for the wonderful panel discussion. Can I now call upon Dr. Veerbhadra Gupta, sir, to be on stage? Please felicitate Dr. Chetan, sir, for the wonderful discussion. Sir, please be in there. Can I request sir to also felicitate Dr. Limesh M? Thank you, sir. Can I please call upon Mr. Vishwanath, sir, on stage? He's the business head for Agilus Diagnostics South India. Please, can you felicitate Dr. Anup Gowda? And also Dr. Kiran, please. Can I call upon Dr. Ashwini? She's the lab head and senior consultant pathologist in CG Fortis. Please give it to Dr. Manjunath. Thank you. Thank you, sir. Can I call upon Dr. Uma, ma'am? She's the senior microbiologist in BG Fortis. Please felicitate Dr. Nageshwini. Thank you, ma'am. Thank you, sir. Now we move on to the next topic, that is the immunological challenges in ABO incompatible transplant. This will be hosted by Dr. Deepak Chitrali. A brief introduction. He is the lead consultant nephrologist and transplant physician in Manipal Hospital, Yeshwantpur and Yelahanka, Bangalore. Please welcome sir on stage.
Good morning. At the outset, I would like to thank the Fortis Group for giving me an opportunity to present about a complex topic relatively, which is immunology of ABO incompatible kidney transplants. to start with some basics about immunologically incompatible transplants. We have two immunologically incompatible transplants, which we have been hearing for last 2 hours or so. One is the HLA incompatible transplant, and the other is the ABO incompatible transplants. Now, today we will discuss about immunology of ABO incompatible transplants. Those started in 1980. The significant increase in the transplant numbers have happened over the last 2 decades because of better knowledge of immune system, better availability of drugs, and evolution of desensitization protocol. Now, before understanding the immunology of transplant itself, we should know certain things about immunology of blood group antigens. As we know that, individual with a blood group will have antibodies against the opposite blood group. So for example, you have anti-A antibodies or anti-B antibodies, which are directed against the opposite blood group. And these antibodies are present in all of us and which are there from birth, or they sort of reach the peak at around 5 to 10 years of age when we grow. And those antibodies happen in us because of exposure to various viral or bacterial infections as we grow. RH is not important for an ABO incompatible kidney transplant because RH factor is not expressed in the endothelial cells of the kidney. Now, this is a diagram where we can see individual with blood group A will have antibodies against the opposite blood group, that is anti-B. Individual with B group will have antibodies against the opposite group, that is anti-A antibodies. Individual with AB group will not have any antibodies, and that's how they become universal recipients. And individual with O blood group, they won't have any antigens of A or B, hence they have both the antibodies, that is anti-A and anti-B antibodies. So this is how the antibodies are distributed in every individuals, and these are present and innate to an individual, which are there throughout the life. Now coming to the antigens of ABO blood group, which are there in the kidney, which are expressed in the kidney, they are the glycoproteins. They are expressed on RBCs, epithelial cells, and endothelial cells of the renal tubules. And these antigens elicit an immune response to the antibodies which are there in the recipient. For example, you put a different blood group antigenic kidney into the recipient, so you will have an immune response with the antibodies which are already existing in that individual against the opposite blood group, and that immune response will activate the complement pathway and hence leading to antibody-mediated rejection. So this is how rejection happens in an ABO incompatible kidney transplant. Now, to make it a little more simple through this diagram, ABMR happens because of isoagglutinins, that is the antibodies against the opposite blood group, when combined or when stimulated by a blood group antigen and with the help of complements. So it leads to complement activation, the antigen-antibody complex, which we can see here. Antigen stimulates antibody, the complex leads to activation of complements, and complement-mediated membrane damage happens here, leading to cascade of antibody-mediated rejection, which is comprised of inflammation, tubulitis, glomerulitis, and fibrinoid necrosis. So this is how a rejection happens. Now, little more understanding about this complement is needed to understand the ABO incompatible transplants better. See, once the complement pathway is activated here on the left-hand side, what we can see, it leads to something called as split products, which is of clinical significance for us, which is called C4D here. This is a split product which is formed by the activation of complements, and this C4D combines with the antigen-antibody complex in the peritubular capillaries, and ultimately that gets deposited in the peritubular capillaries of the kidney. C4D is called as a footprint because it stays for a longer time, whereas antigen-antibody complexes dissociate over a period of time. So C4D persists longer, hence C4D is seen after an ABMR or a rejection, which is seen in the peritubular capillaries, as we can see in the immunofluorescence slide here. So this C4D is very important, and which indicates rejection after an antibody-mediated rejection. So, but there is a paradox here with the C4D. What happens when the opposite thing happens, that is accommodation, which we were hearing in the panel discussion, what is this accommodation? Accommodation is basis of no rejection happening after a kidney transplant. This is a process where there is no immune response against a different blood group antigenic kidney, and that's how the body treats recipient. I mean, the recipient body treats that kidney as its own, and which happens over a period of 2 to 3 weeks. Now, what is the mechanism of this accommodation? It happens, first of all, when the antibodies are very less during the time of transplant. When you implant a kidney, the antibodies are less, and that will further lead to the suppression of antigenicity and reduction of these antigens to mount or stimulate an antibody response against these antigens. So this is called accommodation. However, accommodation will also have C4D positivity. No, that leads to a confusion. And in ABMR you have C4D positivity. In accommodation you have C4D positivity. So how does both happen, or how does both differ? That is the thing which I want to explain in this next slide. The whole point here is about ISA titers, that is isoagglutinin titers, or the antibodies against the opposite blood group. So what happens when the titers are high? You have rejection because antibody titers are high, antibody binds and it activates complex, and there is C4D positivity and there is rejection. What happens when the opposite thing happens? That is, the antibody titers are low, the isoagglutinin titers are very low. Then the accommodation happens because you don't have such robust immune response or such robust antigen-antibody binding capabilities. Though antigen-antibody bind with the help of C4D, but that immune response is not so robust. And hence, there is a milder antigen-antibody accumulation with C4D, which leads to C4D footprint and C4D positivity, but it is not strong enough to cause a rejection, and that's how accommodation happens. So C4D is positive in both the conditions here. When we do a kidney biopsy, how do you differ that C4D is due to rejection or C4D is due to accommodation here? That is done by the clinical evidence, serological evidence, and histological evidence. So you check for rise in the creatinine, you check for DSAs, you check for tubulitis and glomerulitis and fibrinoid necrosis in the biopsy. That tells that it is rejection and not accommodation. Otherwise, most of the ABO-incompatible transplant kidneys have C4D positivity because of accommodation. Now, this was about little of immunology. Now, how do we tackle this immune risk, or how do we deal with this complex immune mechanisms? We deal by knowing one, overview of ISA antibodies, and second, suppression of these antibodies or removal of these antibodies, and achieve the target level of antibodies, transplant surgery, and post-transplant monitoring. I'll go very briefly with the protocols because already in the panel discussion we have discussed about that. This is a general protocol for an ABO-incompatible transplant. In the upper half, we can see what is important for an ABO-incompatible transplant. That is over there. And rest all is same as the ABO-compatible transplant. -14 rituximab. Some people do give -21 as well, but the standard is -14 injection rituximab, and followed by plasmapheresis within 7 days prior to the transplant, and achieve the target titers of ISA levels, which could be 1:6 or 1:18. Different centers choose different target levels of ISA antibodies at the time of transplant. And starting immunosuppression little early, -7 or -5, again, it differs from transplant to transplant center. And then rest of the immunosuppression would be same as the ABO-compatible transplant. So this is a gross overview of a protocol. There are various protocols, but each center over a period of time, once the number of ABO-incompatible transplants increase, they adapt to their own protocol. But the basis of these protocols are pretty simple. One is suppression of these antibodies by giving rituximab, and eviction of these antibodies by doing plasmapheresis. So at one end, you are giving rituximab and suppressing the antibody production by blocking the B cells, and at other end, you are removing these antibodies by doing plasmapheresis. So that's a basic concept. Estimation of antibodies are important. IgG is more relevant than IgM, and preparation of blood bank team is really important. This is ABO-incompatible transplant is a field where blood bank plays a major role, and having a good blood bank team with the trained technicians is really important to have a successful ABO-incompatible transplant program. This is a slide which shows, where we can see this, towards the bottom of, on the right side, you can see this slide agglutination test done by gel card method. You can see the upper portion of settling of antigen-antibody complex, that is agglutination, which indicates there is positive reaction. It could be 3+, 4+, or 2+. And the extreme right there, you have settling of those agglutinins, which indicates there is no reaction. So it is graded from 0 to 4. These are the methods which we again discussed about plasmapheresis and immunoadsorption. And there are different methods of plasmapheresis which we discussed: conventional or membrane, centrifugal plasmapheresis, and double filtration plasmapheresis. We at our center use centrifugal plasmapheresis, and we have data of more than 60 cases. And all the cases we have done centrifugal plasmapheresis, which offers little advantages. Like, this is a centrifugal machine. The advantage would be having a very low blood flow and having better hemodynamic instability. And you can do it in the ward. There is no need to shift to the dialysis unit. You can do this in the ward, shifting the machine there. And we use citrate anticoagulation, so bleeding risks are lesser when we use citrate anticoagulation. So these are some of the advantages of centrifugal plasmapheresis. And this is a circuit of immunoadsorption where we can use glycosob or adzopac column. I'll not go into the details of these protocols because we had a discussion on that. This is what we follow at our protocol, our center, the protocol about rituximab. Initially, we were using 500 mg, and now we have moved to 200 mg because more global data is emerging with 200 mg of rituximab. We give about 10 days to 2 weeks prior to the transplant. Immunosuppression is more or less standard, and everyone is aware of this immunosuppression. Target TAC levels would remain same. Induction, again, ATG or basiliximab. Each center can have their own protocol. We use a low-dose ATG as a protocol, and then maintenance immunosuppression would be same. This is important, peri-transplant monitoring. When we are doing an ABO-incompatible transplant, monitoring of the titers and keeping it as low as possible, peri-transplant period is really important because that will help in achieving accommodation faster. So that's the theoretical part of it. Pre and post plasmapheresis, when we are checking titers, it is important to give 2 to 6 hours gap before checking the titers once you have done plasmapheresis, because that would give a more accurate value. If you do it little early, you may have lower levels, and next day you may see that levels are relatively higher. So on the day of surgery, you achieve a target titers of 1:8 or 1:16. Initially, we were achieving 1:8 because we had started transplant program, ABO program initially, but now in the last 30 cases, we have kept target as 1:16, and we have got good results with that. Then the transplant surgery happens, and post-transplant monitoring, again, in the panel discussion, we had this discussion, there are no guidelines on monitoring beyond 14 days. So ideally, 10 to 14 days monitoring is enough, and that is a time where accommodation happens. Beyond that, monitoring may not give us any additional benefit. So what about this prophylactic plasmapheresis? Again, there are guidelines or consensus saying that no prophylactic plasmapheresis is needed post ABO-incompatible transplant. But again, few centers differ in this aspect. Somebody, after an ABO-incompatible transplant, if titers are more than 1:64, few centers, they prefer doing plasmapheresis so that, the risk of rejections are negated. But again, that is dependent on the center to center. So this is any rebound post-transplant doesn't warrant doing a plasmapheresis. Target TAC levels, as we discussed, it's more or less same. Most important point, what I would like to stress is post-ABO-incompatible transplant, the risk of CMV or BKV is a little higher than the compatible transplant. So it is important to check CMV or BKV, after about 6 to 8 weeks post-ABO-incompatible transplant. Prophylaxis would remain same. Few centers add antifungal as a prophylaxis, but again, there is no consensus or data on adding that antifungal prophylaxis. This is our data which we compared. This may not be very relevant. Now, this was about immunology and how we tackle immunology. Let me discuss few complex case-based situations, what we had at our center after doing ABO-incompatible transplants. So I wanted to share a few complex cases, which we will go through. We had a 40-year-old male, O group, and native kidney disease was CIN for him. He came to us for a second transplant. First transplant was done in Malaysia. Mother was a donor, and this was about 20 years back. His graft lasted for 20 years. That was an ABO-compatible transplant. And now he was back on dialysis, and his wife wanted to donate kidney. And they came to us for a second transplant, and it was A to O. The donor group was A, and the recipient group was O. We had challenges in this case because, as we can see on the right-hand column, the titers of IgG in him were 1:2048. So it was a very high titer ABO-incompatible transplant. And it was a second transplant. Luckily, there was no HLA incompatibility. HLA was compatible in this case. So that made things a little easier. And he had some dilated cardiomyopathy. We optimized him for 2 weeks, 2 months before taking him for transplant. Titers were 1:2048. Other important thing during an ABO-incompatible transplant is you got to build up the nutrition of the recipient, because they will be susceptible for hypoalbuminemia post-transplant. So you got to build up their nutrition as soon as we know that he is going for an ABO-incompatible transplant. So that is going to be really important when we take the patients for ABO-incompatible. So 2 months we waited and then took them for ABO-incompatible transplant. The protocol, most of us would use the same, the hybrid protocol of immunoadsorption because titers are higher, and then plasmapheresis. We did about 2 to 3 sessions of plasmapheresis. Titers dropped to 1:64 over a period. Titers down. We reuse the immunoadsorption. We use another column of immunoadsorption. It was not helping. So what did we do? I called few friends, find out, what can we do, because titers are not coming below 1:64. Should we go ahead? Should we not go ahead? And if we go ahead, what are the risks of rejection? So on, things were, going on in our mind. Few friends suggested that you can modify the FFP and the albumin composition. Generally, I think most of the centers, what is done is 70:30. 70% albumin and 30% FFP is what is used. AB group FFP is what everyone uses. So making it 50-50%, with a little more use of FFP would dilute titers little more and would give a lower titer value. This was a theoretical, advice given. We did that actually. And then others also suggested using a donor FFP because that can lead to greater reduction of antibody titers. So we didn't try that because this was initial few cases for us, but we tried with that 50% ratio. But, anything changed? No, actually nothing changed. The titers remained at 1:64. So, this time, surgeons kept calling, rather than we calling, surgeons called saying, no, when are you posting the case? We have booked the OT and all that. So we went ahead and did the transplant with 1:64 titers because the data from East actually suggests that 1:32 or 64 is a cutoff. We thought this could be one of the patients wherein we can take that risk. Patient was also from Malaysia, his, titer cutoff, we would not know. He's not Indian. So, those were the thoughts which went on in our mind. And then we went ahead with the transplant, and actually he had a successful transplant. His titers remained 1:64 post-op for about 2 weeks. There was no rebound of titers. And he did excellently well. Till now he continues to do excellently well with a creat of about 0.8. Then what lessons we learned from this case was we increased the cutoff for titers. And, we made it 1:16. Before that, we used to take 1:8. We used to make sure it used to come to 1:8, keep postponing surgery. Then, we got courage to make it 1:16. And from then we have, amended our cutoff titers to 1:16. And, touch wood, no patients are having rejection with 1:16 titers, at least. Few centers take 1:32, as I said. And we also started taking higher baseline titers cases, like, 1,000, 2,000 odd titers. And, this I discussed, and this about FFP I discussed using. Some centers also suggest, particularly in liver transplants, they use FFP alone and not the albumin for desensitization in a ABO-incompatible transplant. That gives a greater reduction of titers. The explanation given in this is it leads to dilution of titers. So that's why the titer values can be low. And using a donor group FFP also helps in reduction of titers when you have difficulty in achieving low titers. So other important point here is be careful with the anti-A titers. You always see a donor blood group A or a B. You would be happy if you have a B donor group rather than having an A donor group, because A is highly antigenic than compared to B. And in A, you have subgroups like A1 and A2, and A1 is more antigenic than A2. And that's how we have to be a little more careful with the A titers. One, the baseline titers would be higher. Second, it would be difficult to achieve reduction in these titers. Third, the rebound of titers are more with A group rather than B group titers. So that we have to keep in mind, and we have to be prepared before for more session of plasmapheresis or use an anti-A column rather than going with plasmapheresis. This is a second case, again an interesting case, which was from wife to husband. And this was complex because you had to deal with two blood groups, that is AB to O. So you have to deal with A group and B group. To make it more challenging, both the groups' antibody titers were very high. Anti-A titers were 2000, anti-B titers were 1024. Again, you can see here, anti-A titers are relatively more compared to anti-B titers, suggesting that, A is more antigenic. This was a highly motivated family. Initially, we were reluctant to tackle this, because 3 years ago, we didn't have that confidence to do, tackle two blood groups. But then motivated family, we went ahead. Again, a hybrid module of desensitization protocol or antibody reduction, where we use anti-AB glycosob column. We do have anti-AB glycosob column now available with glycosob, and 4 sessions of plasmapheresis. Titers dropped to 1:16 in him. It was easier to achieve 1:16, and then we did a transplant, and he had a good outcome. However, he had a rebound of titers 1:64. This was again anti-A and not anti-B. And this 1:64, we did a session of plasmapheresis because sometimes we may have to take that clinical decision wherein, you have done all the hard work. We are a little scared to keep those antibodies beyond certain level, and then we had to bring it down. So we did a prophylactic plasmapheresis for him, and then titers remained at 1:32, and then he had a successful transplant. This case we are publishing. This is a third case. This case is a easier case actually, because in ABO incompatible transplant is anything easy in this, actually no, but relatively this is an easier transplant. It was a mother to son transplant, blood group A to B. Titers were 1:4. We thought, okay, the blood bank team has given a wrong titers. How can you have 1:4? We checked again, we checked at multiple places. It was 1:4 only when we checked multiple times. What we learned after this particular case is when you have an A group donor, you do subtyping. A1 or A2 group, you check for a subtyping. You may be lucky having an A2 blood group donor. If you have an A2 blood group donor, which is seen in 20% of population, you may be just lucky to do this particular transplant because A2 is, very less antigenic, as compared to A1. So it is in fact the lowest antigenic among all the blood groups, so your titers will be lesser. You may not use any plasmapheresis. In this particular case, we just used rituximab, and then we went ahead with the transplant, because we didn't have to do plasmapheresis because titers were very less. So having an A2 group would make things very easy. This, I prepared this slide, wherein if you have to judge the complexity of ABO incompatible transplant, we could judge like this. If somebody with an A2 blood group, it would be easier transplant, followed by B, followed by A1, which is more complex out of these three. And when you have a combination of AB group, A2B is relatively easier, and A1B is the more challenging one. So knowledge about this will be needed because you can plan your desensitization protocol better based on the group. Because you have an A group, you should be ready with more session of plasmapheresis, more complexity, start early, be ready for rebound, be ready for post-transplant plasmapheresis and so on, as compared to B blood group donor. Now moving on to the final part of my topic, a little about post-transplant thrombotic microangiopathy, which is evolving, or rather dreaded complication post-transplant, and everyone wants to be known about this. Incidence of thrombotic microangiopathy is as high as 5 to 20%. In the East, data has come, a few papers have published that it could be 20-25% as well, often linked to ABMR. When you have a TMA, you have to deal with it very seriously because it indicates an antibody-mediated rejection and nothing else. So you have to be very, very proactive in treating this ABMR or TMA. It is independent of ISA titers. So somebody has a lower titers can have TMA. Somebody with high titers may not have a TMA. And early diagnosis and prediction is really important. Biopsy may not be possible all the time. Why? Because platelets may be low, the bleeding risk may be higher. So you can't do biopsy most of the times when you see a TMA post-ABO transplant. You got to rely on biological diagnosis like thrombocytopenia, microangiopathic hemolytic anemia, elevated LDH, and so on. So you got to rely on that and then treat with plasmapheresis or eculizumab. Biopsy comes secondary here, and treating TMA becomes more important because the risk of graft loss is as high as 30%. As per this recent data from KI, you can see this is a retrospective multicentric study involving 375 ABO-incompatible transplant. Here the risk of TMA was 6%. Actually, in our data, we have TMA of 12% in whatever 60 cases we have done. So here it's around 6%. You can see TMA histologically 80%, biologically 91%. Treatment is plasmapheresis and eculizumab, and that corner is very important. 30% graft loss unless you treat them. So that's why post-ABO incompatible TMAs are the most dreaded complication. Luckily, we have eculizumab now, and it is becoming more and more affordable. Even in India, a vial of 300 mg costs around 75,000 rupees, and directly if you take it may cost little lesser. Eculizumab, is a monoclonal antibody which acts and inhibits C5a, the complement C5, and that's how preventing the formation of membrane attack complex and so on. So that's how eculizumab acts. So combination of plasmapheresis and eculizumab is a treatment for post-ABO incompatible TMA. So dosage of eculizumab, when you take the complete dosage or the cumulative dose or the total treatment dose what you give, then the cost may be higher. A lot of Western data says that 900 milligram per week for 3 to 4 weeks. That's pretty high on the cost as well as pretty high on the dosage. But in Indian, a lot of case reports are coming where they have used 300 milligram per week for 3 to 4 weeks. We also have used for 3 to 4 cases where we have used 300 milligram per week for 3 to 4 weeks. It is a relatively safe drug with only some pre-medications, and it can be given within half an hour time. Only thing is you got to plan this eculizumab post-plasmapheresis because it is washed off by plasmapheresis sessions. So it is this post-transplant TMA and ABMR post-ABO incompatible transplant is gaining more importance because of more risk of graft loss. Luckily, we have treatment options in the form of plasmapheresis and eculizumab. So to conclude the talk, ABO-IKT is a successful modality of transplant for patients having different blood groups. And if you have a same blood group or if you have a swap option, always better to go with that rather than challenging the immune system, which we know very less as of now. And it helps in increasing the donor pool as high as 30% and increasing the transplantation chances. Understanding immunology and evolution of desensitization protocols have proved more successful rates. And during incompatible transplant, the more you do, the more you learn, and you can have your own protocols. Careful selection of patients is also important. Not every patient is suited for ABO incompatible transplant. Cost is lesser as you compare with dialysis or waiting on the list for a cadaver or a deceased donor transplant program. So also, immunology is something which is not in our hand. You got to pray for the patient and also meditate for ourselves, so that we stay calm and take those right decisions. So with this, I would conclude my talk, and thank you. the dosage of rituximab, what we give is very less, that's about 200 mg. So it is not routinely recommended to monitor, but maybe sometimes when you are using ATG as an induction agent along with rituximab. So, and sometimes recently there is data from East where high titers, they have started using eculizumab also as an induction agent or an adjunctive agent, induction agent. So in such cases, maybe to avoid little over immunosuppression, you can do CD19 monitoring, but routinely it is not recommended.
Any role of bortezomib in resistant cases where you are having a
as
very
a
high
part
titer
of
in spite of the immunoadsorption or plasma exchange like what you had in the first case?
Bortezomib as such would be helpful for the treatment of ABMR and in resistant ABMR, but honestly speaking,
During the preparation period?
no,
pre-transplant.
there is no data on using bortezomib.
Basically to block the premature B cells.
Yeah. I am not aware whether anyone has used, but as far as I know, there is no consensus or any data on using bortezomib as an induction for ABO incompatibility.
Okay. And one more regarding the PT TMA, the post-transplant TMA. Definitely titers is not the good line. We can see patient with a low titers post-transplant having a severe TMA. Basically, in the what is called immunological sink phenomenon can happen, where the antibody titers in the blood may be low, but locally it will be more powerful and causing a severe TMA, thrombotic microangiopathy.
Correct.
Thank you.
Dr. Pathak sir, no, he is giving it for to prevent the bleeding complication. He is substituting whole replacement with FFP. So to prevent the complication, bleeding complications. First time I'm hearing to it will also reduce the antibody, but in neither case it did not reduce the antibody.
It did not.
But I think it will go into, definitely will have implication reducing the risk of bleeding during surgery.
Yes.
That is one thing. Second thing, anyway, eculizumab is available now. Can we do now transplantation for all atypical HUS by giving prophylactic eculizumab, like we give for rituximab before this one? No?
I think
many, because that was hindering to transplantation. As soon as you do transplantation, graft will get rejected.
Yeah.
Can you use as a?
Many centers have started doing that. Only issue here will be post-transplant, how long you will give eculizumab. Probably it would be lifelong. So for that, is the patient affordable, and are we okay to take that risk is the only question. But many centers have started doing for TMA, atypical TMA, particularly atypical HUS. So they have been doing transplants with eculizumab, but continuation of eculizumab is an issue and the cost is an issue.
So you used 300 milligram for 3 to 4.
Yeah, we have used for 3 to 4 cases, and 3 grafts we were able to salvage. 1 we had a graft loss, despite doing all that. So
thank you.
Sir, any absolute split GFR cutoff for choosing the donor kidney in ABOI?
I think it remains the same as the regular compatible transplant.
Because anticipating all the rejection and also TMA and so many other infections, is there any cutoff that you would personally make?
No, I don't think that should determine whether we take a particular donor as a donor or not. I think that criteria should remain same for compatible as well as incompatible. Because the outcome of ABO incompatible transplant at the end of 1 year is almost similar. It's around 90% as you compare to 95%. It is only the initial 1 month or so which differs. After that, the outcome really doesn't differ with a compatible or an incompatible transplant.
Okay, sir. Thanks.
Yeah, we have data, but we are yet to present that. We are having a 3-year graft survival with also a separate wing for these antibodies, ISA agglutinins for anti-A or anti-B, and higher titers, how they flared, lower titers, how they flared. and all that. We are yet to come up with that data. Any other questions I can take, or else? Thank you.
Thank you, Deepak.
Dr. Deepak, that was a very wonderful session. I think most of the doubts were cleared. Thank you very much, sir. I now call upon Dr. Vinod, Consultant CG Fortis, and Mr. Saurabh Dubey, Cluster Head for Agilis Diagnostics, Karnataka, to do the honors for felicitation Dr. Deepak Chitralli. Yeah, sure. Thank you, sir. Thank you, sir. Next is the second panel discussion for the day. The topic being precise and cost-effective immunology workup for kidney transplant, for which I would again call upon Dr. Firoz Aziz. Firoz, sir, from Calcutta. Dr. Girish, HOD Nephrology, MSR Hospital, Bangalore. Dr. Dhananjay Kapadi, HOD and Director, Continental Hospital, Hyderabad. And the moderator would be Dr. Veerabhadra Gupta, Director, Nephrology, Fortis, Nagarbavi.
Good morning, everybody. It's a great opportunity for me to introduce Dr. Firoz, Dr. Dhananjay, and Dr. Girish. They're all placed in a different states. One is from Kerala, Telangana, and Karnataka. They are practicing, but we have a common root. We all are the alumni of IKDRC, which performs more than 500 transplants per year. Already completed 5,000 transplants till date. So they have huge experience during their DM days, as well as they have now the HODs of concerned specific departments in their locality. I welcome them. Today, transplant scenarios, we all want a successful outcome. We don't want any rejections, so that the patient's longevity of graft and graft survival is a main thing. But before that, immunological workup also is very much needed to prevent transplant rejections. So a lot of advances are happening, which puts a lot of cost on the patient's pocket, because the patient has to pay from his pocket. Majority of the insurance doesn't cover all these expenses. Keeping that in mind, we wanted to evaluate the patient who is going for a transplant in a cost-effective manner. Looking into the latest developments in the immunological field, we wanted to take a concerned opinion regarding how and what all the drawbacks of current ongoing tests. So I welcome all the panelists. So first question is to Firoz sir, because Firoz sir has a laboratory which deals with immunological workup. So he may be a better person to give an insight into that. Dr. Firoj, what should be considered the minimal immunological workup before every kidney transplant, irrespective of the center status of the center? Is it like ABO typing, HLA typing, CDC cross-match, flow, PRA, or SAB? And kindly highlight the cost involved in these tests.
Yeah, basically, we being primarily clinicians, and I would see it in a different perspective, from a patient's perspective. Suppose a patient walks into our clinic and says that he would like to do a transplant. Even before we discuss the donor part, suppose he's for a deceased donor enrollment. The first thing that I would like to know is that basically his sensitization status. So one thing that we have to do is some sort of a screening assessment. It could be a mixed antigen screening bead, or it could be a PRA screen. Both are basically conveying the clinician the same message that he's not, either he's a benign guy or a problematic guy. Because as a clinician, 70-75% in India, living donor transplants, primarily we will be dealing with a benign guy, 70-75% time. The 20-25% is going to be a problem, immunologically challenging cases. So that information you can get upfront by just doing a screening or a PRA. So that is one test that we should do. Either it could be a mixed antigen screening or a PRA screening. It gives you the same information. Okay. Then next thing is a cross match. So a patient walks in, I do a screen, and if he has a donor, I do a flow cross match, then I'm sure that he is a transplantable guy. So the conversation starts in that way. Okay. Suppose his screen is something, flag something, or cross match flag something, then he goes to the 20-25% of that patient who needs, some workup. So that, I think that will be the algorithm in which that we have to work. And if you look at the cost, definitely we have to do blood group typing. After blood group, the thing it will be a screening test, then you do a cross match. And complete the game. Once you're going ahead with the transplant, then the HLA typing comes into place and other things come into place. So that will be it. So that will be the clinical algorithm that I think we should follow. Can you elaborate the cost? Because that's the main factor. Okay. So screening cost around like 5,000 to 7,000. Okay. If it's a PRA screen, the PRA gives you some sort of a semi-quantitative value. The mixed antigen screen is just a rough qualitative thing. It's just a yes or no. Yes. But when it comes to PR, it will cost around 10,000. And cross match is again anything between 7,000 to 10,000. So if you're saying a screen and a flow cross match, within 10,000-12,000, you are giving a clear verdict you have an idea like what you are going to deal with. But when it comes to SAB, it is around 30,000 to 50,000. SAB class 1 and class 2 can be done separately. It will like half for class 1 and half for class 2. HLA typing is actually evolved a lot. Now you go to NGS typing, which covers all loci, gives you higher resolution, and is becoming cheaper than SSP and SSOs. So it is around somewhere around like 15 to 20K. It has become more competitive because NGS has cut down the prices a lot. So again, screening between 5,000, if it's a PR around 10,000, SAB 1 and 2 will be around like together 30 to 40, some labs charge based on the hospitals they attend. And HLA typing is around 15 to 20K nowadays.
Thank you. So that means that clinical history is very much relevant so that we can categorize the patient initially itself. So, okay. So Dhananjay sir, can these tests be tailored according to the individual risk? What is your practice like?
Yeah, I agree with what Firoj sir said. First of all, we should look at the sensitizing events of the patient. What is the sensitizing history of this patient, whether he has received a blood transfusion, all those conventional things which we have been taught when we were in nephrology. And one important thing what I wanted to ask Firoj sir myself was, some of the people say that doing a mixed antigen screen or a PRA may not be worthwhile because it is not going to pick up 15 to 20% of the problematic patients which we don't pick up when we do these things, and they end up in rejection. That's why do more sensitive assay like solid antigen bead and skip altogether this screening test. What do you say, sir?
But because we have now the New Delhi people have studied it systematically, and what they have found is a human antibody screen and flow positivity, flow test could cover almost 100%. So we have been using, but okay, it is not as sensitive as single antigen bead is like. But if you look at the representation of the mixed antigen screen beads, it covers our, on a serological level, it covers all our antigens in Indian population. So I don't buy that argument. It is, but if you have, it is just a qualitative test, just like you do like ANA and other tests. If you have some borderline actions, you have to, you have not to belittle it. You might. I think it's not that bad a test that you are going to miss your 30%. It need not be that sensitive as single antigen bead, but single antigen bead comes with its of issues when it's because it's more sensitive. But that's why we'd have to have a screen with a flow cross match, which is also very sensitive, not with a CDC. Okay, then I think we are good.
In my practice, or what usually I do, once we do the risk estimation, we always do the HLA NGS typing, high resolution typing, followed by flow cross match. And I am till now I'm not doing this screening. I usually advise the patients to go for single antigen bead, because transplant is for a lifetime, and as clinicians we shouldn't be just thinking about the finances of the patient. If we do not convince them, that is when they start telling us that it is a problem. Especially I am sitting in a private sector hospital, so in a government sector or other hospital it might be slightly different. So we have to individualize our practice and tailor according to the patient's risk.
Yeah, that means you have to speak to the patient, explain the risks, and pros and cons you need to explain in detail. Next, Dr. Giri sir, where do you think smaller transplant centers should draw the line between essential investigation and desirable investigations?
Thank you for the question, sir. Now, this is a discussion, so definitely I will keep it more open. Now, smaller transplant centers, should they be more vigilant? Because they are handling very less people, so they do not have that kind of a facility. So maybe they need to do more rather than do less. But if at all we are looking at the financial viability, then it will be something like what is the most basic thing that needs to be done. And if at all we are looking at what's the most basic thing that needs to be done, here are two things again we need to consider. One is the patient outcome and the legal requirements. So both the things we'll have to keep into account whenever we select what is the minimum most. And we are all from the era, we know, when there was only CDC. And still we know that is something which we can't neglect, CDC, though all the other things are there. So coming to the basic things. So CDC definitely will give us what are the antibodies that are actually going to be pathogenic. And yes, definitely we cannot do away with the CDC. Then HLA typing, so most of the times if it is a legal requirement, yes, otherwise we can actually do away with the HLA typing if it is not legally required. If at all it's a spousal transplant, we actually do not require to do a HLA typing. We can actually do away with it. And these days, so now that the DSA is available, as Dr. Firoz has already told, it's become more affordable. So it adds value to just do a DSA screening at least, so that we know where we stand. I feel this is the minimum most we should be looking at, if at all we are looking at the financial restricted scenario.
Can I add a little bit?
Yeah.
Actually, just I think if we become patient-centric, just like Deepak was presenting his ABI data, it was basically, he was, if you know, it was an experience. You evolve as you go but through your patients. So basically, it need not be like, you should not limit, the perspective should not be from a center standpoint, if it is a patient standpoint. So it might be, you have definitely patients at the benign end of the spectrum where you'll be comfortable to start with. And nowadays, we are in a place where, if you like, Sruthi and myself, we have started this around 15 years ago. Now, there are, you can just send a mail, shoot a mail, and, you can ask anyone. There are experts across the, India right now. You can just ask, that is a patient-centric, what Deepak did, he rang his friends, what sort of plasma you have to do. So it is a journey that it is not a center-specific. I think if you make it like patient-centric, then things will be ease out, and all these things will become easy. Now the problem is that now I send HLA typing to one lab, I get some information, and I as a clinician send screening to some other lab, and I have a history from the patient. This is not meeting, you are not connecting the dots, and unnecessarily we are spending the money. So we have an algorithm in place, you work through your patient, then all these tests will align according to our this thing. That's my take.
Coming to you only. So with the increasing availability of Luminex technology, many centers perform DSA testing in every transplant candidate. Do you believe this is justified? Since you worked in Terasaki institution, so Luminex was first introduced by them. Can you throw some light on that?
Yeah, actually Luminex is a very wonderful tool. It has revolutionized transplant immunology that we are discussing today, but it comes with its pluses and minuses. That is it. So, I mean, just like we discussed during the initial discussion with Sunit ma'am, and it is a very sensitive tool. We have problems where Luminex has given up some readouts and we are stuck with that. So it's a wonderful tool. It has revolutionized transplant. The way the virtual is being done, the way paired kidney exchange is done is virtually impossible without Luminex platform. So it's a wonderful tool. Every transplanter should have an access to it and a familiarity with it. That would be my final take.
So, Dhananjay sir, should the DSA testing become universal or should it be a selective investigation? And how do you interpret low-level DSAs?
So as sir already told, the DSA by Luminex technology is the superstar. Like it is very highly sensitive, picking up very low-level DSAs also, which we were not picking up before. So that is why it has revolutionized the field. Now whether it should become universal, as sir said, it becomes
too much of
it has its own pros and cons. For example, we need to know like what is the center specific threshold, what they have kept, what is its positive and negative, and we also need to understand what is that prozone phenomena and whether it is C1q binding, all those things. So we need to interpret it with a lot of caution, because earlier people used to do transplants only with CDC, and they even now when we speak to our elders who are pioneers, they always say CDC works best. Why do you do all these things? So, but we need to understand after couple of years of transplant, these, if they have DSA, those patients will not be doing well. So it is worthwhile to do this, and that's what is my take.
There is a lot of confusion regarding the MFI values. So, Giri sir, do you kind of consider what is the cutoff and what is the implications of MFI values in the transplant?
Yeah, so like how to interpret a low-level DSA, or like how should we look at the MFI values? Now, once we are looking at DSA, this is the most important thing, what we'll be considering, the MFI values. I am sure there are so many prominent nephrologists here, and we would have never transplanted anyone with a high MFI value. So without doing some desensitization program, unless in some very rare cases. But I'm sure that everyone would have encountered some or the other rejections even in these patients who had a low level DSS too. So where do we draw the line? So these tests are only here to give us some guidance. So just because the DSA level is low doesn't mean that he is not going to have a rejection. It's just that the chances are low. The same thing for the other question. So should we be deferring a transplant solely based on the MFI values? Might not be. We will have to look at the patient. Dr. Firoz made it very clear that it's the individualization that's more important, and we'll have to take, if at all it's a high-risk patient, there are other ways to look at it. So we can look at the flow cross-match, we can look at the CDC, and we can look at the single bead antigen, how much of donor specificity is there. Based upon that, we can have come to a conclusion whether to go ahead with the transplanting of that particular patient, or whether he will require some more desensitization procedure before proceeding with the transplant. So yes, there are different center-specific cutoff values between the class 1 and class 2, and it depends. So usually 1,000 and 2,000 is what is taken. But there are people who take like up to 5,000 also. It shouldn't be much of a concern. But then a universal consensus is not there. This is what I believe. Maybe Dr. Firoz can throw more light on that. But what I feel is this. This is a discussion, again, I am stressing. Just because it is low level doesn't mean that he's not going to have a rejection, or just because it is high level doesn't mean that he cannot be transplanted. So we'll have to individualize. But having this basic knowledge of what should be the cutoff will definitely help in making a decision.
Coming to the virtual cross matching, it is actually becoming more popular nowadays. So do you think it is ready to replace conventional cross matching, or it is only advisable in a selected patients?
Okay, actually virtual cross match is basically just like Sunit told in the morning. You have two set of data. You have the antibody data and you have the HLA data. Again, I would like to make it very clear. Again, let us be very patient centric. Okay, by virtual cross match, what you are trying to infer is you are trying to predict like how your physical cross match is going to be.
Correct.
Okay, so virtual cross match makes sense if your patient has got a lot of antibodies and the particular donor in the frame is something that is question mark. That is only a scenario. So if virtual cross match has a role in, suppose I am a sensitized patient. You know, I find that certain antigens might be okay for me from a donor perspective. So in a broadly sensitized patients, I cannot waste my time every time doing a flow cross match 7,000 rupees and see whether it is working. So virtually looking at helps to narrow down my donor options, and then you have to do a physical cross match. So in the previous time, whatever like low level DSA, at the end of the day for a clinician, what is the gatekeeper? For in India, for a living donor program, it is still the flow cross match or the cross match.
Correct.
And flow is, outperforms CDC. So I think to guide your flow cross match, limiting your flow cross match, just utilizing it, I think virtual cross match can guide you, and that's it. You cannot take further with just doing a virtual negative. You cannot go. I mean, even in certain in India, certain big programs are doing deceased donor transplant using virtual cross match.
Correct.
But the problem there is that you are denying transplants for many of these patients because virtually you are calling them positive.
Correct.
For in India, a donor's case situation, we cannot deny a transplant. Suppose I am waitlist number 1 in a particular hospital, I am denied because I have a funny antibody out there. So it's injustice.
Yeah, that was my next question, because we have several patients on disease cadaver transplant list. Those who are coming, they are coming cross-match positive literally many times. So we have recently requested Dr. Mathur sir for doing a virtual cross-match. So that's probably, based on that, probably we can allocate. At least patient will feel that they have called us. Otherwise, it's a frustrating situation for us to really explain the things to the relatives.
I think donor HLA typing, deceased donor can be done, should be done, because we have labs across, like Bangalore. I think it should be done.
Next to Dhananjay sir, do you think, what are the advantages, disadvantages? Actually, Dr. Firoz sir told. How should centers without access to advanced immunology laboratories approach this issue, sir?
Sir, what is our my take is, we are employing this virtual cross match only in case of an highly sensitized patient who is waiting on transplant in a deceased donor program. So nowadays we have Luminex where they are doing low resolution HLAs within 6 to 8 hours of time. So a donor who can be maintained for 24 to 48 hours, if it is within center or a nearby center, you can send the sample for donor HLA typing, low resolution HLA typing. Keep your single antigen bead results ready. Do the virtual cross match, because these patients are highly sensitized and they might have low level of DSA which may come when we do a physical cross match. So retest the physical cross match just near to the time of transplant, and then you can go ahead. That is how it is very advantageous in those circumstances. For doing for everybody, it may not be good. And for selecting among multiple donors, if brother, sister, both of them come forward for donation, who is better, those things also can be better understood by this. So this is the advantage. Disadvantage, Firoz sir already has explained.
Yeah, coming to the applet matching and HLA typing, actually Dr. Firoz gave a wonderful lecture. So they are actually becoming popular nowadays. So do you believe these technologies will become standard of practice over the next decade, or they are likely to remain confined to high volume transplant centers?
I think molecular HLA typing is the norm because serological typing is no more done. Now everything is confining to NGS, and NGS, newer NGS platforms are there where it's very easy, short turnover within 24 hours, low numbers can be run. So NGS HLA typing is going to be the norm, and all typing is going to be that. And the main issue many times what we face is that the clinicians are hesitant to do HLA typing for all their patients. So there, the thing is that, India being a very highly, close, we take, Kannadigas marry in Kannadigas and Malayalis marry in Malayalis. So we pretty much, we have a lot of, crosstalk in our communities HLA. So we find husband and wife sharing same HLAs. We see, zero antigen mismatches between spouses in class 2, which is a phenomenal advantage. I think HLA typing, high resolution, 11 loci should be the norm going forward for any Indian transplant. Everybody should do that. So we get many of this information. Having a zero antigen mismatch mother might be not a half haplomatch mother for a different person. So these are opportunities where we can tailor down our immunosuppression, unnecessarily bombard them with things. So I think we should put our money on HLA typing whatsoever, irrespective of the relation and this thing. Applet matching, just I told you, there are, in an era where you have single antigen bead and Luminex, and this is, you are not spending any extra money to do an applet. All thing that you put this data, feed it in the software, give you some information, and if it helps in analyzing your antibody or in circumventing your memory response or finding a donor for a sensitized patient, these 3 sets, I think it should be used.
Coming to Dr. Girish, sir. So every test we advise adds on to the cost of the transplantation. So how do you ensure that we are ordering investigation that genuinely improve the patient outcomes rather than simply increasing the cost?
Sir, you have given me a very tough question for which there is no clear-cut answer.
Just
this is like cost effectiveness versus the outcomes. So how do we balance the both? And there is no easy answer for this. But yes, we already discussed the first question, what is the minimum basic? Then adding to that, depending upon the risk of the patient, so we all know that we usually categorize them low risk, intermediate risk or high risk. So based upon that, we will have to select the next set of tests, which will give the highest yield. So, and if at all we are expecting a patient to be highly sensitized, maybe we can go for the highest test rather than going in between tests. So that way, maybe we can remove some test which we know by the patient profile that it's going to be positive and go for the last test directly. So this might help us in reducing some of the costs, but yes, it all depends upon tailoring to the patient requirement and the risk appetite of the doctor and also of the patient. And what is that outcome that we are looking at based upon our own experiences.
That means you are implying that you should stratify the patient. The next question is that, like, can we develop differential immunological working protocols for low risk, intermediate risk, or highly sensitized recipient instead of following a uniform approach?
Yeah, I think this is just a continuation of the previous question. So we definitely should be having a different immunological workup protocol. So if at all it's a very low risk, so including the first transplant that was done between an identical donor, we did not do all the set of tests which are required. So we can just go ahead and transplant them with a single test. But whenever it is a highly sensitized patient, Dr. Dhananjay was telling, if at all he has received a lot of blood transfusions, whether it's a second transplant, in all those conditions, we will have to be all the more vigilant. We definitely cannot neglect that patient and push him into something which he might not recover from. So it is definitely essential that we have a protocol, and yes, things are making one more, this is the discussion we are having itself is to implement these things. So I think this is happening slowly.
Yeah, moving to the DSA, already we discussed. Should India move towards a standardized protocol regarding DSA interpretation, MFI thresholds, or cross-match reporting and acceptable criteria? Firoz Bhai.
In principle, yes, but it's not easy. The thing is that the American Society of Histocompatible Immunology, that is the big like ASN, and so what they have done has that, ASHI certified labs had some sort of a comparative study. They follow the same protocol, everything, but center to center in MFI reporting, they could see like 40% variation. One center reporting 6,000, others reporting 10,000. That's why that's a problem where, I mean, this is basically a test, though there's a machine, there's a man who has to do a test, dilution, cell washing, everything can have variations. So it is bound to be variable. That's why, again, I underline the fact that we have to be patient-centric. Sorry for being repetitive many times. Then this will evolve slowly. If you look at read CPC in NEJM, beyond level they do PT scan, everything. So there is one subpopulation where you can, little. So slowly the risk escalates, when patients become complex. At that time, all these tests will have to have a place. So I think let us be patient-centric. And one thing that we can do as a transplant community is that, now you have an expert, Sunit ma'am here, So she should be a part of the transplant team. It's a discussion just like we had with pathologists. Okay, so it will be mutually benefit for everybody. So now previously, 5 years before, when me and Sudhi were starting our career here, used to send one to one lab, other to another lab, and at the end of the day, we are not connecting dots. I think you have a full setup lab here. You people should have an algorithm which works for you people. Then madam will have her cutoff. She said that, okay, though the flow was negative, I'm not comfortable with that flow. It's not like no test in transplant immunology is black or white. So there's a lot of gray areas, it's full of gray areas. So unless and until you work through your this thing, you'll have your own protocol. Fortis will have your own protocol. I mean, other Manipal will have its own. And I think that will be the final take. Though we try, whatever we try to have a uniform, it is not going to happen.
Thank you. So, artificial intelligence is rapidly entering into clinical medicine. So, do you foresee AI assisting in donor-recipient matching, rejection prediction, antibody interpretation, or individualized immunosuppression planning? Dhananjay sir, you are from Hyderabad, AI techie savvy, so please answer this.
No, sir, I am not AI techie savvy. But anyway, morning Firoz sir was presenting an excellent talk on applet and applet matching. It is nothing but game of the software. So the software does the three-dimensional architecture of these antigens and sees where is the applet which our immune system recognizes. So it is nothing but an AI tool or a software tool. So it has resulted in, sir already told, lot of increase in the donor pool in terms of more number of swab transplants happening. So we already know by doing virtual cross match, these patients are at higher risk of developing rejection. So the rejection prediction is also a reality as of now. Antibody interpretation, HLA fusion software which is there, it is telling whether the antibody though it is a semi-quantitative assay, it is able to tell us it is going to have an harmful effect or not. So already we are seeing that whether all this can be integrated and made into a single tool, that remains to be seen.
Any comments, sir? Girish sir and
not much, but now AI is everywhere. So it is just the level of trust that we have to develop in AI. So for a simple Google, we are already using AI. We have just left Google beyond, so now we are using AI. So to prepare a presentation, we are using AI. So it's just a matter of time that we start using it to treat our patients. So how do we use it justifiably and without harming the patient is the only question. Because the only advantage that we doctors have not being replaced by AI is that personal touch and the individualization that we are still having. So AI is still not so very evolved so that we can trust it entirely to make a decision regarding the patient. But yes, it is evolving. In the time to come, we don't know when, 1 year, 5 years, 10 years, 25 years. It will definitely be there in managing everything, but right now is not the time.
So, Firoz bhai, are C1Q and C3D assays worth the additional cost in some difficult cases?
Actually, I'm not a strong believer of C1Q or C3D because, where I was taught, they were not doing this thing and they were not believers of it. So that's why I might have my own biases, but I think a good, so again, I think the communication with the patient is very important, okay? So I will be more comfortable if I say a sensitized patient is coming and I find that the particular donor that he is flow cross-match positive. This thing stops there. And if he has a DSA, I stop my discussion there. I go for a paired kidney transplant. So I don't spend my money on C1Q and C3Ds. And of the biomarkers, I think cell-free DNA is what is something that is offering some hope.
We are running short of time.
Yeah, I understand.
So we gained a lot of information. Thanks all the panelists. So the thing more take-home message is immunological evaluation should be evidence-based and patient-centric. Based on that, we will further progress in further evaluation. Second, it's a more advanced test and more artificial intelligence and the other things doesn't mean that they are very accurate. As a transplant, to have a precision, we should involve nephrology community, surgical community, as well as immunologists and pathologists also. With that, it's a teamwork. With the teamwork only, we can achieve a greater success. With that, I will conclude my talk. If any questions, please, I will open the session. Thank you, all the panelists.
Thank you, sir.
Thank you, sir. Please be on the stage. Can I call upon Dr. Manjunath S. Fortis? Mallikarjun sir is there. Please come on stage, sir. Please give it to Dr. Dhananjay Kapadi, sir. Can I call upon Dr. Sridhar, HOD INU? Please come on stage, sir. Can you please give it to Dr. Girish? Dr. Suraksha, please come on stage. She's the lab head of People Tree Yashwantpur. To Dr. Veerbhadra Gupta, sir. Thank you, sir. We'll move on to the next session. I call upon Dr. Ashwini to do the introduction. Thank you, everybody.
Our next speaker for the session is Dr. Shruti Tapiawala. Madam is a consultant nephrologist and transplant physician, transplant immunologist, fellow American Society of Transplantation, Glen Angeles Hospital, Mumbai. She'll be giving her insights on immunological assessment and treatment strategies in sensitized recipients. Welcome, ma'am.
So, good morning, everyone. Thank you to the organizers for inviting me to such a nice meeting. It's a good meeting between the urologists and the nephrologists. Bangalore, just check. Go to the list. No? List. Bangalore, it is called. Not this. So we've had very nice sessions since morning, very insightful. A lot of discussions have gone on for difficult cases. In our country, transplant immunology is still building, I should say. Since the year 2000, there has been a lot of advance in the field of transplant immunology, where we can now do precision diagnostics and precision immunosuppression for patients, and hence avoid infections and rejections. However, even with all this, our long-term outcomes have not improved. All over the world, short-term outcomes are much better. So we need to do better when we are monitoring and maintaining patients. Today I'm going to speak to you on sensitized recipients, which is a burning topic, because whoever nephrologist is there in this August gathering will know that today every alternate patient you see is sensitized because they've had some sensitizing events in the past, like pregnancies, transfusions, transplants. People are coming for second, third transplants because they must have been transplanted long back, and now the first transplant is failing and they've come for second or third transplant. So I'll present to you few of my cases which I've handled very carefully, individualized things, because in our country we cannot compare ourselves to the West. We cannot have that much economy, we cannot have all those drugs, we cannot have all those monitorings which they do. So we have to do somewhere in between and try to do the best for our patients. Like being emphasized from morning, be patient-centric. I also have a lab, I run a lab of transplant immunology, but that doesn't mean I use all the investigations for everyone. Let me start with a case. 51-year-old lady, she herself is a doctor, who was suffering from end-stage kidney disease and was on maintenance dialysis since 3 years. She presented to my outpatient department in Jan 2017 for inability to get renal transplantation due to cross-match positive status with her family donor, her spouse. Her husband, also a doctor, blood group matched with her, O positive. She had 2 pregnancies with this donor. Blood transfusions done a few years ago when she started on dialysis. Someone told her that rather to take blood from your own family rather than taking from outside. So they actually did a donor-directed transfusion to the patient, not knowing she's going to be the donor, but the husband donated, it was processed, and that blood was given to her. So she was sensitized with pregnancy, she was sensitized with the blood of the same donor, and she was not able to get the transplant. So she further added that I have no other donor. She had 2 children who were just entering medical school, and she was like, I have no other donor, I don't know what else to do. So we know that a positive cross-match is a definite no-no, because it indirectly tells you that there are donor-specific antibodies to the titer of more than 20,000-30,000 in this individual, which is lysing the donor cells as soon as the serum is incubated with those donor cells. It's like a mini transplant done in the lab. Now to show you this schema, that these are the type of antibodies which we should be scared of as nephrologists and as urologists. There are centers where urologists also work equally for transplant immunology like the nephrologists, so it's equally important for both. At the time of transplant, you should be worried about preformed DSAs. That means the DSAs which are already circulating in the patient circulation, and this can be because of the sensitizing events like pregnancies, transfusions, previous transplantations. After transplantation, you should be scared about a memory response, about any HLA antibody which was exposed, or HLA antigen which was exposed to the patient, which is specific to the immunizer or the donor at this point of time, because the memory response will kick in at about 8 to 9 days and a month, and you will get an ABMR at that time. So you should be worried about preformed antibodies and memory response at the time of transplant. Post-transplant, if you look at the timeline, you should be worried about de novo DSAs. You should be worried about the development of de novo DSAs, and the de novo DSAs will form only when your immunosuppression reduces or you have a lot of applet mismatches like it was elegantly discussed today morning. And these, when you remove the veil of immunosuppression and your immune system in the recipient is looking at the new graft which is there in the system, you will start forming antibodies. So de novo DSAs come into the picture when there is non-adherence, when there's reduction of immunosuppression due to some infections or any other reason why the physician has withdrawn the immunosuppression, or on purpose that you think that, oh, the patient is doing well, let me reduce the immunosuppression. These are the reasons why you develop de novo DSAs. The last reason can be there was a very antigenic applet, and even a little reduction in immunosuppression has caused a de novo DSA to come in, and that can lead to acute antibody-mediated rejections or chronic antibody-mediated rejections, which eventually lead you to an allograft failure. Historically, the presence of these is and a positive cross-match is contraindicated, and this can lead to transplant failure. So cross-match positives have been avoided in the past. The consequence of this high degree of sensitization is that many of the patients today will have positive cross matches. They will not be able to go through transplantation. They will be waiting for a long on the waiting list. They'll be dialysis dependent, vascular access failures, and you lose these patients just for the want of getting a transplant done. And transplant anyway is the best option for any patient who has an end stage organ failure, be it kidney, be it heart, be it lungs, be it anything. And the growing shortage over the last 2 decades has stimulated efforts to facilitate the transplantation between incompatible pairs, like ABO incompatible we just discussed. So that is one effort to expand the donor pool. So now for sensitized recipients also you need to find ways and means to expand donor pools to try and get them transplanted to the lowest immunological risk and the best possible outcomes. So about 85% or greater panel reactive antibodies are termed as highly sensitized. So in my practice, what I have tried to calculate, and I'm sure it is the same in everyone's practice, that you see that out of the 100 patients you want to transplant, 11 to 12% are sensitized. Remaining are not sensitized. So you just do a PRA screen, it's negative, just go ahead. Unless there's a sensitizing event, then you repeat a PRA and you see. 11 to 15% you will find that there are some antibodies, and out of this 5% will be such where they have more than 80% PRA and they're very difficult to handle from the transplant point of view. So what is the assessment usually required? A thorough history. A recommendation to define a non-sensitized patient. Validate the patient history for lack of sensitizing events. Confirm that a patient is non-sensitized using a solid phase assay. By solid phase assay, I mean a PRA screen or a single antigen bead assay where you can define that this patient actually does not have any HLA antibodies. It would be advisable to do 2 PRA screens if the patient is going to wait for 6 months before the transplant, because if there was a memory response or if there was some antibody which was waxing or waning in the system, then you can pick it up. Because when you do an SAB or a solid phase assays, it is a snapshot of that time. That does not tell you that all the life the patient had antibodies or no. You will confirm it pre-transplant with a CDC and a flow cross match. Yes, from the previous discussions, we have noted that CDC we cannot get away with at present point of time, but there are institutions where now we are trying to just transit away from the CDC. CDC is a solid test, but it has its own fallacies. So if you have a good flow cross match in your lab, you can easily do away with the CDC, and flow cross match will cost you a little bit more, 6,000 to 8,000 in comparison to a CDC which is 3 to 4,000. But it will be more sensitive, more robust, and if it is standardized, you can easily do away with CDC. So a physical cross-match and a solid phase assay being negative should be your defining level for a non-sensitized status. We have come a long way from 1969 when the CDC cross-match was innovated by Dr. Paul Terasaki and Dr. Patel. After that, there have been a lot of nuances in the CDC cross-match. You have had AHG additions, you have had dilutions, you have had addition of DTT, all those things done, but CDC still remains a little inferior to the flow cross match. 1982, the flow cross match came in to give us more sensitive and objective assays to identify if there was a donor-specific antibody causing the flow cross match to be positive. And then it was realized that even flow was dependent on a viable cell, which in the case of a deceased donor can be a little difficult. So solid phase assays came in, which is the inert bead based assays. They are factory made beads which are inert, and they are coated with HLA cultured cell lines of antigens, and these are then stuck onto these beads in a particular density, and then they are processed further to give you a panel reactive antibody or a single antigen bead. A panel reactive antibody is nothing but a bead which has multiple antigens attached to it. Class 1 is a separate bead set, class 2 is a separate bead set, and you get an answer yes or no. It's like our CMV qualitative assay which we do for all our patients when we suspect CMV. You're not going to give a quantitative assay directly. You're going to say, I want to understand whether this patient has CMV, yes or no. So you will do a qualitative assay. So PRA is a qualitative assay for you which gauges the immunity or your immune risk of that patient towards the population. If the PRA is positive, then you can go to the higher level like a single antigen bead assay where you can identify which antigen is positive, and then you can check if that antigen is available on the donor and your DSA is positive. So as simple as that, the algorithm goes like that. Then there are many nuances whether that antigen which has come positive is really pathogenic, not pathogenic, they are antigenic, they are not antigenic, they are complement binding, non-complement binding. So this is the hierarchy of the system we follow. So to a sensitized patient, what would you want to assess? You want to optimize the detection of any low titer or high titer anti-HLA antibodies in the serum using a sensitized solid phase, sensitive solid phase assay. Monitoring should include both evaluation of class 1 and class 2 HLA antibodies and to all the antigens which the donor or the donors would have. A cross-match test should be performed before the transplantation using a minimum of an enhanced CDC technique. Minimum of. I would suggest flow, but this is the international recommendation. The final cross-match technique should be equal sensitivity to solid phase assays used to screen for the presence of HLA antibody, which means a flow cross-match. A B-cell cross-match should be included in the final cross-match because a B-cell cross-match, like previously thought, is not redundant. It is an important part because it picks up low titer class 1 antibodies and class 2 antibodies. So B is a very sensitive test and it should be included. So all the CDC cross matches should have T cell, B cell, allo, auto. It should have a DTT. It should have a pronase if Ritux was used in the patient. So that you are not confused at any point of time, and it is a jigsaw puzzle that you have an HLA typing, you have a single antigen bead assay, you have a physical cross-match in the form of a CDC or a flow, and you can put everything together and understand if this patient is sensitized to this particular donor. Peak sera should be included in the final cross-match. Now this concept India does not follow. I do follow in my lab because the day I started the lab 10 years ago, I decided that I will have a freezer where all the samples at all the point of times will be stored so that anytime there's a sensitized patient going through a transplant, I will have at least 10 sera to cross-match from back. So I know if there is any memory response which is possible. And peak sera is a sera where you have the maximum number of antibodies in that serum. So when you assess the sera at particular intervals of time, you will be able to pinpoint one particular serum where there were a lot of antibodies. And then because the immune system went quiescent, the antibodies reduced in the blood. So remember, when you see very low amount of antibodies in a serum, that doesn't mean that the previous antibodies just went away. They are hiding in the memory system and they will be re-challenged as soon as the graft is put in with those particular antigens. So peak sera is important. There is an engaged working group from the ESOT where they have categorized the sensitized patients. So category 1 is day 0 where you have DSA with a positive CDC, the highest risk. Category 2 is day 0 of transplant, you have DSA with a positive flow, but a negative CDC. That means you have an MFI of between 10 to 15,000. Category 3, you have a day 0 DSA with a negative flow and a negative CDC. So you are only VXM positive. And category 4 is where you have absence of day 0 DSA but a potential of a cellular memory coming back. So if my peak sera had something positive but today it's negative, then it goes into category 4. You immune stratify these sensitized patients in this way so that you can decide what immunosuppression you want to use. Now what happened to our case? In our case, this is the donor and the recipient typing. Their CDC was positive, flow was positive. PRA for class 1 was positive, PRA for class 2 was negative. So we did a single antigen bead assay for class 1, and you can see that B35 is a donor-specific antibody with a reasonable MFI, which is giving you the cross-match, which is positive. So here I have a patient where the husband is the donor, she's sensitized to this person with positive physical cross-matches, which makes her go into a category 1, right? So now this is the highest risk. Okay, so what options do I have? I have the option of a living donor paired exchange, which is an acceptable mismatch, which I'll show in some way. And we have the option of desensitization. So I actually put it to both of them. Luckily, they were doctors, so it was very easy for me to explain to them that yes, I can do plasma exchange, I can give you, and this was 2017. I told them plasma exchange, Ritux, IVIG, we will go ahead with this. I said immediately post-transplant, nothing will happen because I will remove everything. But at 8 days, 10 days, 1 month, I'm expecting an ABMR because this is not going to keep quiet. So I said, you have to decide whether you are desperate to get a transplant but have a bad outcome, or you're really ready to wait and I can tell you what else to do. Now, from desensitization point of view, we have a lot of new drugs which have come in. So in living donor transplant, you have all the time to prime the recipient. You give IVIGs, you give plasma exchanges, you can give Ritux, and you can wait for the antibodies to come down. You can wait for the cross-match to turn negative. But in a deceased donor, you have to attenuate the humoral response. So if the person is first on the waiting list, then you will have to start 3 months prior, you have to give rituximab, you'll have to give some cycles of IVIG. You might have to do a plex pre-transplant if you know that the VXM with this donor is positive. But in a deceased donor case, you would not want to go ahead with a flow positive or a CDC positive. So that would totally contraindicate the transplant. But with a VXM positive, you might still want to try with the desensitization. Having said that, desensitization has come a long way in the world. You can see that we started with conventional therapies, IVIG, desensitization, and since the year 2000, when all these new technologies came in, we got Ritux, we got the complement inhibitors, we got the ABOI and HLA desensitization. There are columns available now to absorb HLA antibodies. We saw that columns are available for ABO antibodies also. You can use eculizumab, bortezomib around the transplant. Obinutuzumab has also been used in a few trials. Clazakizumab has a good outcome, which I will show you in the next paper. Tocilizumab and imlifidase. Imlifidase has been used a lot in America now. Dr. Stan Jordan's group is using it. But the main problem is the rebound of antibodies. So what they do is that they team it up with plasma exchange. So they use imlifidase, they know that a rebound is going to happen, and they're going to then team it up with plasma exchange, and they will desensitize with clazakizumab and imlifidase. Post-transplant, from 20 to 2025, there is CAR T-cell therapy. There's a lot of things coming which are targeted, but I do not know when they will enter our country, and they're horrendously costly. This is the paper on imlifidase, that there were many successfully transplanted individuals who were highly sensitized, but the only issue they saw was antibody-mediated rejection in the first few weeks after transplant, which of course they had to intensively treat at that point of time. Imlifidase just now is not available in our country, but even when it is available, I'm not sure how much we are going to be able to use it, because we will risk our patients to infections, because post-imlifidase, when there's a rebound, you will be using a lot of immunosuppression. These are the studies with clazakizumab, and Dr. Stan Jordan has said that he could give it in place of rituximab, and many patients had a reduction in the TRA, and there was a significant increase in the Tregs and the Breg cells. This is very important because T regulatory and the B regulatory cells are important in controlling the immune response and stopping any rejection which is ongoing. And antibody rejections happened only in 3 patients out of the 20 patients who underwent the transplant. So in general, in Dr. Stan Jordan's group, this is a study which summarized everything, which said that a retrospective analysis of factors which predicted the antibody-mediated rejection in kidney transplant recipients who were desensitized. These were flow positive and DSA positive, and some were flow negative and DSA negative. But everyone was a flow negative at the time of transplant because they desensitized. So you find a score of 10 if your MFI of the DSA is more than 10,000. Moderate risk, 0.5 if your DSA is 5,000 to 9,000. And a weak DSA if your DSA MFI is 2,500 to 5,000. So if you add these and your score is 17, then you are considered to be a very high risk of antibody-mediated rejection despite the desensitization protocol with imlifidase, with clazakizumab, and with all the new drugs they have. Despite the success, the AMR remains a problem. Even after desensitization, the rate of AMR was as high as 29% in the CPRA group of 99 to 100%. This is likely due to 44% having a flow cross-match positive and DSA positive at the time of transplant, and 80% having previous transplants. This is the type of patients we sometimes see in our clinics. These patients are highly likely to have a memory B cell response, and hence clazakizumab was used. And in these patients, when antibody-mediated rejections happened, tocilizumab was used, and that seemed to help the rejection. So this is an algorithm for desensitization given by Dr. Jordan's group and Dr. Sethi, where they have tried to see if a successful desensitization happens in few individuals where you have a low MFI of DSA and the risk score is less than 17. If they cannot, then they push these patients into living donor paired kidney exchange algorithm. So simply doing a CDC and a flow cross match and a single antigen bead assay will risk stratify these patients. You try the desensitization, and if it doesn't happen or your RIS score is more than 17, they directly push these patients to living donor paired exchange. So desensitization protocols are not for everyone. Some antigens are really very strong and they don't allow you to desensitize, like some ABO titers which never come down. So there are some refractory sensitivities, there are some antigens or applets which are really strong. There are some patients who really will not get desensitized, and then we are risking these patients to infections, tuberculosis, BKV, CMV in our country, and of course the cost is horrendous. Out of your 100 patients, maybe one patient will be like that Doctor Saab, mere paas paisa hai, ab karo. I don't find patients, because by the time they land up with end-stage kidney disease and come to us, they've already spent a lot of money. And then at transplant, if you are looking at 25, 30 or 40 lakhs, then what remains for post-monitoring and post-troubleshooting? So we have to be very, very practical with our patient group, especially since we do not have universal health care. So the second option is that you accept the antibodies. So what is the difference between the two is, when you are trying to desensitize, you are challenging the body that I will attempt to break your immune system. I will attempt to remove the antibodies which are coming in my way. In the second part, we are trying to go with the body. We are trying to say, okay, I acknowledge that you have antibodies. I acknowledge that I cannot face you. I'm going to bypass you. Leave them as it is. So you accept that the patient is sensitized. Come on terms with the situation. So what is the practice in the Western countries? Because they all have universal healthcare and they are wasting a lot of economy on sensitized patients, because at the desensitization, at the transplant and post-transplant, there's a lot of economic usage burden which increases, because they have IVIG, they have plexus, they have SAB monitorings. So they are all now advocating to go for living donor paired kidney exchange. And how was it being done initially? Initially, it was a trial and an error method, because they did not have all the sophisticated tests which we have now. So they would do a sera bank, which would then test a cross-match with each and every donor which comes for that patient, and then they would try to find a cross-match negative donor. Now, this was a trial and error method, which sometimes even Indian doctors are doing, ki chalo iske saath cross-match kar lo, iske saath cross-match kar lo, but that really is not the answer. Now you have single antigen bead assay, where, like Dr. Firoz rightly said, single antigen bead assay can predict your physical cross-match. Use it, especially for the sensitized recipients, because that will save your money and that will save the patient from going for repeated cross-matches. So the basis is define the HLA antigens toward which the patient did never make any HLA antibodies, and use this knowledge for donor selection. Look at the HLA type and then try to look at the recipient SAB. So you make a list of unacceptable antigens. So if you have a list of HLA antibodies against whom you know that there are antibodies, you make a list of them. So you know that the remaining are the list of antigens which you can give to the patient. And here we like to add the cross-reactive epitope groups. Like if it is B7, I know B7 is big Craig. If there's a B7 antibody, I will avoid that entire antigen family in the donor. So I will make a list of acceptable antigens and unacceptable antigens. And that is what makes it an acceptable mismatch. And Eurotransplant has adopted this since the early 1980s, where they used eprets and triplets to match. And they found that the people who had acceptable mismatch, the first line in the graft, had the most superior survival. Because at the deceased donor allocation, they were using this knowledge to assign acceptable mismatches to the recipients. And this is the algorithm. It is where if you just see the triangle, there is a virtual cross match, there is an acceptable mismatch, and there is a CPRA. So I told you, you have to make a list of avoidable antigens. You make a list of the patient's self-antigens, you add them, minus it from the total antigens, you will get a list of acceptable antigens. That is as simple as that. And whichever donor has those antigens, you can accept. And it has been gradually increasing in all the countries, and the outcomes with the acceptable mismatch program, if you see the blue line, is doing the best, despite them being very sensitized, versus when you transplant them with a PRA which is high across their own donor. So this is a win-win situation for the transplant professionals, for the patients, and for the long-term outcome of the patient. So what did we do with our patients? With our patient, she waited for at least 2 years till I could find a proper donor for her. And it was a fisherman who came across to me from Ratnagiri, and he had his mother who was ABO incompatible with him. And he said, I don't have the finances to go through an ABO incompatible transplant. Lo and behold, that mother of the second donor matched with my patient as an acceptably mismatched donor, HLA compatible, but she became ABO incompatible in that bargain. And the patient's husband was O positive who could give to the fisherman, and the second pair went ahead with an ABO compatible transplant, and the first pair went ahead with an ABO incompatible but an HLA compatible transplant. The titer was 1 in 256, a basic simple Ritux 200 mg, Simulect on induction for both the patients, and they are still doing well. So when you reduce the immunological risk, you don't need to shoot with a very high immunosuppression, because you know there's nothing which can come and harm the allograft. So that was the first transplant which I attempted for a sensitized after coming back to the country in 2018. 2009 I came, but I didn't have any means to do all the advanced tests which I was used to doing in Canada when I was working in the transplant department and the lab. So this was the first I tried with that. And ever since that, I have a sort of registry where I add such patients. And every few weeks, I try making matches, because these are really difficult to match. And all you need is single antigen bead assay, HLA antigens of the donor, recipients, and the blood groups. Now, 3-4 more cases and we'll end. So this is a 16-year-old male, underwent the first living donor transplant in 2018 with his mother as a donor, had antibody-mediated rejection just after COVID because he had stopped his immunosuppression on his own. Virtual was positive with paternal aunt and father, who were then the potential donors, and the cross matches were all positive. The CDC flow and the virtual were all positive to a DR beta 40101, which was 28,000 MFI. And he waited for at least 1.5 years till I could find a suitable donor. And this was a donor from Hyderabad whose wife was not able to get transplanted because she was sensitized with him as a donor. And I could match them with all cross matches negative, no DSAs, blood group compatible. The second patient from Hyderabad, whose husband donated to the first patient, 53-year-old female, she was sensitized through her pregnancies, no blood transfusion or transplants in the past, but she had cross matches positive with all her family donors, and she could not go through transplant. This is Dr. Anuradha Raman's patient who was sent to me specially to get her a suitable donor or to find a way to desensitize. She also took around 6 months for me to get her a proper pair. And it was a third patient's donor who could give to her. So it was a 3-way domino which I did in December 2024, where there were 3 highly sensitized recipients. This was the third patient who was from the domino pair, where she had Kakut, and she was transplanted in 2017 with a lot of congenital anomalies and history of blood transfusion and a transplant in the past, very highly sensitized, and her own donor, her mother could not give her. Here there was a caveat though. The donor, the first patient, Mr. SG's father, was her possible donor. The cross matches were negative, but the virtual kept coming positive. And there was a DSA at A0101 at 16,000. Now I was very foxed as to why the flow cross match kept coming negative despite a 16,000 MFI. So then I did a complement binding study on this, and I found that A0101 was 100, the MFI was 100 or 200. It was not 16,000. So that essentially means that there was misfolding of the proteins on the bead, and it was giving me a false positive. I went ahead with the transplant, and it was a 3-way transplant, 3-way domino which was done, and all of them are doing well with an average creatinine today of 1.5. This is now 18 to 20 months over for this transplant. So the immunosuppression protocol was as basic as everyone. They did not receive retux, they did not receive plasma exchange, and the patient with that complement binding, non-complement binding SAB, I was scared because this was the first case I would have taken across a DSA. I did give her retux 14 days prior, and then I gave her low-dose Graflon. I use Graflon ALG where I find that I can't give ATG given that the risk of infection will go up, because I don't so much believe in Simulect for sensitized patients. So every one of them has received Graflon and they are all doing well. Outcome is excellent, and these are the 3 pairs. They have done well. Similarly, a 2-way pair. Now here if you see, the previous 3 had ABO compatible transplants. Here if you see this, these are the both second transplants, both PRA 98%, both waiting for more than 5 years to get a pair. And when people keep getting added in the sorter registry, I keep matching them. And I found that the pair 1 was matching with this pair. This pair is from Varanasi and this pair is from Mumbai only. The Varanasi patient had already had a transplant with Dr. Vishwanath Billa long back, and at 10 years his transplant had failed. And Dr. Vishwanath had requested me to find an LDP for this patient. So we found a pair, but if you see, they were both becoming ABO incompatible with their donors. And the titers were anti-A was 1 in 1024 and anti-B was their patient 2 was 1 in 2048. Again, here there was a non-complement binding DSA. Although the virtual became negative after the complement binding assay was done, but the physical cross matches were all negative. We went ahead with retux of 200 mg with Plex alternate days. We got the titer down to 1 in 4 only with the plasma exchange. We gave ATG to one patient and Simulect to the other patient. Simulect because he had had BKV in his transplant earlier, and the maintenance immunosuppression was standard. In our protocol, in our institute, our ABO incompatible outcomes as equal to the ABO compatible outcomes. So we can showcase this data to the patients and convince them to go for the ABO incompatible instead of HLA compatible. And out of all the pairs which we have made from sorter, if you see 1, 2, 3, 4, 5, 6, 7 patients have been ABO incompatible and they've all done well. The latest being 2 weeks earlier. We did a 3-way domino 2 weeks earlier where everyone became HLA incompatible, but they all became, everyone became HLA compatible, but they all became ABO incompatible. Their titers were anywhere between 1 in 16 to 1 in 512, and only plasma exchange is what was done. Now, if you look at complement binding antibodies, there are multiple studies now which say that anti-HLA DSA screening with assessment of complement binding may facilitate a risk stratification at individual patient level. So don't do it for everyone. When you find that the patient is very highly sensitized and you have found a probable donor with a flow and a CDC negative, then you try a complement binding. If it turns negative, then you might still be able to go ahead. So you can use this as an additional tool to facilitate transplantation. And we have now done 5 or 6 such patients where there were DSAs on a routine single antigen bead assay, but when you add a complement, those DSAs would become negative. And the flow and the CDC were negative, which clearly told me that these were not pathogenic and I could go ahead. So to summarize, allocation of kidneys to highly sensitized patients remains a challenging risk. Over years, the Eurotransplant Acceptable Mismatch Program has proven to us that it is an efficient way to manage these highly sensitized patients. With fields of histocompatibility advancing and the technologies advancing, we can use it to our advantage to help these patients. Regardless of its success, there is a subset of patients where the desensitization may not work. So not every patient you can attempt to desensitize. And you may not find a direct match which is pristine for a patient. So you might have to go with an hybrid approach where you can use an ABO incompatible transplant in lieu of an HLA compatible transplant, because now ABO incompatible transplant is very manageable and it does not have any future implications. A hybrid approach with accepting a non-complement binding DSA in the acceptable category, except in an ABO mismatched donor, can be possible. And this is an algorithm I will leave you with, where at the time of transplant, we do donor recipient typing, intermediate or high resolution. High resolution is very cheap nowadays, so you can do that. PRA screening and CDC flow crossmatch at the time you start the workup. After that, if the PRA screen is negative, then you keep repeating it 6 monthly till you go for transplant. If it is positive, you flex back to single antigen bead assay. Add a C1q assay if you find it very difficult to transplant a patient. Don't use it irrationally for everyone. And if you have a CDC flow virtual, which is virtual is positive, but the CDC flow is negative, then you use the complement binding and take it ahead for an LDPE. Thank you.
Thank you, ma'am, for such a wonderful talk. I now call upon Dr. Suneet and Dr. Manjunath to do the honors of felicitating Shruti, Dr. Shruti. Dr. Mallikarjun, sir, can we please have you on stage? Thank you. Thank you, sir. Thank you, ma'am. I now welcome Dr. Mahesh Venkalakunti, Senior Consultant Nephropathologist, Manipal Hospitals, Bengaluru, to give us a talk on role of IHC in renal transplantation. Welcome, sir.
Good afternoon, all of you. Thank you, Dr. Manjunath sir, Dr. Mallikarjun sir, and Fortis team for having me here. The topic given for me is the immunohistochemistry in the renal transplantation. So we heard about the immunologies in the morning and very lucid talk by Dr. Shruti. Moving on to the histology, when we get a renal biopsy and what are the implications of immunohistochemistry applications in the renal transplant. So, we as a morphologist, we are trained to look at the architecture, the shape, the cells that are involved in the histology, and try to build up a sense of what is going on in terms of etiology, etiopathogenesis, and arrive at a reasonable diagnosis so that the patient management is taken care of from the biopsy point of view. So the immunohistochemistry, as it is, it's one of the layer which bridges the subjectivity and converts that into an objective results. So this is an ancillary technique in the histopathology that is related to binding of the antibodies to the antigen which is expressed in the tissue or the cell. It depends on whether it is the nuclear expression or the cell membrane expression or a cytoplasmic expression of the components that is detected by applying the serology based antibodies that are developed in the commercial setup. So the principle of immunohistochemistry lies in the fact that the antigens are expressed on the cells, and that is detected by a antibody prepared against to it. So the antibodies that can be either primary, that goes and binds to so the antigen that is expressed on the cell here. No, the mouse is not. So here the antibodies which are directed against the antigen that goes and binds, and then this binding, the bound product is lit up by one of the lighter that is a chromogenic, which gives us a color. The positive and the external control, the negative controls are mandatory so that the quality assurance, the reliability of the analytical process is mandatory in the process. So the chromogens which lights up the bound material of the antigen and the antibody could be of various the components. The commonly used is the diaminobenzidine, which is reflected as a brown color in the immunohistochemistry. So whenever we apply the cocktail of antibodies, that is a mixture of antibodies in a single test, so then we use the different chromogens which are bound to different antibodies, so that in a given one single slide, a brown represents a single antibody, and the red light in the given test applies to a different antibody. So that's the beauty of combining the antibodies in a single test, so to see whether there is an antigen-antibody reaction to it. So the beginning of this immunohistochemistry started with the surgical pathology, where the tumor diagnosis and the site of origin of the tumor, the micrometastasis, the prognostic and the predictive markers were there. When it comes to transplantation, it is about the etiopathogenesis, as I will come to the C4D. The etiopathogenesis is highlighted by the C4D in the acute antibody-mediated rejection. And the second application is that of infectious diseases, especially with respect to the viral infections. So as I said, the AMR, the acute antibody-mediated rejection, is picked up by one of the component in the diagnostic armamentarium is the C4D. That is one. The viral infections, the three common, the relatively common is the BK polyomavirus, and the second and the third would be cytomegalovirus and the adenovirus. So the other applications would be in terms of cell-mediated rejection to see what is the component of CD20 positive cells to base your judgment on attacking the B cell component, how much aggressive you could go upon. Or in case of a recurrent of primary glomerular diseases, especially in a MPGN proliferative GN, if there are hyaline plugs, the application of CD68 IHC also will come in the role. So starting with the acute antibody-mediated rejection, I'll go through with the examples of 4 cases, taking through these antibody-mediated rejection and the viral infections. Beginning with the AMR. So as the antibodies are there, preformed or the newly formed, which attack the endothelium of this, and then the consequence activating the complements, the recruiting the leukotrienes, and then forming the plugs which blocks the microcirculation. This is detected on the histology by the and assessed by 3 components. One is the morphology, that's the microvascular injury, and the second would be that of the immunohistochemistry analysis or the immunofluorescence analysis of C4D, and the third would be that of what Dr. Firoz has already highlighted upon, the DS donor-specific antibodies. So beginning with the morphology, that's straightforward, that of a glomerulitis or a peritubular capillaritis, which is semi-quantitatively graded on a scale of 0 to 3. So 0 being no glomerulitis and 1 is less than 25% of the gloms having this finding of a leukocytes infiltration along with the activation of the capillary endothelium. So that constitutes the definition of a glomerulitis. And then the proportion of this is semi-quantitatively graded. Similarly, in the peritubular capillaries, the same components, and the grading is listed here. Coming to the C4D as the immunohistochemistry marker, this is one of the biomarker which is a kind of a footprint to the earlier component of the activation of the classical pathway or the lectin pathway, which involves the activation of the C4, which further degrades into C4B and the C4D. So this C4B being a labile, which is labile thioester, this gets vanished very quickly, but this C4D is bound covalently to the endothelium. That stays for a longer time despite the antibodies which triggers the mechanism may not be present at all the time. So this C4D binding is highlighted here. The peritubular capillaries, the endothelium of this, you can see the nucleus of this endothelium, and the endothelial surface is clearly showing the brown character. The brown, if you remember, the chromogen we used is the diaminobenzidine. And this binding is giving a positive reaction in terms of it being a linear and the uninterrupted staining of the endothelium. So this constitutes a definition where we call it as positive C4D. And then again, based on which method we use. The earlier photograph was that of immunohistochemistry, and this is immunofluorescence. It's just the modality is different, but the principle remains same. The quality assurance, the one factor that we always have to keep in mind is the tissue. Since this is allograft, so we many a times we get the tissue for a rapid processing, and this is the prerequisite to have the tissue in the formalin solution, the 10% buffered formalin. The tissue should be at least 1 hour, so that this does not impede in the results of or the interpretation of this C4D immunohistochemistry. So anyway, in-house case are the ones which we have to be very careful, but those coming from outside, it would anyway be, especially in Bangalore with the traffic, it it's going to be at least 1 hour. So we don't have to worry for those which come from outside. But in-house, we have to make sure that the tissue is there in the buffered formalin for at least 1 hour. So the semi-quantitative grading of the C4D stain is, it goes like this: the negative reaction as 0, and less than 10% is called as C4D1, that's the minimal positive. C4D2 is the focal, anything between 10 and 50% is C4D2, and more than 50% is categorized as diffuse, that's C4D3. So when it comes to the interpretation or the inference drawn from this IHC or the immunofluorescence, it goes like this. So the C4D2 and 3 is regarded as positive if it is done in the immunofluorescence, but the inclusion of C4D1, even if there are less than 10% of the C4D that is positive by the immunohistochemistry, that is again regarded as a positive. In the immunofluorescence, if there are less than 10%, then the significance goes down in terms of immunosuppression therapy to be decided upon, because the sensitivity of the immunofluorescence method is quite high. So these are some of the pictures. As you can see here, the peritubular capillaries, the lumen is having the leukocytes within the lumen, and then the nuclei of these endothelium are very prominent, and there is a linear staining of these peritubular capillaries, which is all throughout. So in this, it is C4D3+. So it is diffuse all throughout the core. There is brown reaction to all the PTCs that are seen in this tissue. Similarly, in allograft biopsies, which has the transplant glomerulopathy as well as the peritubular capillaries in a chronic allograft nephropathy or the chronic transplant glomerulopathy. So the C4D positive can be seen here. These are some of the illustrations so that this remains in your mind whenever you look up the slide by yourself. So I would recommend, this is 2012 article from KI, the pros and cons of C4D as a biomarker. This is one of the insightful article which draws not just the C4D application in the transplant, but also in the active diseases like proliferative lupus nephritis or pregnancy. The C4D application goes on to even in the native diseases as well. So having seen the positivity in the C4D, what does it mean if there are DSA which is negative in the serum? So the possible explanations could be that of the standard assays that are missing the DSA detection, or is it the sink effect that all the antibodies are absorbed in the kidney and nothing is remain in the serum to be detected. So so the interpretation or the immunosuppression decision would again it goes back to the morphology. If it is a diffuse staining and there are morphologic evidence of microvascular injury, treat it like active, like an antibody-mediated rejection. But in case if the focal positivity is there for the C4D and the histologic evidence of AMR is still there, then you go in a cautious way. But if there is no histologic evidence of microvascular injury, then comes a question whether to treat for AMR or not. These group of patients should be watched upon in having a serial graft function, and so that there is no further deterioration. In case if it is, then treat it like a AMR. This is one of the pros and cons of the C4D. The C4D immunohistochemistry, like all the histopathology labs, can do IHC, so that this evaluation has become more inexpensive, and it is done in almost all the labs. and that's the positive takeaway of the C4D. The recent BAMF classification, the 2024 is unchanged now. So we'll have the 2022 classification running through. So the C4D positivity with both C4D positive and the DSA, it is clear AMR. The C4D positive or DSA, so it is still to be regarded as AMR. But in case both are negative, but only having the microvascular injury, that's still a red flag. But if the diagnostic features are absent and you have one of the two positive, then the probable AMR would be the list in the diagnosis. So this again highlights the C4D positive and the DSA positive is AMR, C4D negative and DSA negative with only microvascular injury. So this is a watchful scenario. C4D is positive, independent of status of the DSA. It is still a AMR. So that is the importance of C4D. Like microvascular injury and the C4D is positive vis-a-vis the DSA being positive or negative, the management would be that of a AMR. So till 2013, the C4D was mandatory to have a diagnosis of AMR, but 2013 was the year where the C4D negative AMR, meaning there could be other antibodies that activate the C4D or which bypasses the C4D activation, but having the microvascular injury. So that new terminology was coined here in this BAMF meeting, and thus it became that the C4D being very specific, but it is not fully sensitive, and thus the C4D negativity does not rule out acute antibody mediated rejection. So this is about the application of the C4D, that it helps in management decisions. It's useful in both the acute and the chronic process of rejection, and it's crucial when it comes to the combined rejections. Moving on to the viral infections, the three dreaded viral infections that are imperative to the level of dosage of the immunosuppression being used. The BK polyoma, the cytomegalovirus, and the adeno. I have put it in the order of prevalence of what we see under the histology, while the CMV prevalence of the CMV infection, the positivity is high on looking at from the serology point of view. This is one of the case of 18-year-old who got transplanted 6 months ago, and the native kidney disease was that of an ANCA mediated disease. As a surveillance, the urine was sent for the decoy cells, and here you see those decoy cells on a highest magnification. These are all very labile urothelial cells which are infected, and here you can see an intact urothelial cell. And being a positive in the decoy cells, if there is a PCR done, and this is how the number of copies and the implications would mean with having the tissue being affected. Tissue in the sense the allograft. This was the biopsy done in this case, as you see that there is an arcuate artery at the middle bifurcating the cortex on the left side and the medulla on the right side. There are some of these cells which are having the nuclear abnormalities, and on the closer view you can see that the margination of the nuclear chromatin is seen along with some of the nucleolus-like prominence and the hyperpyknotic nuclei which is degenerated into the lumen. So when we did the immunohistochemistry, these were positive for the SV40, the T antigen that is diagnostic of a tissue being affected by the BK polyoma virus nephropathy. The viral load on the tissue is semi-quantitatively graded in this way, and along with that, we look for the fibrosis in the interstitium. How bad is it? That drives the prognosis. This is one of the table highlighting the graft loss, looking at the fibrosis, which stage of this disease, A, B, or C. C is the extensive IFTA, whereas you see almost the graft loss is 100% in these cases. So we just looked at 5-year data of these BK polyoma and came out with one of the interesting finding, which has helped us prospectively now, and you can see that the infection of this BK is more so within the first year and the second year, very uncommon in the further third year onwards. This is the one which I was highlighting. The IHC load, the positivity gives us the tissue load, and the trichrome stain gives us an idea about how bad is the interstitium and the tubular atrophy is in a given tissue. So the interesting finding that I was highlighting was that of a C4D in cases of BK polyoma. So there were granular deposits along the tubular basal membrane, and similarly in the immunofluorescence also with the IgG antisera. You can see here that despite having this nuclear positivity, the tubular basal membranes of these affected cells and also in the adjacent ones had these granular deposits with the C4D. So this was surprise finding for us, and we looked up the literature, and there was one of the article which had mentioned that the immune deposits along the tubular basal membranes might be a hint towards doing the SV40 as by default in cases where the nuclear features may not be so obvious. The nuclear abnormality may still be in the early features showing just the nuclear hyperchromasia, but not the typical halo or the margination. So the prevalence in this study was that of 1.7% with a typical slow progressive graft dysfunction. And by this, after this, we started doing, whenever we saw the C4D, which is done default in all the graft biopsies, if the tubular basal membranes had any granular deposits, we started doing the SV40 in all those cases. And prospectively, we picked up in 2 patients without having any nuclear abnormalities, but still positive for the SV40. So moving on to the third case, this was again with a history of previous rejection and the recurrent UTI. The graft biopsy was done, as you can see here, that the interstitium is inflamed, and there is some amount of fibrosis around this glomerulus with an increased urinary space in this Bowman's capsule, Bowman's area. And the trichrome highlights this fibrosis. So, but in the tubular contents, there were evidence of these neutrophilic casts indicating that the pyelonephritis is quite active. And some of these nuclei had the inclusions of the which was enlarging the cell as well as the nucleus. So this is a cytomegalovirus, and this colonic biopsy of this patient had loaded with this cytomegalovirus here, which is highlighted by the CME immunohistochemistry. So see, the immunohistochemistry bridges the subjective variation and brings in the objectivity for the given target evaluation, like viral infections or the C4D. This is the last case, the last 2 slides. This is a recent case, a 52-year-old male who got transplant done with the ATG induction, and there was graft dysfunction, and the histology showed these tubulocentric neutrophilic dominant or the karyorectic dominant inflammation in the interstitium, and also causing rupture of these tubules, spilling over of these inflammation into the tubular lumen, as you can see here. in these two foci. And there were nuclear abnormalities as well in some of these lining epithelium, and we did the adenovirus immunohistochemistry, which turned out to be positive. So these scenarios highlights the importance of immunohistochemistry application in the transplant. So whenever there is a biopsy, that is a gold standard for the evaluation of a graft dysfunction, and this becomes an ancillary technique, and this has been integrated in our BAMF right from 2007 onwards. The role of C4D in the diagnosis of AMR. The C4D and the SV40 has most impactful information in the evaluation of a graft biopsies, and based on this, the immunosuppression management, the dosage is titrated upon, and the graft survival is based upon what the morphology of the IFTA versus the active viral load or the C4D positivity. With that, I end, and I'm open for the questions. Yes, sir. Yes. No, yeah. The non-HLA
also have to get it done.
Yeah, non-HLA minor antigen antibodies can also activate the C4D, and thus we see the positivity. Vis-a-vis, we may not have that microvascular injury in the tissue.
Thank you for the wonderful discussion. Regarding the C4D, we have seen ABMR with the C4D positive and C4D negative. Is there any difference between the outcome of positivity and negativity in the graft?
Yes, there are studies which says that the C4D positive outcomes are slightly better because we know that it is antibody mediated, and we can target that with the immunosuppression protocol. But the C4D negative, there are two schools of thoughts. The C4D negative, we don't know what has caused this microvascular injury. So the etiology remains unknown, but the management would still be in the lines of AMR itself. So this group of patients, how are they going to turn out? Since the etiology is not known, we cannot draw a complete conclusion as to what could be the prognosis. So the two schools of thoughts say that the C4D negative, though we treat it like a AMR, we cannot extrapolate in terms of whether it is because of the AMR therapy that is given or the C4D negative. So, it's still not addressed.
This immunohistochemistry for viruses, that is SV40, BKV, and adeno, together, how much it will add to the cost?
So since the prevalence of this is very low when it comes to CMV and the adeno, that can be done as a morphology based, adding on those things. But see, SV40 can be done in if you think that this is a potential candidate, despite not having the histology for it, as is by default, like similarly as to C4D, that would add another 3,500. So that would not be a major when it comes to the outcome is compared to in a graft.
Okay. The adenovirus, which you showed neutrophil-rich interstitium, then how do you distinguish from graft pyelonephritis?
No, the nuclear abnormalities and the tubulocentric, the pylo, the histology is different, and the adenovirus is always a tubulocentric, and it ruptures the tubular basal membrane also. Whereas in a garden variety of ascending infection of a pylo, it would just be limited to the lumen in the tubules or in the interstitium. The tubular basal membrane disruption is very unlikely in a usual pyelonephritis. and there would be microgranuloma formation in the adenovirus, which is very unheard of in a typical pyelonephritis, and the nuclear abnormalities. So these 3 points would differentiate from a garden variety of pyelo versus adenovirus.
Okay. Thank you.
Thank you, sir, for such an insightful talk. I now call upon Dr. Shakil, IDC physician, Pan Fortis Hospitals, Bengaluru, and Dr. Uma, senior consultant microbiologist, Fortis Hospital, Bannerghatta Road, to do the honors of felicitating Dr. Mahesh. Thank you, sir. Thank you, madam. We shall now go ahead with the panel discussion. The panel discussion will be on management of kidney transplantation rejection. I call upon our panelist, Dr. Sridhara Ji, Professor and Head of the Department, Nephrology, Institute of Nephrology, Bengaluru. Sir, please come on the stage. Dr. Sri Harsha, Consultant Nephrologist and Renal Transplant Physician, Sparsh Hospital, Bengaluru. Sir, can we please have you on stage? Dr. P. Ramachandra, Senior Consultant Nephrologist and Transplant Physician, Sparsh Hospital, Bengaluru. Sir, can we have you please on the stage? Yeah, thank you. Dr. Krishna Kishore, Director, Nephrology and Interventional Nephrology, Kaveri Hospital. Dr. Mallikarjun HM, I request you to be the moderator for this session. Dr. Mallikarjun, sir, Additional Director, Nephrologist, Fortis Hospitals, Bengaluru. Thank you.
Good afternoon, everybody. So we are in between your lunch, so we will try to finish it as early, sir. So I would like to welcome Professor Sridhar, sir, Professor and Head of the Department of our INU, Bengaluru. And I also welcome Dr. Sri Harsha, Senior Consultant and Nephrologist from the Sparsh Group of Hospital. Dr. Ramchandra Bhatt, sir, very senior most nephrologist from the Sparsh Group of Hospital. Dr. Krishna Kishore, the Senior Consultant and Nephrologist from Kaveri Hospital, Bangalore. So without delaying, we'll start the case. So 57-year-old male, known case of type 2 diabetes mellitus, hypertension, and biopsy proven IgA nephropathy, CKD stage 5 on regular hemodialysis. So he underwent kidney transplantation in 2003. Wife was the donor, and 10 years later, he lost the kidney due to chronic allograft nephropathy. In 2012, he was back on hemodialysis, and he was registered for the cadaver transplantation. So once he was registered for the cadaver transplantation, from 2015, nearly 10 years, he had multiple cross-match positive. So CTC used to be positive. He used to go back. Family was frustrated. And later only during the 2022, the SAB all started. So we did a SAB. Even in 2022, the SAB was positive. But he underwent a deceased renal donor transplant. Only one CDC cross match was negative, so immediately we did a transplant. In 2024, CDC was negative. On the same day, the SAB-HLA antibodies, previously he had multiple times SAB-HLA antibodies were more than 5,000, 10,000, 15,000, but these were the values. Class 1 was 21,000, 22, like this. This was persistently high. But still, just because the CDC was negative, we went with the transplant. On the day of transplant, we had sent the SAB assay was sent on the day of transplant, and induction was ATG on POD 0, 1, 2, and 5. Total of 250 milligrams with 4.5 milligrams per kg in divided doses was given. And this is the HLA of the donor. In view of high antibody titers on the day of a transplant, we did the plasmapheresis with IVIG, 2 sessions of plasmapheresis with IVIG, and a dose of rituximab with 500 milligram. And the repeat DSA showed there was a reduction in the MFI values from 16,500 to, in the class 1, there was a reduction in the values from 16,500 to 10,500 and 15,000 to 3,000. But in class 2, there was not much difference. Patient started doing well, diuresing well. The creatinine also started improving. Up to the day POD 8, the creatinine was 1.8, and after that, subsequently, the creatinine started increasing. From 1.2, it went up to 1.6. So the graft biopsy was done, which showed ABMR with borderline ACR and IFTA. So immediately we did a plasmapheresis with IVIG. And at the time we discharged the patient was stable, the creatinine was 1.6. But on outpatient basis, another 4 sessions of plasmapheresis plus IVIG was done on the OPD basis. So patient was doing well. And diuresis, creatinine was well accepted within the acceptable range. It started coming down, his urine output was good. But still, we empirically did a biopsy, though we thought we should know what is happening. That was the early microvascular injury with mild ABMR was there. So hence, he was started with the IL-6 receptor blockers. So a monthly once, that is every month we gave for 3 months, followed by once in 3 to 4 months. And still we are planning to give once in 6 months. That is the plan. But the biopsy was done. The third biopsy showed focal segment. There was no ABMR. And the patient now, the creatinine is 0.9, 1.5, 0.9, and the last creatinine was also 0.7. So this was, nobody will take this risk of doing because the family was also very much insisting, and after explaining the risk, though the MFI values were very high, the day when the CDC was negative, we took him for the transplant. So that was the clue for us, which helped us in, but this IL-6 receptor blockers has also helped us in, sir, with this high because
Sir, excellent case and excellent outcome. Happy seeing the creatinine 0.9, whatever this one you have made.
10 to 15 times
Yes.
this cross
Really.
match was positive.
It's a wonderful job. Whatever the tocilizumab, actually they tell it is used for only chronic active ABMR or chronic ABMR, but you are given early. The only question is, really cause of graft loss, first graft loss, you were told after 10 years IgA nephropathy
It
is
was
ABMR.
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 Biopsy
So it
proven.
is like a now preformed
sir,
DSA.
ABMR was there. Then over 10 years, gradually it was he lost the
Wife
graft.
as a donor, ABMR, the graft loss was due to ABMR, that's what they
That's what biopsy.
It's not a recurrence of IgA.
No, sir.
So then it's like a preformed DSA now.
Yes, he was a highly sensitized.
Yeah.
Yes.
Preformed with highly sensitization. Now the question is, CDC negative, SAV positive, and good graft function. What we looking at other SAV, whether it's really implicate in our transplantation. That is the one question. Second thing is, see, this is a preformed DSA. Now this is for preformed DSA. And you are given plasmapheresis and IVIG post-transplant, right, sir?
Immediately.
Immediately.
Because
not like you are not used like a desensitization.
No. So immediately, because he is having this MI5 high value since long time. So immediately after the transplant, we did the plasmapheresis.
So what made you to give IL to the IL-6 receptors?
Because in spite of that ABMR was there, repeatedly the graft dysfunction was happening. We have given so many times of plasmapheresis, rituximab.
Histopathological, whether it's active ABMR.
It was a mild ABMR, sir. Mild active ABMR.
So this is a new one, I think, and now we have to learn from the tocilizumab.
So the MI5 value of being so high, 10 to 15 years, 10 years he is waiting. Every time he used to get the call, he used to come back. So
I think treating ABMR post-transplant is easier than desensitization program, according to this case. That's what we are also believing, because when you do post-transplant ABMR, no, it's easy to treat. Actually, we give plasmapheresis, IVIG, glucocorticoids, and rituximab. That's what. So according to this one, this case will definitely highlight us to give tocilizumab also. There are other class
yes.
whatever Shruti told. No, there are other IL-6 where you can give subcutaneous also. So wonderful, Professor. I think I don't have any comment. When the creatinine is 0.9, I don't have any comment to this one. Sir, anybody?
Sir, in this case, rituximab was given, sir?
Yeah, it was. We had given. Sir, I think we'll go for the discussion now.
In this, because you did CDC was negative, and you had the donor's blood. So, and the DSA levels, class 1, class 2, both are positive. But did you do the flow? So because the outcome is so good,
yes.
Are these...
because at that time, lysate was done.
Lysate was negative as well.
Yes.
CDC negative and the lysate negative,
yes.
but we don't have a flow cytometry.
No.
And we have DSA class 1, class 2, and we have excellent graft function. Whether should we have done a complement fixing for this just to understand whether these are falsely high?
Yes.
Okay. Anyway, the end was good. Thank you.
Okay, sir. Now...
I have two such cases.
Sir.
One case is a similar case, almost same ditto I can say. CDC negative, but I took the patient and immediately within 24 hours there was a fall in the output. I did the similar kind of thing, but I have not given tocilizumab. But the patient recovered well. He had a normal creatinine till around 2 years after transplant, but she developed some pneumonia and I have to lose the patient. Another patient was another sensitized patient, previous transplant lost because of rejection. There was I also did the desensitization program, that is for a cadaver. Even then, there was CDC was negative, but the single antigen was positive. I did pre-transplant plasmapheresis, 2 sessions, and followed by around 3 to 4 sessions. He is doing well after more than 4 years now, almost normal creatinine. So this can happen, but if you are very aggressive in the initial post-transplant period.
And looking at the finances of the patient, with the minimum finance, we have done all these things. We have to look into it.
IgA, which he had focal.
So another case I have cut down. We'll just go for a short discussion because quickly we'll just have a Dr. Sri Harsha. Could you please enlighten us like the types of the allograft dysfunction?
Sir, allograft dysfunction can be categorized into three categories: acute, chronic, and delayed graft function, what we say. So acute allograft dysfunction there is no consensus, but the crude definition of that is if the creatinine is more than 25% of whatever the baseline was achieved, and if there is proteinuria of more than 1 gram, or if there is decrease in or increase in creatinine after initial improvement or decrease in urine output. So that constitutes the acute chronic acute allograft dysfunction. Chronic is, there is no guideline for that, but it is a kind of a slow progressive graft failure, which will probably might lead to a graft loss. In DGF, we have a specific definition where it is generally accepted that anyone who requires dialysis within first week of transplant is considered as DGF. However, it varies among patient to patient. Some patients may not require dialysis, although their creatinine might be high and urine output may be borderline. And over a period of 10 days to probably 3 weeks, they might improve with a improving outcome and improving creatinine. Those patients fall into category of slow graft function. So this is roughly what is allograft dysfunction.
Okay, thank you. Sir, Sridhar sir, how would you approach allograft dysfunction within a week post-transplant?
See, actually, when everyone know, I think all nephrologists will look at the urine output. When the urine output comes and starts, now we will be very happy. So before that, decreased urine output is one of the marker that acute allograft dysfunction is there. Before that, we have to know the residual urine output of the patient actually. So what are the residual urine output, whether he is passing prior to transplantation. Especially it comes in preemptive transplantation where they have very good output. This knowledge you should know. After that, what we have to assess, during the surgery, there will be blood loss, so much of loss will be there. Volume status assessment is very, very important for immediate post-transplant. So nowadays, previously we used to look at the CVPs. Nowadays, no point of care ultrasound focus is there. So all our even DM students are trained in focus. Immediately we look into the volume status. If the volume is less, give bolus, like 500 ml or something. Then once volume status, give Glasix. Like in deceased donor, we usually give up to 100 milligram. And in case of live, live is very, very important. Live, if there is a decreased output in live, we have to scratch our head. Because that is where you expect brisk urine output in live. But in cadaver, because of the DGF, okay, we can take time. So if the volume status is normal and everything normal, even output will not come, then look at the Foley's catheter. That's the urinary outflow.
That's very important. Sir.
Yeah, that's because there will be some clot and gentle catheter. This one is
especially if this happens in the night, nobody consultants will not be there.
Then
everybody will be jumping around.
That is important. Ultrasound is important because vascular catastrophe will be there. Because nowadays the surgeons are very good. Vascular catastrophe is very less unless patient have hypercoagulous state or lupus. So look at the vascularity. Assess both artery and vein vascularity. If there is a thrombus, yes, it is an emergency. We have to explore immediately. If there is a urinary leak, yes, we have to explore and treat this one. After that, if nothing is there, then I want to do biopsy or because we don't have much financial this one. Biopsy is a better option, but in some center they use DSA level, and deceased donor now cell-free level also come. So they all are there. So you do biopsy. If there is a rejection, according to that you treat. And some glomerular disease can occur early. You should keep that also, like FAGS and oxalate, primary abdominal and TMA, especially TMA. It may be due to the basic disease, or it may be due to tachymus induced also. CNS can have TMA. So you look at all this one aspect and treat according to this one.
Yeah, very nice. Thank you. Dr. Krishna Kishore. So now, after sir speaking about less than a week, how will you approach for allograft dysfunction post-transplant after a week?
Yeah, so I would take some cues from Dr. Sridhara. The first one is because these are people on dialysis and they may not be having urine output, suddenly they're diuresing. So we must be looking for dehydration. That's number one. Second, because they'll be having indwelling stents and they're prone for infection, there are immunosuppression, so infection. 3, they'll be on immunosuppression, especially tacrolimus or any of the CNIs, and the metabolism changes with improving kidney function to assess the levels. And of course, next comes our biggest enemy if there is a rejection. And very rarely, very, very rarely, if you have a native kidney disease, we want to see recurrence. And most common diseases that can recur so early, as we know, FSGS and C3GN. So we see the proteinuria if it is there, and if you know the history of somebody having FSGS, and we have to embark upon plasmapheresis. If it's a C3GN, yes, definitely there is a clinical profile of the patient, young and previous history, or if you have any known complement-mediated disorders, then we may have to think about plasmapheresis or eculizumab there. Probably we might be well prepared if you know the native kidney disease. If you don't know, sometimes there can be some bounces. So we had a patient, young chap, who had ESRD on dialysis. Suddenly he had acute graft dysfunction, and we found that he's having oxalosis. So it was not diagnosed because he was on ESRD for so many years. People forgot to know what it was, and then he lost his graft. Eventually, he underwent liver kidney transplant. So these are some things that we should be careful about. Thank you.
Thank you, sir. Sir, Dr. Ramchandra Bhatt, sir, how do you approach the initial therapy in a patient with histological evidence of acute T-cell mediated rejection?
T-cell mediated.
T-cell.
Well, I think T-cell mediated rejection nowadays, I think it is not so common. With the use of tacrolimus-based immunosuppression and ETG and other depleting.
So with the histological evidence, do you have any?
We have that on the initial.
G1A.
What I would have done is I will start with a small dose of methylprednisolone, 250 to 500 mg, for around 3 days, 3 to 5 days. See the response. And along with that, when you get a biopsy report, we'll see the severity of this, whether there is any transfrontal arteritis or is there any only interstitial and tubular. Based on this lesion, how aggressive one has to go, and what is the stage after a post-transplant period he has developed, whether within 1 year, after many years later. So is there any definitive cause for this T-cell mediated rejection, the withdrawal of immunosuppression or insufficient or this thing? These are the various things why I judge. In case if there are some chronic changes in the allograft, then I think aggressive, too much aggressive with the using depleting antibodies in such patients. And if there is if you assume that prolonged period has passed after the withdrawal of this thing, then I think there is no point in to be too aggressive in treating this. Earlier days, maybe before 2000, we used to use OKT3. That is what for and T-cell mediated rejection was very common during that time. That is cyclosporin era. So we used to see almost 15-20% of cases in 1 year, mainly T-cell mediated rejection. The ABMR was very less common. So we used to use OKT3 to treat these patients. Nowadays, of course, ATG is the rule.
Sir, Sridhar sir, how would now you manage the borderline, subclinical, or mixed rejections? This is
yes, sir. See, I think secular rejection we are seeing because see tacrolimus now as soon as you stop tapering, you stop the methylprednisolone 500 milligram whatever you give for induction, then tacrolimus level will vary. We are getting off-late, and we are doing polymorphism also. See, this is not correlating with the tacrolimus levels. As soon as start Viceron tablet, tacrolimus level go less than 3, 4 like that. We are getting more patient now. That's why we are adding ketoconazole with the diltiazem also to raise the level of tacrolimus. As everybody told now, cellular rejection regarding borderline rejection, whether to treat or not. So that is also very important. See, if you won't treat, if anything happens, you will be in this. That's why borderline also we are treating, as you know, stage 1A onwards. Stage 1A only treated by the glucocorticoids. So after that, you need rabbit ATG or alemtuzumab, but it's not available in our India. So this has to be given first. So you wait for 3 to 5 days. That's what the glucocorticoids 3 to 5 days. If the creatine, your goal is to creatine at least comes to 10% of the whatever the baseline. If it is not coming down, in stage 1A, you have option. You can give rabbit ATG or alemtuzumab. But in stage 2 onwards, stage 1B onwards, then you will look at the infection, this one. Whether if you give more infection, more immunosuppression, patient will have infection episodes, then you have to assess that. And you do biopsy. If you biopsy shows any other lesions other than like ABMR or any other, treat that. If the IFTA is developed more, if the IFTA is more, if is not salvageable, then better to stop the treatment at that time. And allow, see, regarding the patient and kidney, always my tell the resident, patient is important. If your life is important than the kidney, if life is there, you can put one more kidney, allow them to come for dialysis slowly. That's what my this one principle. That's my level of way of treating the patient. If it loss is there, I will not move forwards. I'll allow them. The creatinine will be somewhere 1.5, 1.6, and I'll usually hike up the immunosuppression. Tactile mass level usually I will maintain around 8 to 10, and MMF I'll try to increase if there's no infection, and steroid I'll continue.
Sir, continue with, sir. How will you monitor the treatment and when will you stop the treatment for?
So serum creatinine actually whenever you see every day when the patient is admitted, see some people will not admit the patient, especially in stage 1A. So every day we have to see the creatinine level. After that every week, after that monthly, and then this one. In outpatient patients, every other day you have to monitor the creatinine level. So that's what, if the, see, 1A definitely responds. After that it's very difficult.
Sir, Ramchandra sir, how do you prevent the opportunistic infection while treating the T cell?
Well, we give routine prophylaxis for the pneumocystis and the CMV. Generally, if I use ATG, in such situation, I continue this CMV prophylaxis for 6 months. And in case of all patients, I continue this the pneumocystis for 1 year at least. And even if the patient is diabetic and if there is a chance of UTI, and I continue this indefinitely, the pneumocystis prophylaxis, that is Septran. So even despite of this, I think other viral infection like the polyoma, BK polyomavirus or adenovirus, we don't have any prophylaxis. Even for fungus, we don't have any prophylaxis, and we have to thoroughly monitor them. I find one patient I lost, the graft I lost because of the adenovirus infection. It was really a surprise. He did so well. Creatinine become normal. Even despite of that, it was really a surprise when Mahesh gave me this thing as a diagnosis as a adenovirus. Despite of using all the medication, including cidofovir, I could not save the graft. So there is one of the very challenging thing in this situation.
Okay. Dr. Shriyar, what are the predictors of the outcome of ABMR?
If we come to ABMR, that is antibody-mediated rejection, first of all, I would say the histology is to a large extent it plays a role. So whatever the histology is, if there is also accompanying T cell mediated rejection along with ABMR, that confers a poor outcome. And if there is any chronicity, if there is any evidence of chronicity in the histology, that also confers a poor outcome. And sometimes if there is severity of ABMR, that is, for example, transmural arteritis or fibrinoid necrosis or a TMA for that matter, it also is difficult to treat. With all the available treatment agents, we generally find it difficult to treat despite employing every medication. So this, if the level of injury or if the level of ABMR is limited to G1 or PTC1 according to Banff, sometimes it is a good prognosis. But as it progresses to G2 and G3 and PTC1, PTC3, and if it, God forbid, goes to chronicity or IFTA, that sometimes it is very difficult to treat. And the second aspect is the DSA. To confirm whether it is antibody-mediated rejection, we always do a DSA. So DSA also will give us a clue whether this can be, a poor prognostic marker or a good one. So any MFI of DSA of MFI of more than 6,000, IgG3 subclass of immunoglobulin, or if it is a de novo DSA, that is, if in case a de novo sometimes preformed DSA at a higher level can cause rejection or ABMR. But if it is a low level, it sometimes may not cause ABMR. It will be suppressed with our medications or immunosuppression which we give. However, thinking that probably the patient is doing well, if we reduce the immunosuppression for some or the reason, for metabolic reasons, for financial reasons, whatever it is, and if that time patient develops a de novo DSA, that also confers a bad prognosis for the graft. That means it might not be last long, even with treatment. The third and one of the most important aspects is the clinical aspect, that is graft dysfunction at the time of the diagnosis of ABMR. What was the creatinine? What is the proteinuria? How high or how bad was the creatinine, or how bad was the proteinuria? This also gives us some clue in whether we are dealing with a probable treatable ABMR or a non-treatable one. And the newer methods of molecular markers like endothelial cell transcripts or a DSA selective transcripts, if along with rejection, if it is seen in as a urinary biomarker, that also confers a poor prognostic marker for a graft outcome.
Thank you. Dr. Krishna Kishore, how do you approach to the prevention of ABMR?
Okay, so ABMR, for the prevention, first we should know whether the individual is susceptible. So initially when we take for the transplant, we classify them, risk stratify them, saying that whether they are low risk or moderate risk or high risk, based on the clinical history, including whether they're sensitized, received blood transfusions, multiparity, or a previous transplant. So that gives us an idea that probably they might have the higher risk of ABMR. In people who are naive, who is the low risk, and we may not suspect it. First, what we do is, in the initial stage, we get all the three things. So we get CDC, we get flow, and we get SAB. So if there is a suspicion. If the SAB is negative, we know that we don't have preformed antibodies, which means during the course. So during the transplant course, if they develop an episode of rejection, ABMR, then we know that they're prone for another episode of it, or they would have developed the de novo antibodies. In which case, we do a DSA and see what kind of antibodies they have, class 1, class 2. It is not unusual not to have DSA negative when they have ABMR, because all the antibodies are absorbed by the graft. In which case, it is still there, but DSA is negative. So this is what we have. But can we protocolize them? Can we do the DSAs frequently? So it's a cost issue. But if you want to do that, the reasonable period is once in 6 months, which is practiced elsewhere. So apart from this, what are the other non-invasive markers we have to understand or to assess the risk of ABMR? We have donor-derived cell-free DNA, and there is gene expression profiling, what we call transplant excellence, yes or no. So those two things are there. Protocol biopsies are a thing of the past. Nobody is doing it because it carries the higher risk. So if at all you suspect, you have certain biomarkers in the blood that you can do, or you can do a DSA.
Thank you.
Thank you.
Sir, Dr. Sridhar, sir, how do you manage with de novo DSA after transplant, de novo DSAs?
See, de novo DSA usually causes whatever the ABMR after 1 year, usually post 1 year. See, actually, as sir told, no, you have to manage. The cost is not an issue. After transplantation, we can monitor every 3 months and then every 6 months. Usually, why de novo DSA occurs is, I think one is because of the non-adherence. So that is most common in our this one, non-adherence. Second one is reduction of immunosuppression. Because see, everybody will want to reduce the immunosuppression, keep as low as possible. Then because of the infection, some infections like CME, BKV, where we have to forcibly reduce the immunosuppression. So these are all this one condition where we can have DNA, de novo DSA. So when it comes to this one, I want to do the biopsy actually. So biopsy is because if the DNA is there, I will treat according to the biopsy findings. If it is definitely there is active or chronic active, I do plasmapheresis with IVIG, glucocorticoids, and rituximab. See, in some literature, what they are told is, in case of this de novo DSA causing ABMR, the plasmapheresis is contraindicated. They are telling not contra, it's not useful. It's not useful. So they give only glucocorticoids with IVIG. So rituximab plus or minus they give. See, that's how they usually manage de novo DSA. And before that, we have to tacrolimus and MMF we have to optimize. Actually, tacrolimus dose has to be kept in 8 to 10, and MMF also as tolerant as the patient tolerant as the dose. We have to keep the MMF level.
Do we have time for 2 minutes? Okay, they are. requesting us to. So thank you all the experts panelists for your contribution for the. Thank you everybody. Yeah, Manjunath, please.
This was an excellent case. But considering the case, what you have presented, is having a high SAB and being repeatedly positive, not able to get an organ. Do you rely on only on CDC for such kind of patients, or should we do a DSA along with that, or do a donor HLA and go for a virtual?
Yeah, because at that time when he was registered for deceased in 2000, the HLA for that was not done. After registration, we were not getting that HLA matching was not done at that time. So only after 20s it started.
There was a phase where DSA lysate crossmatch was not being done for cadaver allocation, cadaver kidney allocation, but then it was included, and then now
later only it started. Then we did that.
So now the deceased donor allocation, as we know, in Karnataka is only done on CDC.
Surprising to see CDC negative with such a high sub value.
Probably as Krishna Kushor sir was mentioning, probably it was not a complement binding one. So probably
means non-complement binding. And also during the monitoring, you were telling about donor-derived cell-free DNA. Actually, any injury to the graft can increase the free DNA. Need not be always a allograft nephropathy or a rejection. Even a minor injury, acute kidney injury of different cause can increase this value. How much importance to be given for this cell-free DNA during the monitoring?
Yeah. So personally, I do not have experience, first thing. And the other one is, in the studies that were done in 1,025 patients, the positive predictive value of 61%. And the negative predictive value is 84%. But when you combine these two, so what you're going to see is not one value, you see it sequentially. So you're going to see the trend and see if it is going up. That might give you some information. That is one way. And second is, really, if everything is available, you can combine this with peripheral gene expression profiling. If both of them are positive, then your positive predictive value increases to 85%. So this is what, where it was done, the study shows. So these will never replace biopsy. It is only help you to make a decision whether to biopsy or not.
Yeah, basically the clinical situation we need to understand and do a biopsy.
Yes, you do biopsy.
With other
it will only help you in one way. So there is a patient, you cannot do the biopsy immediately, so you're going to wait. So these might help. But where you can do the biopsy, that's gold standard anyway.
Thank you.
Only you can assess only after 1 to 2 months of transplantation. As sir told, no, before you have one value, then if it is increasing more than 1%. Yes.
And in this case, there were 3 biopsies were done. Any subsequent biopsy during the follow-up to know exactly what is happening?
The last biopsy was good.
Happy to see that the creatinine
He's doing well.
Normal and doing well. It was an excellent. But what has happened to the?
We have to develop this protocol biopsies, and because finance is also an issue for him. So with great
from the academic point,
yes, it is required.
Biopsy and
maybe
very high
probably
MFI
doing further biopsies will more confuse us than
because he is under follow-up in the last follow-up also.
High MFI is 21,000. Repeated 10 to 15 time cross-match positive. They used to come, they allot, they used to go back.
So doing a biopsy might confuse us more than it might give some positivity, and we are not sure what.
Academic point, not talking about the prognosticating or therapeutic. Since he's doing well, we pray God to keep him well and with a really a good graft function.
Yeah. Thank you very much. Thank you. Thank you, sir. Thank you very much.
Thank you for such a wonderful panel discussion. Now I call upon Dr. Veerbhadra Gupta sir and Dr. Geeta, our lab head and consultant pathologist at Nagarbavi, to do the honors of felicitating our guests. Dr. Sridhara CG, sir, please do the honors to Dr. Sridhara CG, Professor and Head, Nephrology. Thank you. Dr. Sriharsha, Consultant Nephrologist and Renal Transplant Physician. Now please do the honors to Dr. P. Ramachandra. Now I call Dr. Geeta and Dr. Veerbhadra Gupta sir to do the honors to Krishna Kishore. Dr. Krishna Kishore. Dr. Geeta and Dr. Veerbhadra Gupta sir, do the honors for Dr. Mallikarjun HM, please. I thank all the speakers for such a insightful talk and wonderful discussion. Our next speaker for the session is Dr. Dhananjaya. Dr. Dhananjaya is the head of the department and director of nephrology, Continental Hospitals, Hyderabad. He is going to speak on challenges in post-transplant care and immunological perspective. Sir, can we please have you on the stage?
Good afternoon, everyone. At the outset, I would like to thank organizing committee and Everlife for giving me this opportunity to be in front of all of you today. I'll be speaking about post-transplant immune monitoring. I won't take much time. I won't stand in the way of your lunch. I know all of us are hungry. So I'll start with a small case. 35-year-old female. She is a microbiologist diagnosed as IgA vasculitis, treated variously with various immunosuppressants like MMF, steroids, and others. She had progressive renal dysfunction and she became end-stage renal disease in 2020. She opted to undergo transplant and we looked at the donors which are available. Father was diabetic, mother was again an obese diabetic, husband had recurrent renal calculi. Her paternal aunt came forward for donation. So this is on the right-hand side. We have the HLA of the donor and the recipient. The mismatches have been highlighted. She underwent a transplant with ATG induction of almost 2 mg per kg, received standard immunosuppression. She had a fairly good graft function in the first 2 years. So this is the first year of transplant, where her baseline creatinine was between 1 to 1.2. She had BKV PCR done in the 3rd month, and in the 10th month there was a small increase in serum creatinine, and that's why we had done a single antigen bead after ruling out the common causes, and single antigen bead was negative. In the 2nd year of transplant, again there was a small increase in creatinine for which SAB was done. It was completely negative. It was very reassuring. In fact, there were no donor-specific antibodies in both class 1 and class 2. We looked at tacrolimus levels. Our tacrolimus levels were always in a good range, within an acceptable range, averaging around 8 nanogram per ml. In the 3rd year of transplant, she had a small increase in the creatinine. We just hydrated her, thought to be because of the severe summer of Hyderabad. So following that, there was, after a month or so, there was increasing serum creatinine, which we noticed. So we did another single antigen bead, and we had a surprising result of a HLA A antigen, which is showing a low level antibody of 2300. So that is when we considered doing biopsy, and biopsy showed chronic active ABMR and T cell mediated rejection. This is what we usually see in our clinical practice day in and day out. There is a there is a patient who is looking ill and healthy. He walks into our clinic with a creatinine of 1.2. His complete urine examination is bland. His tacrolimus levels are acceptable. But after 2 or 3 months, when they do come for follow-up, we see them having rejections. The question is, why not, it is not why these patients are having resection. We should ask ourselves, where did this rejection and when did this rejection begin, and where did we miss the chance to treat these patients completely? Why? Because an opportunity that is lost for treatment usually results in irreversible graft injury. As transplant physicians, we always want our patients to be healthy. We want them to lead a long life with a better and a good grafts. So this is one study where they looked at the late allograft failure. The present era, we have been very much able to identify preformed antibodies. We have very good immunological tests available. That field has advanced and is advancing a lot. Along with that, we also have very potent immunosuppressive medications in our armamentarium. That is why we have been able to decrease the acute rejections significantly. But if we look at the long-term life of these grafts, there has not been much change in the last 4 to 5 decades. So our patients are losing grafts because of late graft failures are happening, and major cause of this late graft failure is antibody-mediated rejection. Around 60% of the grafts are lost for late ABMRs, and the major cause, as Dr. Sridhar was highlighting, is not because of anything, it is because of non-adherence and decreased immunosuppressive medication that these patients are taking. In our nephrology DM days, we have been taught about some baby steps. These baby steps are the absolute basics. We do therapeutic drug monitoring of our patients. This therapeutic drug monitoring is commonly used for CNIs and MTARs. Elite Symphony trial, the landmark trial, has shown that low-dose tacrolimus along with MMF guarantees higher GFR for our patients. So based on that, for the first 3 months, we target a trough level of 8 to 10 of tacrolimus levels, and after 12 months, we target a TAC level of around 4 to 7 nanogram per ml. But unfortunately, the trough levels for mycophenolate are not reflective. For MMF, the recommendation by many guidelines is do not do any therapeutic drug monitoring. Why? Because it has a very poor correlation. But there are many centers who are doing serial drug level monitoring and plotting the area under curve and seeing what happens to these grafts. So these are some of the studies which have been done in similar ways. So what they saw that if we are maintaining a MMF area under curve less than 30, those patients had an increased risk of antibody-mediated rejections. If the levels are between more than 60, that is the patients who had rejections. So there are various trials, APOMER, OPERA, FDCC, who are advising us to keep the MMF levels between 30 to 60. But because it is a tedious thing, we are not routinely using, and I don't even know many of the centers except for CMC Vellore in India who is doing this therapeutic drug monitoring. There is a central paradox with which the transplant physicians will live. We feel that our patients are good as long as the creatinine is good. But that is not the case, because even when the serum creatinine is plateaued, we may have alloimmune activation that may be silently injuring our graft. Serum creatinine is a very late marker. It kicks in very late. And also, it just indicates the function of the kidneys, and it does not tell us what is happening with the immune activation arm. It does not tell us whether antibodies are developing, whether there is any microvascular inflammation, whether there is any complement activation or endothelial injury. None of these things we can make out by looking at the creatinine. So creatinine lags behind the clinical features, and it is very clear, and it rises only after substantial injury. And also it is very non-specific. It is influenced by volume status changes, hemodynamics. If there concurrent use of nephrotoxic medications are there, if there is pyelonephritis, all of these can lead to increase in serum creatinine, making it a very non-specific marker. Biopsy is the gold standard, and we always resort to it. So it is able to distinguish the various types of rejection, like antibody-mediated rejection, TCMR, recurrence of GN, drug toxicity, and it will clearly tell us what to do when we encounter the diagnosis, and it will guide a targeted therapy. But it has its own limitations. It is invasive. It can cause bleeding, hematoma, and rarely there are circumstances where the grafts have been lost because of biopsy. Many of these rejections, as well as glomerular diseases, can start very focally, and this biopsy is prone to a sampling error. The biopsy is read by pathologists, and one pathologist might be better than the other pathologists in reading these biopsies, so there is a lot of inter-observer variability. And also it only provides a snapshot of the event. It does not provide a continuum of the picture, and it is not possible to do it again and again. So what I want to do in this presentation is to put two ideas in your mind. This is the crux of my presentation. I want to impress upon you that every graft or graft dysfunction undergoes what is known as alloimmune time injury. And there are 4 monitoring windows that are available to us where we can, with which we can use these patients and monitor these patients. I'll be describing this one by one. So this is an alloimmune injury timeline. We can envision this, or we can imagine this like a movie. In the scene 1, the immunological risk kicks in. In the scene 2, there is alloimmune activation. In the scene 3, there is antibody production because of this alloimmune activation. And 4 and 5, it leads to molecular injury, and it leads to graft dysfunction. Unfortunately, as nephrologists, we are entering in the stage 6, where there is already functional decline and there is increase in the creatinine, and that is very late. Below I have highlighted some of the markers which we can use for monitoring of these patients. My idea is not to tell that one biomarker is better than the other. My idea is to impress upon you how we can make use of a combination of these, and at various time points with which we can do the transplant surveillance of our transplant patients and improve the graft outcomes. So there is 4 windows. Who is at risk? This risk estimation can be done by these things which I will be describing. And the second window is the immune system attacking the graft. And the third window is the graft really getting injured? And the fourth one is this patient over immunosuppressed or under immunosuppressed? So how do we make out the immunological risk? As I already told you, we have the best machine available now, Luminex, which can even detect very low level of DSS, which are probably not significant. So we have that sensitive investigation available, and we have very good NGS methods now available where we can do high resolution typing of our HLAs. So HLA mismatching can be read, and we also know that our immune system does not recognize the antigens, rather it recognizes the epitope, and that is why it results. So this is already Dr. Firoz showed the same study, the Wiebe et al., where eplet mismatch was shown to be a strongest predictor of allograft rejection. HLA class 2 and HLA DQ has been proposed to be the significant factors which results in de novo DSA formation. How do we say whether it is a de novo DSA or a preformed DSA? If the donor-specific antibodies are appearing within the less than 3 months of transplant time, that is when we call it as preformed DSA. And if they are appearing after a timeline of 3 months of transplant, that is when we call it as de novo DSA. So now coming to the second arm, how do we make out whether this immune system is attacking the kidney? We can make use of donor-specific antibodies by measuring through Luminex. And HLA class 2, as I highlighted, is a significant risk factor. Along with increasing DSA, what we need to understand that we need to characterize this DSA. Only MFI does not mean that this patient is going to get tissue injury or is going to get graft dysfunction. If it is the rising MFI values that are more important, and MFI does not always equate to the antibody strength. Also, class 2 and HLA DQ are more important, and if these DSAs are complement binding, they are thought to be more pathogenic. If the antibodies are IgG3 and G1, they carry more worse prognosis. And if you do a plasmapheresis, and if these antibodies persist despite therapy, and this increases the allograft dysfunction. So what happens to the graft if we detected de novo DSA? There are several prospective studies which have looked at what happens to the graft, and all of them are giving one clear and consistent message. That consistent message is there is up to 40% increase in the antibody-mediated rejection of these patients if these patients develop de novo DSA. So there are various societies which are looking at the clinical utility of DSA, how frequently we should monitor, what to do if this patient has a stable graft dysfunction. Anyway, we know if there is an unstable graft or if there is a graft dysfunction, we need to do biopsy and we need to categorize the type of ABMR and we treat it accordingly with various agents what we have in our hand. But what about detecting of DSA in those patients who are having stable graft function? So if the patient is having stable graft function, the societies say that if we detect them, the pathogenicity and impact of the prognosis is currently assessed only by doing the biopsy. Please do not treat your patient just based upon the appearance of de novo DSA. And also every effort should be made during this pre-transplant monitor to do additional lab tests, which I explained earlier, to see whether they are really pathogenic or not. And in those patients who have high-risk characterization, biopsy should be done early. So important thing to remember is antibody that is being present does not always equal to the graft that is injured. DSA just tells that this patient is at a higher risk and the immune arm is attacking the kidney. So how do we interpret this? DSA with a graft injury, it is nothing but a ABMR. We need to treat, reassess our immunosuppression, increasing immunosuppression, and if the patient is non-adherent, ensure adherence. If the DSA is present, but there is no detectable injury, such patients are at an increased risk, intensify monitor and confirm adherence and this thing. If there is no DSA, somebody is telling it does not exclude injury. It just tells that right now there is what is known as DSA negative microvascular inflammation. Such patients can still go on to have antibody-mediated rejections. So rejection is a spectrum. It includes several things like borderline rejection, TCMR, MVI, and active ABMR. That is why the recent Banff classification recognizes microvascular inflammation as one of the entity. Why? Because it wants to move towards the molecular diagnosis of these kind of rejections. So antibody-mediated rejection involves three, as we have classically taught. It includes microvascular inflammation, C4d deposition, and presence of DSA, and the direction of travel depends upon more probabilistic and molecular diagnosis. So the second agent which we can use to assess the immune injury is donor-derived cell-free DNA. So donor-derived cell-free DNA is like a fingerprint of this injuring kidney. So it leaves a mark when the immunity attacks the kidney, the donor cells will die, and when they die, they release some amount of DNA into the circulation, and these DNAs can be picked by NGS methods and where SNP or single nucleotide polymorphisms can be studied, and a technique which is developed by Allosure. This can make out that what is the percentage of this donor DNA that is present, and depending upon the percentage, we can say which patients are at the risk of developing rejection. If there is an high percentage, such patients are at the higher risk of developing rejection. This is the landmark study, DART study, which looked at almost 300 patients, and it serially did all the biopsies of the patients who had graft dysfunction, and simultaneously in them measured cell-free DNA. You can see here it has a positive predictive value of 60%, but a negative predictive value of 84% and in any rejection. And in those patients who are having antibody-mediated rejection, the sensitivity as negative predictive value, which is specificity, is as close to 96%. So what it tells us that if the cell-free DNA is positive, then that patient has high likelihood of rejection. But if it is negative, that means that this rules out antibody-mediated rejection. So the negative test has more predictable value than the positive test. So this study used 1% cutoff, which when they did the fraction, if it is more than 1%, and this more than 1% predicts ABMR. So Admiral study, which was done subsequently, took it one step ahead or one step further and used this instead of diagnosis of ABMR for the surveillance of patients, thinking that if these patients had an increased fraction of this cell-free DNA, so those patients may be at increased risk of rejection. So they serially studied at 1 month, 2 months, 3 months, every month for 6 months, after that every 3 monthly. And what they saw is if the cfDNA increases more than 0.5%, so such patients had increased risk of rejection. And it also estimated by a lag time of 90 days, if even before this patient develops antibody-mediated rejection, we can predict that this patient is going to develop rejection by as many as 90 days. It has its own strengths and caveats. The strengths are, it is non-invasive, it can be very frequently repeated, it has a very strong predictive value, it can rise before creatinine, and it also can track the molecular phenotype of rejection, which I will be telling in the next slide. But the pitfalls are the thresholds assay specific are not interchangeable. Each company has different levels or different setups because the way which we use this is little complex. And it has a modest positive predictive value and a higher negative predictive value. Another thing what we can see to look at whether this graft is being injured is to make use of molecular biopsy, or what is called as MMDX. Molecular biopsy makes use of genetic microarrays to look at the RNA transcriptomes of the transplanted tissue. And there are some 26 to 57 transcriptomes which have been studied, and if they are expressed in high levels, such patients had high rejection in these patients. And even among these transcriptomes, it is the cell-free DNA which fared much higher when compared to the other transcriptomes. Coming to the last term, to see whether our patients are oversuppressed, overly immunosuppressed, or underly immunosuppressed, because as transplant physicians, we are always trying to achieve this holy grail of transplant tolerance, and we are always walking in the tightrope in between this over immunosuppression and under immunosuppression. So can we make out whether our patients are under immunosuppressed or over immunosuppressed? Therapeutic drug level monitoring is one way, and another way is to look at the viral replication as a net state biomarker. So we look at BKV virus right now. Somebody was discussing. We all know BKV levels are higher in the patient who are overtly immunosuppressed, and it remains quiescent in those patients who are having adequate immunosuppression. So we can monitor these levels by doing PCRs, And if the levels are more than 10,000, we can make a presumptive diagnosis of BKV nephropathy and reduce your immunosuppression. And if the copies are more than 1,000, we follow them serially and see what is happening. Similarly, we can make use of CMEs also. But now we have a new kid on the block, that is Stark tenovirus. Why did we require a new virus? That is because BKV and CME have very low prevalence. If you want to have a screening test, it should have a very high prevalence. The CME and BKV are prevalent only in 20 to 30% of the humans, whereas Stark tenovirus is present in more than 90% of the humans. So it is almost a ubiquitous virus, non-pathogenic, and exactly like how the other virus behaves. If there is a high TTV load, it indicates that the patients are very much immunosuppressed. If the TTV load is low, it indicates that these patients are under immunosuppressed. So can we make out a level of virus which can guide us to the treatment of this? So various studies have tried to look at it. There are only 2 randomized trials which are there, which have been looked into these things. And what they suggest is it is very heterogeneous. It is distributed among the population. The levels are very heterogeneous. It is very difficult to make a uniform recommendation. And best is to follow each patient serially and see what is happening to the levels of these viruses. If the levels of viruses are going up and up, that means the patient is overtly immunosuppressed. And if the virus remains stable, that means they are doing good. In majority of the patients, the log viral load copies of these viruses have been studied. And if it is between 4.5 log to 7.8 log, that indicates these patients have optimum immunosuppression. So there are some functional assays also. These functional assays are not, though some of them have received FDA approval, they have not gained wide popularity. Why? Because it is difficult to make out with these patients and difficult to interpret. These are some of the novel things which I will explain you. One is immunoassay. Immunoassay quantifies intracellular ATP, and repeated assays will detect how is the immune cell function over time. Small trials had shown consistent results, but a meta-analysis says that it has a very poor performance. But it is the only FDA cleared assay which is available. There is other assay which is known as K-sort assay, where 17 gene panel is tested. I won't be going into detail of all those things. What we need to understand is none of these tests are complementary. We need to use them in combination for the best efficient. You can see here I have monitored, below I have written whether the test is invasive, non-invasive, those kind of things. And based upon that and based upon personalizing and tailoring it to our patient, we need to use these tests. So I have provided a rational approach. As clinicians, what we can do a baseline immunologic risk estimation. If the patient is in a high-risk category, better to put them on this multi-axis surveillance of function, immunology, injury, and net state of immunosuppression, which I explained. If there is any trigger, like a rising DSA or a new DSA, or increasing cfDNA levels above a threshold, or appearance of graft function, immediately, without waiting, we need to go for the biopsy and give a targeted therapy and adjust our immunosuppression. So this is one window where I have put it all together. So this algorithm is a way of thinking. It is not a rigid protocol. You need to adopt it to your programs. So the take-home message is creatinine and biopsy are necessary, but it is insufficient. As clinicians, we can think in these 4 windows, which opens up our brain and opens up the scope for our patients to do better. cfDNA is a powerful rule-out, and biopsy remains the decision maker. De novo DSA is just a risk signal. We cannot make a diagnosis based on it, and we always need a tissue readout along with it. So we need to integrate, stratify, and stay honest about these evidences so that we can make precision transplant a reality rather than a theory. So detect the injury while it is reversible and match the tool to question with these 2 lines. I'll be finishing my presentation. So this is, I thank my Professor Dr. H.L. Trivedi and Dr. Manoj Gumbar, who are my teachers and because of whom I am in front of all of you today. No, madam. It is actually not at standardized. Only one lab probably in India is doing it. Now I'm seeing only Lal Path was doing it. Yeah, so it takes around 8 to 10,000 rupees they charge. So we have done it as an experimental basis because the lady is an microbiologist herself and was very inquisitive, was spending a lot of time with us and interrogating us on everything. That is why we have done such a surveillance of our patients. But to be honest, in our clinical practice, in our busy schedule, probably we don't have time to think about all of them, and we need to have a very high volume center to do all these things, and we need to have good transplant coordinators also who can make this a possibility. This is a teamwork at the end of the day. Sir.
The lysate based or Luminix?
Sir, I was
the flow.
As I was one of the panelists and I was asked the question. So I already told that I do not use donor lysate assay at all. Why? Because donor lysate assay, what do? They lyse the donor cells, they purify the HLA antigen of the donor cells, and they coat it on the polystyrene beads or the synthetic beads. And when they do that, theoretically it looks very attractive to us as transplant physicians. It appeals to us. So this I am taking the kidney of this patient. So if I am looking at the HLA antigens of this kidney, and if there are no antibodies, this patient should do well. So that is what we believe, right, sir?
Yes.
Even I was under the same belief, but there are various reports which have shown that HLA-C and HLA-DQ-DP are not picked up well
Not picked up
by
Luminix. And also the cryptic antigens plays a role.
Yes.
And the sensitivity is quite less.
So I never do DSA lysate. I always insist on getting, yeah.
I just wanted to add that the lysate DSA has got advantages and disadvantages. But the thing is, we do DSA lysate regularly at our Apollo. I am from Apollo, Hyderabad. So the thing is, donor lysate, the advantage is there for cadaver transplants because we can store the donor lysate for post-transplant monitoring, because getting the donor sample after the cadaveric transplant is very difficult. So for post-transplant monitoring, we store all the DNA, all the DSA lysate. And for live, as most of the publications say that it doesn't pick up the HLA-C, DQ, and DP antibodies. So what we do is regularly we do PRA screen for all the patients, and we have PRA XP, which is recently introduced, and it covers all the HLA-C, DR, and DQ. So when you add PRA screen along with the DSA lysate cross-match, it is an add-on tool for pre-transplant and post-transplant monitoring as well.
So, yes. Correct, sir. So one important point I want to make, madam. The cost of DSA lysate is around 12 to 15,000, whereas the cost of single antigen bead, class 1, class 2 combined is around 40,000. What are we truly trying to say when we are doing a 10 lakh transplant, 8 lakh transplant? What are we truly trying to save? So rather than that, we can always go for a better test which gives us a complete information rather than roaming in the dark.
Thank you, sir, for such a wonderful talk and giving us an insight on the challenges faced in transplant care. I now call upon Dr. Uma and Dr. Suraksha to do the honors of felicitating Dr. Dhananjaya. Thank you, ma'am. Thank you, sir. Now I invite our next speaker, Dr. Neeraja, molecular biologist, Apollo Hospital, Hyderabad. She'll be speaking on HLA typing in organ transplant. Thank you.
Here down here. Next slide. Next slide, Professor. A very good afternoon, everyone. At the outset, I would like to thank Fortis and Dr. Suneet for giving me an opportunity to present here. Since morning, I think a lot has been discussed about ABMR, the de novo DSA, DSA and all. So I'll take you to another tour of what is HLA, HLA typing, the significance of HLA typing in the organ transplant. Yeah. So HLA, as it was called in 1967 and recognized as a very polymorphic system. So the first organ transplant, as all of you are aware, was done in 1959 by Joseph Murray and his colleagues in Boston, and they successfully transplanted a kidney from fraternal twins, and it worked for 20 years without immunosuppression. So why the organ transplant is difficult? I think since morning, half of the knowledge has already been shared. So organ transplant is difficult because of the HLA antigens located on the cell surface. So HLA, also referred to as the major histocompatibility complex, plays a role in intercellular recognition and discrimination between self and non-self. So what is the immunology of allogenic transplantation? So alloantigens elicit both cell-mediated and humoral immune response. So recognition of the transplanted cells that are self or foreign is determined by these polymorphic genes that are inherited from both parents and are expressed codominantly. So where are these HLA genes present? They are present in the major histocompatibility complex, or the MHC. So they are found in humans. It is named as HLA, found on the short arm of chromosome 6, and its essential role lies in the control of self-recognition. So where are these class 1 HLA genes present? They are present virtually on all nucleated cells, while class 2 are restricted to the specialized cells of the immune system, like B cells or the macrophages. They are highly polygenic and polymorphic, and this is the reason for the transplant rejection. So as you can see, like HLA, when we give a report to the patient, you say HLA A, B, and C as class 1, and class 2 is HLA DR, DQ, and DP. Now in HLA class 2, DR is only a variation on the beta chain, hence we give the report as DRB1. While for DP and DQ, the variation is there in both alpha and beta chain, and hence it is given as HLA DQA, DPA, and DPB and all. So these are the HLA antigens based on the serological specificities. So how is HLA inherited? Now HLA is inherited as a set of 3 HLA groups, A, B, DR, as in case of solid organ transplants, but now it has been evolved to all the 11 loci. So this set is known as haplotype. So there is a basic rule in HLA inheritance. The rule is you have 25% chances of inheriting all of the same HLA, and as one of your siblings, you have 25% chance of not inheriting any of the same HLA. That means there is no haplotype match, and you have 50% chance of sharing one haplotype with your siblings. So what is the role of HLA typing in transplant? The first point is indicating whether it is self or non-self. So HLA molecules are present peptide fragments on all the cell surfaces of the immune system, and they can identify them if a transplanted organ has a foreign HLA or a self HLA. The second role is minimizing the graft rejection. So in solid organ transplants like kidney, liver or heart, matching the crucial HLA typically of HLA AB and DR ensures the recipient body tolerates the new HLA and reduces the chances of rejection. The third role is in detecting the pre-sensitization, as lot have been discussed. Prior exposure to foreign HLA through blood transfusions, previous history of transplants, they can cause recipient to develop the donor-specific antibodies. So HLA typing of the donor, when it is combined with the single antigen bead assay for the recipient, as it is called virtual cross-match, will help in avoiding the donor that the patient has already developed the antibodies against. Then stem cell transplant success. So even for bone marrow and hematopoietic stem cell transplant, near perfect or HLA full match is always critical. So unlike solid organs, donor stem cells actually form the patient's immune system. A mismatch significantly increases the risk of graft versus host disease where the donated cells attack the recipient's body. So what do we do in HLA typing? So in this test, the donor's antigens expressed on the surface of the leukocytes or the genes are matched with that of the recipient. So HLA typing methods are generally characterized at low, intermediate, and high resolution, depending on their power to discriminate between the HLA alleles. Now, the low resolution is in the antigenic level, composing only the first field of HLA nomenclature, like A1 and A2. So this has now become obsolete, and no one is doing by low resolution. In intermediate resolution, a DNA-based HLA typing results to include a subset of allelic sharing, the digits in the first field of these alleles name that exclude some alleles sharing the field. So now the trend is everyone wants to do high resolution HLA typing. So it defined as a set of alleles that specify and encode the same protein sequence within the antigen recognition site. So this level of resolution resolves all ambiguities resulting from the polymorphisms located in the exons 2 and 3 for class 1 loci and within exon 2 for class 2 loci. So as you can see in the Venn diagram of this slide, how does the resolution matter and how do we interpret the result? As you can see, the first one, the low resolution, where you can just see what is the gene, that is HLA-A. When you do a typing by low resolution, then you will know the HLA-A plus the allele, like A2. So as the resolution increases, you go to high resolution, then you know what is, you get till the 4 digit and the ambiguities goes away. So HLA typing resolution, as the higher the resolution, the lesser is the ambiguity. So this is how the nomenclature of HLA looks like. HLA-A followed by a separator. So whenever we do testing by molecular methods, the asterisk, as you can show, is in between the field separator. Only if you do by molecular method, you get that asterisk. And then 2 is the gene followed by the specific protein. Then field 3 is used to show the synonymous DNA substitution within the coding region. And field 4 used to show differences in the non-coding region. So as a nephrologist or the clinicians, you should know how the report of the HLA typing is being interpreted and the methodology which is used to show what method of typing is being used. So earlier the serology was used but was considered to be the gold standard. Now it is being superseded by the molecular techniques. So molecular method is fastly becoming the method of choice by most of the laboratories. So this is by using the pattern of lysis of peripheral blood lymphocytes in the presence of complement and typing. the sera. So this was serological method of typing, which is no longer being used. So coming to the molecular methods, the steps of molecular typing is we extract the genomic DNA. Many a times I get questions from the many of the clinicians or from the labs, madam, what type of sample has to be collected for HLA typing. So the sample need to be collected in the EDTA tube, which contains the anticoagulant. For any molecular assays, the sample has to be collected in the EDTA tube, 3 ml in each. So 2 tubes we ask, because many of the patients, the WBC count will be low. It will be difficult for us to extract the DNA from a patient who has low TLC. So the main steps is extraction of the genomic DNA, amplification of the genes of interest, and detection of the sequence polymorphism that defines the alleles. So how do we classify the resolution and what region of the gene is being covered in the molecular test? As you can see, the class 1, it covers the exon 2, 3, and 4. Class 2, the typing region is only exon 3. So what do we do while we do HLA typing? So first step is we extract the DNA from the EDTA sample. That is followed by the amplification of the gene of interest, like the HLA region. So this earlier, the method which was used for HLA typing was SSP, and this is also not being used by many of the labs now because it is too tedious. It takes a lot of time to do this test. So the most common technology adopted by most of the labs is PCR SSOP method, which we can do it either in Luminex or Mr. Spot from Back Diagnostics. So we isolate the DNA, the generic PCR amplification, denaturation of the products, and then they are again hybridization to the oligonucleotide probes. So this is the Luminex instrument, which has been discussed a lot from the morning. So this is how the instrument looks like. So HLA typing by Luminex, we can do both low to intermediate resolution. As it is a reverse PCR SSOP, it involves PCR amplification of the targeted regions within MHC class 1 and 2, followed by the process of probing the amplicon with Luminex beads, each coated with sequence-specific oligonucleotide probes to identify the presence or absence of the specific alleles. So the advantages of Luminex HLA typing is that the combination of speed and reproducibility form the main advantages of Luminex as used in HLA typing. So this was the first case of de novo DQ antibody-mediated rejection in our Apollo hospital. As lot has been discussed about de novo, so I just added this slide. So this was a 29-year-old male CKD recipient who came for cadaveric transplant to us. He has a history of 3 units of blood transfusion, who presented to us in February 2022. So CDC crossmatch was negative. The Luminex, as I said, the lysate crossmatch, that was also negative. But since he had history of 3 units of blood transfusion, we did both single antigen beat class 1 and class 2. So single antigen beat class 1 was negative, but class 2, it was showing a PRA of only 1% with DQ antibodies O1, O2 and O6, O4 with an MFI of just 1636. Since the MFI was too low and it was a cadaveric transplant, our clinicians went ahead with the transplant, and it was run on 21st February. So patient was on a regular follow-up as per our hospital policy. And then after 3 months, the recipient presented in May 2022 with low urine output, and we had a suspicion of antibody-mediated rejection. So on 19th May, as you can see the timeline, it was from February to May, exactly 3 months. So the patient was presented on May, and then when we suspected ABMR, we repeated single antigen beat class 2. Since we did PRA screen, it was class 1 negative, so we did only single antigen beat class 2 to cut the cost. So as you can see that the same antibodies were there, which were there in pre-transplant, but the MFI had increased from 1600 to 5832. So we did cadaveric since, as I said, we store all the DNA of the cadaveric donor in our lab. As per NABL, we have to store all the DNAs for a period of 5 years for post-transplant monitoring. So we did cadaveric donor HLA typing, and we saw that the virtual cross-match was positive. As you can see in this slide, the one on the right side is the donor's HLA typing, which was showing the same DQA A1O2, O1O2 and DQB O6O4. And this is the single antigen bead of the patient, which was showing the corresponding antibodies. So the virtual cross-match was positive, and this was a full proof to show that the cadaveric donor HLA typing is in a sensitized patients is a very good tool for post-transplant monitoring and pre-transplant also. So this is when we did start virtual cross-match for all cadaveric highly sensitized patients in our center from 2022. So we do virtual cross-match for all cadaveric transplants, whoever is having high history of sensitization. So this is how the HLA antigens or the nomenclature looks like. Now coming to HLA typing by next generation sequencing. So why should we do next generation sequencing? So NGS HLA typing has now become a routine technology in many clinical laboratories, as it has provided a cost-effective and routine solution leading to significant increase in the number of alleles in the database. So as of early 2026, the IPD IMGT HLA database there are 46,000 distinct HLA alleles across various human genes. So as you can see in the graph, that the number of alleles have drastically increased when the resolution or the HLA typing has increased from serology to molecular typing. So next generation sequencing is a new technology and a very powerful method that is able to identify and type alleles very easily up to 4-digit resolution. So what happens exactly in the NGS, as a lot of discussion about high resolution HLA typing was discussed from the morning. So in NGS, it's a massive parallel sequencing technology that offers high throughput, scalability and speed used to discriminate the order of molecules in the gene. So NGS offers to detect novel or rare variants with deep sequencing. And you have 4 digits of resolution by NGS as it resolves the allele ambiguity in the exons, thereby achieving better tissue compatibility in transplant. So these are the steps which we follow in NGS. First is the collection of the sample, followed by long-range PCR, quantification, and then fragmentation, library preparation, and sequencing. So till last 2 months back, we used to do HLA typing by Illumina, and the turnaround time or the workflow itself takes 3 days. That's why I think you all might be knowing that the turnaround time when you send sample for HLA typing is almost 7 to 10 days. So recently we have introduced Oxford Nanopore technology to our lab, and the turnaround time has reduced to just 2 days with very free hands-on. So the data, what we check is checked for multiple quality matrices, and we have identified, I think, around 50 new alleles by introducing next generation sequencing in our lab. So whenever we identify new genes, as you all know that today there may be a new gene, but tomorrow it may be some associated with new types of diseases. So we submit all the new alleles what we identify in our lab to WHO, and it is called IPD IMGT HLA database. So this is how it looks like. When you do the long-range PCR, we identify by gel electrophoresis, confirm it, and then after the sequencing, this is how the result looks like. As you can see, all the results are expressed in 4-digit resolution. So this was our first novel allele what we identified in our lab. This was a 40-year-old male recipient CKD for renal transplant with wife as a donor. He doesn't have any family history of CKD. So we did high-resolution HLA typing by NGS, was done between recipient and donor. So when we did HLA typing, to our surprise, we found the routine B44 allele was not there. It was showing like B44 256. So when we did repeated analysis, the nucleotide sequence of the novel allele B44 256 was found to have 8 nucleotide changes at exon 3 in comparison to the common 44O2O1O1 allele. So this sequence was submitted to WHO. As you can see, in multiple positions, the nucleotides are being replaced by new nucleotides. So this we had published in HLA Immune Response and Genetics. You can see the letter from the WHO confirming that the new allele, what we have submitted is from an Indian patient. And this was first published as a new allele alert. So similarly, we have identified, this was from a liver transplant patient. He had like both multiple kidney and liver combined transplant was done for this patient. And it was from a patient from central India, C12O2O222. This was also submitted to WHO and was published. So why I am stressing that when you do HLA typing by NGS, we can identify many new alleles or the disease-associated alleles. So this was from South India. So following the implementation of the NGS methodology, we have discovered many new HLA alleles with direct implication for donor selection, as well as many novel alleles with intronic differences. So identification of the novel alleles by high-resolution HLA typing leads to less ambiguities and better transplant outcome for patients. So full-length gene sequencing and the ability to curate full sequence data will permit future interrogation of the impact of introns, expanded exons, and other gene regulatory sequences on clinical outcomes in transplantation. So the use of high-resolution HLA typing significantly improves the correct identification of DSA, both prior to and after kidney transplantation. So advantages of NGS is that these technologies can reduce the cost of high-resolution typing to that of commonly used low or medium resolution methods while maintaining equivalent simplicity in methods and application. So now the question is, which HLA typing is best for renal transplant? So currently the standard care for HLA typing to select a donor for transplant is to use low or intermediate resolution method first and then type the eligible candidates using high resolution method to confirm the results and select the best matched donor. So a lot has been discussed about antibody-mediated rejection due to the HLA. But we are the first one to do non-HLA donor-specific antibody, and this case had been published in Transplant Immunology journal. So this was our first case of an 18-year-old boy who underwent transplant with his father as a donor. So all the immunology workup was done regarding the HLA. So CDC, flow, virtual cross-match, single antigen bead, everything was negative. So transplant was done. But on post-op day 5, this boy ended up with low urine output and graft failure. So then we explored this case by using non-HLA antibodies, MIC-A typing. So MIC-A antibody screen was performed. As you can see, he had MIC-A 002. So we had did MIC-A genotyping by GenDx, and to our surprise, we found that this patient has MIC-A donor-specific antibodies by virtual cross-match of non-HLA. So we were the first one to do virtual cross-match for non-HLA antibodies. You can see the patient had donor-specific MIC-A antibody against 002, 01, 03, indicating the virtual cross-match is positive. So as a nephrologist, it is not, mandatory that only HLA antibodies lead to antibody-mediated rejection. Even non-HLA antibodies like anti-endothelial cell antibodies, angiotensin type 1 receptor antibodies, and MIC-A antibodies can also lead to ABMR and draft dysfunction. So we have, as I said, we have introduced Oxford Nanopore technology to our lab recently. So that is nothing but short read versus long read sequencing. So what is the advantage of doing long read sequencing is that, as you can see in this picture, in the short read sequencing, only some part of the gene will be sequenced, and then you will get ambiguities in the fourth digit. And the new alleles also is little bit difficult to find when you are doing short read sequencing. So the advantage of Oxford Nanopore, as you can see in the picture, it is long read sequencing and new alleles. We were able to identify 20 new alleles in this ONT, and the turnaround time has also shortened. And in our lab also, we feel it very convenient to do the testing. So this is how the short read sequencing results look like. Ambiguities in the fourth digit. So phasing is broken in 3, resulting in genotype ambiguity. So in the long read sequencing, this has been solved. So we have a plan to start this allo-seq cell-free DNA by NGS. The donor-derived cell-free DNA, a lot has been discussed right now, so I don't want to go deep into this. So it is a donor-derived cell-free DNA. As you know, it is a non-invasive method of biopsy. It's also called the liquid biopsy, where the amount of the donor's cell-free DNA, when it comes into the circulation of the recipient's serum or the recipient's blood, you know that the rejection is going to happen. So it's a very good marker. And thank you so much for your patience listening.
Thank you, ma'am. That was the last for today. And please, ma'am, please. I would like to call upon Dr. Mohan Keshwamurthy and Dr. Suneet Kaur to do the honors of felicitation, ma'am. Thank you, ma'am. I would like to call upon Dr. Suneet Kaur to do the vote of thanks. Ma'am, please.
With this session, we come to the closure of today's CME on precision in kidney transplantation. I would like to thank each and all of the delegates who have spared time and attended the sessions today. I would like to thank all the speakers and the Fortis Healthcare Agilus team, and all my doctors who have really went out of the way and arranged everything very beautifully. Again, thanking everyone. Have a pleasant evening. Thank you so much.